ଲଗଇନ ହେଲା ନା କେଁ?
One, two. Don't forget to click the video of my introduction video just right and close. I want to know why this part was not repeated here in the introduction. This speech timing keynote speakers 25 each. This should be, repeated here. You can yeah, but they have Yeah, because we'll start from quality interaction. Okay, so it's already 45 or not? Yeah. I think we will start now. Good morning. Welcome again to the ECG conference, the 14th, the second day. A very good morning to everyone present here. Hopefully, some of you were able to see the sessions happen yesterday. I am Dr. Sahar Muhammad. I am an emergency physician. I worked in Sudan, Middle East as an emergency physician as well. I finished my diploma of infectious disease from Royal College of Physicians. And I'm doing my ongoing Master of Education for Warwick University as well. I'm working as an American Heart Association instructor for the basic life support, advanced cardiac life support, and pediatric advanced cardiac life support. Okay. I'm assigned to Maryland Center in Rhode Island and also to Safety First Center in UAE, in Abu Dhabi, and I'm working in Capital Health. I stand before you today as a chairperson of this remarkable 40th International Healthcare Hospital Management, Nursing and Patient Safety Conference, humbled by the privilege of addressing such an exceptional gathering of nursing professionals from around the world. It's an honor to witness the power of collaboration and knowledge sharing that this event represents. The INPUCG 2024 serves as a testament to our shared commitment to the noble profession of nursing. As healthcare professionals, we are entrusted with the care and well-being of individuals and communities. And our roles have never been more vital than in challenging times we find ourselves in today. We will be now beginning the second day of the conference, the second day session. I would like to introduce our first keynote speaker of the day, too, is Ms. Nazar Kamangar from USA. I'm passing her the stage to deliver the keynote speech on dental medical integration. Thank you. Thank you.
Looking for the PowerPoint presentation.
The screen.
Uh-oh. Okay. Yes, thank you.
You're able to find.
Yeah, thank you very much.
Assignment. See. This one. This one thing. See.
Good morning.
Reminder that the speech timing for keynote speakers and speakers will be for 25 minutes. Postal time is 15 minutes. Certification for in-person attendance will be provided on July 25, and online attendance certification will be provided in July 30. Thank you.
Good morning, everyone. Welcome to the second day of conference. Welcome to Dubai, the global hub of innovation for healthcare. It's my pleasure to be here today. My name is Nazar Kamangar, and I have over 2 decades experience in medical device dialysis, medical practice, and oral health. The energy yesterday was incredible. We learned a lot about different aspects of healthcare. overcoming the challenges to improve the speed, efficiency, and outcome of the care. Today, we would like to start the day with the importance of medical and dental integration. How many of you have heard oral health is not part of healthcare, or oral health is too small? Yeah, a lot of us heard that, right? So let's take a look to some statistics, right? We discussed a little bit yesterday about the heart disease and other major disease around the globe, right? It's about over 620 million people who are suffering from heart disease. There are about over 500 million people who are diabetics. There are over 450 million who are suffering from respiratory diseases. And on average, there are about 1 billion people who are diagnosed with mental health disorders, right? So roughly, this is about 2.5 billion. But let's take a look to the number of the people globally who are suffering from gum diseases. It's about 3.5 billion people. It's more than this, right? And what's the reason, do you think? The reason is the cost for the dental is expensive. There's absolutely no insurance company or government around the world that is covering 100% cost of dental. So what people do, they delay the care, right? And by delaying the care, the problem is getting bigger and bigger. For those of you who are physicians or in the healthcare in the room, you know that a poor oral hygiene is going to impact on the heart. It's going to impact on your overall health, right? And this is silent. People can see it. But then the problem is getting bigger and bigger. So this is the previous presentation that I have, and I try to go over the slides quickly for you. In the United States, Texas Health Institute came up with statistics that about 2.2 million people visited ER for dental emergency issues. And that came up to the cost of $2.4 billion for ER burden cost, admissions, etc. And that could have been prevented, to be honest. Or coming up with the technologies that can work as ER and dental emergency integration, that I'm going to go through that. And the issue that globally we all face is the lack of centralized digital record for oral health. So when we go to the doctor, we see the summary of the visits, right? We have the lab results. We have some metrics. You can take a look to see if your cholesterol, for example, or other blood tests are at this point last year and what you have this year. But when we go to the dentist, everything is variable, right? And hopefully everybody is going to cleaning twice a year. But when you go to the dentist or hygienist, all you get is verbal information, right? You don't get anything digital. You can't really compare to see what was the status of your gum health last year compared to this year. Are you brushing properly or not, right? And then the other fact is telemedicine in the United States exists since 1960s. But teledentistry came when COVID happened. Isn't that interesting? It's pretty new. And the reason for that is insurance companies didn't approve the codes for teledentistry. We have a lot of people who don't live in the cities or people who are traveling. And imagine how teledentistry can really change people's lives, right? So, should you really spend hours in the ER for dental emergency? Not really. Look at the people who are going for the dental pain to ER. There are so many other bacteria. There are so many other issues that are going to come for people who are going to stand in ER to be seen, right? So there has to be a better way. And then putting AI to work, right? And I know we're going to have more about AI right after my talk today. I think it's really, really important to really figure out what can be done with AI, right? So the triage questions, for example, if you're going to say somebody hit my mouth, right? This is really straight ER, has nothing to do with dental. But if you're going to say, oh, I have pain in my tooth or it's bleeding, right? So you're going to reroute that to the teledentistry section instead of the ER section. And then about the scheduling, how you're going to prioritize who has to go first, how that is much important. About the x-rays, and we had some discussions about x-rays yesterday, about the errors, etc., right? So how AI can help with predicting if you're going to have cavity, if you're going to have other issues, right? So getting AI to work is great. And then we get to the teledentistry part. So if the issue is really dental related, the virtual dentist is going to see you and then figure out what is the chief concern that you're facing. So if you're going to have some medication, they can order the medication. If you need to see by the specialist, they can refer you to the specialist. And then about the dental blockchain technology, I keep going back to the centralized digital record issue, which, in my opinion, is huge. And this is the fact that globally we are lacking this function. So imagine, for example, you have a patient and the physician and dentist, they need to collaborate, right? They need to know about the oral health situation. You might have a cancer patient, you might have a cardio patient, right? So you need to have that collaboration, and that collaboration right now doesn't exist. And the reason for that is there is no reliable digital record that you can share between the physician and the dentist. The insurance claims, etc., they are all part of this. Now, I would like to speak about BrushLink, but before, I'd like to um, show a video, and let's see, how am I gonna have the video? Sorry, you can, how am I gonna go back to the video part of? So our goal is to fundamentally change the behavior of people and generations to come about their brushing habit and rethinking of the impact of brushing on their overall health. And then with that, then creating a data ecosystem, which I believe like data is missing in the oral health. And if you do have access to that data, you have the access to the metrics and you know how you have to improve. If you don't have any data, you really don't know where you were that you need to improve that. And the benefits for the major groups, because this is a data ecosystem that we're creating, and I keep emphasizing on the cost, right? Because that was the issue that we review in the beginning. Why we do have 3.5 million people who are suffering from gum disease. It's because of the cost. So if you're going to provide affordable solution, that this affordable solution is going to be for the patient, for the employer who's providing the benefit, for the insurance companies, and for the dentist who are going to have access to the cutting edge technology that is affordable, and physicians who can also have the communication with the dentist and have that access is very important. If you are in the dental market, you probably know that acquiring dental offices became something pretty hot in the past decade or so. And we have a lot of baby boomers, dentists who are retiring, and they're planning to sell their dental offices, right? So, how dentists or these dental groups are going to differentiate themselves, in my opinion, that's data, right? If you're going to provide something that others don't have, if you're trying to provide the data, patient engagement, customized solution to the patients that they want to come back to you, right? One of the issues that we have with the dentist is people don't trust dentists, because it's different from physician. And when you go to the doctor, your expectation is he or she is going to help you to improve the health. When you go to the dentist, you think, oh, they're going to find something in my mouth and I have to pay, right? So we're facing the trust issue over there with the dentist. And that's one of the bottlenecks that, in my opinion, people don't go to the dentist or they change dentist, right? So for the dental offices, for the dentist, aggregation of data is very important. And I've seen a lot of people in the hospital environment, in the physicians in the dental offices, and they say, yeah, I have data. Okay, data is really broad. What are we talking about? And how are we going to aggregate this data? How are we going to read this data? How are we going to interpret that data? That's extremely important. And how we can use that data to improve the overall oral health outcome. So with BrushLink, then there is AI dashboard for dentists and hygienists, and they're going to have access to the brushing habit of the patients. Why is that important? Because if you do have patients with gingivitis, for example, and then you want to customize the brushing for upper right section, then you can do so. And then a lot of people use Fitbit. Maybe you do, right? So if you're doing cardio, if you're doing any activities, you eat, your physician really don't have access to what you're doing. But with this AI dashboard, dentists and hygienists do have that access for brushing. The other hot topic these days is women health. And I'm very impressed to see a lot of women at our conference. And a lot of us probably, or me, we are parents, right? We have children and we went through pregnancy. And we know the challenges. We know there are a lot of things to think about as a mom or as a pregnant woman. And how many of you may have heard um, in your pregnancy, don't go to a dentist? Or maybe some people decline. But we have seen that on the statistics, a lot of women think it's not safe. If you're pregnant, don't go to the dentist. And that's resulting on the poor oral hygiene for pregnant women. And this bacteria can basically transfer to the baby. So there are a lot of complications that we see from poor oral hygiene. And then the next thing about the pregnancy, when the baby is born, a lot of people, a lot of women, they go through the depression, right? And then with the depression, when you're in that mental health situation, you don't like to brush, right? And those again impact on the overall health that you have. Then as parents, we didn't have a manual to be a parent, right? We just learned. It was very hard to be a parent, to be honest. And then for the children, it's so boring to brush. They don't like to brush, right? And then there's no way for a parent to know if the child really brushed or not. So this data ecosystem that we created is for everyone. It's for children, it's for parents. And I think as the Kids Corner, one of the probably easy solutions that can be done in the hospital setup, in the clinics, physician offices, dental offices, is to engage the children with gamified solutions, right? And these gamified solutions, they should have proper content, right? You really need to have the content to engage the kids and teach them how they have to take care of their healthcare
Thank you very much for your informative
Thank you.
presentation, actually. And I really was very happy because it is such an important topic. And for me as a physician, I do not find oral health is implemented adequately in the initial assessment of the patient and even not at the level of the inpatient. So, what are your solutions for that? So, do you think that we have to implement oral care in each single patient assessment at the level of the outpatient and inpatient?
Well, I think please, thank you. As I mentioned, there are seamless technology opportunities. Like we work through the um, best solution, in my opinion, right? So when you have issues, for example, with your dental, or when you are going to see the physician or your dentist, they're going to ask you, did you have any update, right? What are the medications you're using? And then everything is paper based right now, right? So, as far as centralized digital record, the technology that we came up with is ICU dentist and ICU patient. And I think this is really important when you have a problem, where exactly you go, right?
Yes.
How do you start contacting someone when you need help?
Yes.
And then with that, then I think the Smart Toothbrush platform, BrushLink, is having aggregated data, right? So that's the first solution, in my opinion, because you're using that twice a day, right? And then if you have a problem, you're going to go to your app, right? And then with that, the BrushLink is integrated with IC Dentist and IC Vision, as for tracking as well, right? So right now we have the capability for the patient to invite dentist, and within 6 months we're going to invite the physician also. So physician can also see the records. But ideally, what we are looking at is to start pilots, hopefully in UAE, in Qatar, elsewhere, and people can help us that with those pilots, then we can prove how this is going to be efficient, it's going to save costs, and it's going to be more easier for people to understand the importance of oral hygiene. You as physician, I think you have a very impressive background, by the way. You have worked in pediatric, in cardio emergency, in all of this. So you can see the pain that we are trying to resolve
Yes,
and
and the
how
interaction as well, because dental hygiene is really related to so many diseases like depression, cardiovascular disease, diabetes, and also if the patient is immunocompromised, that how much you will
Yeah.
suffer.
Yeah. Thank
So
you.
do you mind if I ask my audience if they have questions? Do we have questions? Question? No questions? Okay. Thank you very much for your presentation again. Do you mind if I share your certificate?
Thank you.
Yeah, sure. Thank you very much. Let's have a picture as well. You can come there. Thanks for now. Yeah, thank you very much for your presentation. So now, our next speaker is Dr. Vibha Jain from India, if I spell it correctly. Okay. I'm passing her the stage to deliver the speech on transforming healthcare, the impact of AI.
Morning, everyone. The people are few and the sound is even lesser. Maybe please have a good morning. Good morning, everyone. Morning, ladies. And I think it's a miss for all the people who are not here this morning because we are having a coffee table meeting and we'll be more interactive. And I think we'll be more forthcoming in questions because there are nobody watching us. Not many people are there watching us over there. So a bit about myself. I'm a general practitioner. I practiced for around 10 to 11 years and then I switched over to healthcare IT. I have been into healthcare IT for past 15 years now, working on clinical solutions, technology and clinical solutions, EMRs, EHRs, and now venturing into the AI field with wellness. A brief introduction of myself over there. So this is I don't know if it is a good statement or not a good, not so good statement. According to the World Health Organization, we can have 40 million new health sector jobs by 2030. A good news. But then there's a shortfall of 9.9 million physicians, nurses, and midwives globally over the same period. So we don't know how to actually interpret this particular information. It's a very contradictory kind of statement. So we do have some good health sector jobs coming in, but at the same time, the professionals, the skilled people, there's a shortfall of them which is going in. And we all are feeling the burden of it whenever we are going practicing. I mean, all of us are from the healthcare sector. How many of you felt that you are overburdened with the work in your organizations? You need more people there? Always? And you feel if there could be assistance to you who could take away your daily small work,
Yes.
it could be very helpful to you. Always needs help. Look at this. AI has the potential to revolutionize the healthcare. These are some statistics. So 20% of reduction in physicians' time in administrative tasks it can lead to. It can help in 90% use for early diagnosis and remote patient monitoring. It has 70% potential to lower the cost of finding new drugs. And then during COVID, we saw around 94% increase in AI adoption. You must have gone through various solutions, the rise in teleconsultations, the rise in teledentistry, the rise in radio imaging, teleradiology things. During the COVID era, we saw all those kind of things coming in. And the people are now more accepting those things. Initial resistance which was there for these particular technologies, especially the teleconsultings or the teleradiology. I believe that has lessened down a bit during this particular period. Is that a correct assumption on my part, or is it something which I'm making it up? So, another stats for you. The market size of the artificial intelligence is forecast to increase by US dollars 11.827 billion between this period, 2022 and 2027, with a CAGR of 23.5%. Why is this increase happening? Why this sudden kind of a focus on the artificial intelligence? What it has in itself in the healthcare sector, which is leading everybody to go into this particular area, there must be something over there, right? So if we see the artificial intelligence AI in healthcare sector market, the majority of the AI solutions are in the medical imaging and diagnostic field, followed by drug discovery, virtual assistants, operations management, and then rest of the things are there. As we see, there is a shift happening in the healthcare management approach. We are going from a reactive to a proactive thing. So rather than like treating the diseases, which we have all been doing all through our years, we are now going into a proactive area where we are wanting to like help or understand the disease better before it comes to a alarming situation. That's where the shift is happening right now. These are 2 or 3 things which have happened in the past few years, which actually have led to an increase in the AI powered diagnostic breakthroughs. One is the data analysis. So if you've got the data, and this AI actually has helped us in analyzing those vast troves of data. We have that data, but what to do with that data? It's all disparate. But this AI has helped us in bringing all those data together to identify the patterns and detect anomalies which might have been missed otherwise. We heard in the session yesterday, in one of the radiology session, it's a bias which is happening, or maybe the radiologist was not like feeling well or whatever. That person missed a small kind of an anomaly in the radiology, in the X-ray, which could have been picked up by the AI if that would have been trained better. The early detection. There are advanced algorithms which identify early signs of disease, enabling timely interventions and improve patient outcomes. So that's, I can see some questions in the faces of the people who are listening. If there are any questions, I'm open to the questions during the session itself. So you don't have to wait for the end of the session.
Significance.
So that depends upon model to model. That's something
100% accurate if AI is detecting or just.
So that's the way the AI models are developed actually. So the way AI models are made, they are made on retrospective data. So you bring up a model, you train it, and then you start building machine learning algorithms into it to make it more accurate. So it's a learning process which goes on and on and on till the time the things are becoming 100% accurate. So it's something which is not going to replace the things, but yes, definitely helping you in understanding the basic small things which are not that much impactful, but at least reduces your administrative work over there. For example, in a radiology thing, we understand there are some normal X-rays which may be reported by a junior doctor as well. So if the AI model is made in such a way that it is actually at least able to tell you that this X-ray is a normal X-ray, this is a normal X-ray, the time saving is there. And obviously, right at the beginning, you cannot have anything which is 100% accurate. But as the time goes, there are like chances, and the probability of it getting into 100% accuracy that improves.
So, sorry. One day, the AI told me.
No,
It has
AI is not.
not even here.
So
It is
AI.
like as you mentioned, yeah, now they are robotic surgeries. You don't need to travel along with your surgeon. You can sit at your home and get.
But even then, if you're at home, you need a surgeon to perform the surgery. So you cannot replace the surgeon over there, right? It's just that the extra work or the administrative work of the surgeon that is getting reduced, but you cannot replace the surgeon over there. And that actually helps in filling that shortfall of the skilled professionals which we have. So basically, what you are doing is you are actually training the models to become your virtual assistants which help you do your task so that you can be free for specialized skill tasks for yourself. So these are some of the use cases in which AI can be deployed. Look, AI is not something which is a magic wand which comes in and like solves all of your problems. It's a model which has to be implemented, which has to be taken care in a particular way so that it can help you. Just like some of the trainees joining your department, you train them, right? You train them to do your work or do the work in the department. And once they become 100% trained, then you are like kind of comfortable. I'm comfortable. I trust him. Now he can take over my work and I can like do my work also. And that's the way you have to train your AI models also. So these are the three things: the proactive monitoring, personalized patient engagement, and enhanced care coordination. These are the major problems which you're having in the healthcare professionals and in the sector right now. Then you must have heard about precision medicine and personalized care. These are two buzzwords which are coming in. AI definitely is an emerging approach that takes into account individual variability in genes, environment, and lifestyle to tailor healthcare. As we heard Ms. Nazar talking about oral data, and you were talking about implementing it in the assessments in OPD and IPD. So these two are disparate data sets. What if an individual, I mean, the individual would have an inpatient episode, the individual will have an OPD episode, the individual will have an oral health encounter, he would go to a skin doctor. What if all this data is collated and then when the when the patient approaches you, you actually have all the information available to you? And that's what the AI virtual assistant does to you.
Actually, going back to this one, sometimes I do really need to know to integrate what was happening with that patient. Like, for example, if something was happening in the inpatients, a dental issue that might be connected to an acute problem later. So I would need to know about it. And if it was not documented, I will keep on searching and this will be time consuming.
Right. So that brings me to the basic thing which is always missed is you can have AI models only if you have the data collected and I mean in any form, at least in the paper form, structured data or unstructured data, but at least it is there somewhere. And then it is all collated. The models are built over it, and then you can actually use it in various different formats. Like for example, the genomic profiling. We're talking of the genomic profiling of the patients. I mean, this is very scary sometimes to listen to. But yes, I mean, it's a double-edged sword. You can put it to beneficial users, you can like misuse it also. But why to talk of misuse right now? We can talk of good uses as well. So when you're talking of genomic profiling of the patient, we understand there are certain gene types which make the person more prone to getting certain diseases. What if we understand that basis whatever the profile of the person is there or whatever the levels of biomarkers are there, this person is more to getting this particular type of cancer, for example. We understand that the cancer, if diagnosed in the earlier stages, is curable. Most of those cancers are. So if we understand that the person is more to prone to get that, we might have certain proactive, modifiable things which the person can adopt. Maybe it can delay the process. That's a maybe, but yes, that has a potential to delay the process also. Then precision diagnostics, pharmacogenomics. This is something which is very interesting, wherein you are predicting the individual's response to a certain drug. And that is not only basis his data, that is basis the data which has been collected from all over the world. Because the AI models now have that kind of a capability to actually analyze that kind of a data in say seconds or minutes. Just asking a question to you, like you work in your organization, and if you ask somebody the data, like I need the data of this patient for the past 6 months, how easy it for you to get that data? If you don't have the documents, most of the time you'll get it in an Excel sheet. So n number of rows which are there, you get to analyze all those things you are able to miss when definitely you'll miss out certain things over there. You cannot do that. It's always retrospective. So if the patient even tells you that I'm coming tomorrow, even then you'll not be able to like decipher all of his data and come back to him. You'll just ask certain questions. Okay, I'll go back, I'll check. And most of the time your IT people say, we don't have that data, we cannot give it to you. But what if that AI model on which there is no dependency, but it has collected the data from all over the world, has built that model. It just gives you a signal saying, look, so many people of this particular race, this particular gender, this particular demographic profile are liable to have this kind of disease. Your patient falls at this range. You please try this out. One. Second, I have analyzed this data in the records which is there. This person is allergic to this. Please don't prescribe this medicine to this particular person. This becomes a little bit easy for you to do.
And sometimes, for example, the patient is already diagnosed with some sort of a disease. So if I don't know the background of that, I will keep on doing investigations to look for the diagnosis. So
That's very true.
Yeah.
That's very true. So the point is, the reason of this particular session also is to actually inform all of you and aware of you. These AI things are available and can be utilized in all of these aspects in the healthcare. It's up to you and your organization. Where do you want to like at least use this? And the other thing which I want to emphasize is participation of the people who will be using these AI models. So look, as a vendor, somebody would come to your management saying, look, I have built a very good AI model which will help you in, say, segregating normal and an abnormal radiology X-ray. The management says, okay, fine, I find it very nice. Please start using it. And when it comes on the ground, you are the person who says, I don't like this. It is not accurate. But then if you are the person who actually are involved in making that particular model, one, you'll have a trust on that model because you've done it yourself. The second thing is the clinical validation which gets from the medical fraternity. So the clinical validation of these AI models is very much important because then it creates a trust level. Look, it's a machine, it's a model, it's a data. When we are interacting with humans, the first thing which we are trying to do is creating a sense of trust amongst ourselves. This helps a lot in like tackling with any kind of situation. So these models also need to gain our trust, and that will only come when we participate in. We were talking yesterday about in one of the session of value-based healthcare. We were talking of new drugs, very costly new drugs, which will take like 5 to 20 years of trials to come with the positive results and all those kind of things. With this particular AI, you'll be actually able to reduce the time of those trials. How? Because there have been so many trials going all around. There are certain information, the results of this, the side effects of all those particular molecules, which have already been there lying somewhere in the data. You can actually use all those particular things, and the time of that particular trial actually gets reduced. That's one thing which is happening. The other important and interesting thing is drug repurposing. Drug repurposing is there is already certain molecules which are available in the market, but they can be put to some other use as well. You would have seen certain anti-diabetic drugs which are now being put to use for maybe obesity. So these are the kind of things which will help you in understanding that this particular information is available at tips of your fingers. It's perfectly fine. The AI probably led it to do that. Anyways, the other feature or the other aspect where the AI can be put to very much use is in chronic disease management. As we understand, all those chronic diseases like the diabetes or the hypertension or cancer, they're very, very long-term kind of durations, right? Whatever is happening with the patient, you don't know. Some of the patients, they just don't come up in the follow-up and they are lost. And when they come back to you, don't understand what is happening to them. Are they following their treatment plans or not? Are they adhering to whatever has been given to them or not? So there are devices today, there are remote monitoring today, which can help you actually take care of your patients when the patient is not within your setup, is at home or anywhere in the world. So the remote monitoring, the medication management, the behavioral interventions. You know your patient doesn't like to take medicine in the morning, probably at 8 o'clock. It's very early for him to rise at that time. So you maybe can adjust the timings because you understand what is the time that person is taking the medication. This is the robotic surgery we were talking about. The enhanced precision, the personalized plans, and the robotized aid. These are some of the good kind of interventions which AI is helping in. Streamlining the clinical workforce, the clinical decision support. I would like to talk more about it because we built a tool. All of us are aware of the hospital-acquired infections, and we are like kind of working towards reducing those infections also. So what we did is we built a model. I mean, it's not easy to actually get a HAI reported in the hospital. Even if the people know, they would not like to report it. So what happens is we just built a two-phase algorithm, where in the first phase we just tried some rules so that all the people who are suspicious to have a hospital-acquired infection basis the criteria which have been set as the benchmark, we just collated the information on all those patients. The second part became very easy for the infection control nurse because earlier that infection control nurse used to take a round of the whole facility of the hospital, of a 1,000-bedded hospital, taking time, used to miss out certain things. Now at a certain level, she is now out of those 1,000, only 100 persons are maybe having may have a hospital acquired infection, may not have it, but then it was easy for her to actually do a detailed round of those 100 people and then come back to the clinician saying, sir, out of these 100, these are the 50 patients we need your this thing on, and the results were coming in.
Dr. Bikha?
Yeah.
Actually, we have 5 minutes for the time.
5 minutes?
Yes.
So anybody who would like to know more about it, we can talk after the session. The other thing we can, this AI can help is in care coordination and clinical documentation. Administrative tasks, we all have spoken about it. Patient appointment and scheduling, billing and medical coding, medical records and data management, especially in the inventory management, in the supply chain, and in reduction of claims as well. Predictive analytics for population health, wherein it can help to forecast the spread of infectious disease in a population. You can actually stratify the people who are at higher risk and then optimize your resources accordingly. For treatment optimization, again, basis the patient profiling, the treatment simulations can be done and the outcome can be predicted. This is a upcoming aspect of AI wherein you actually are venturing into mental health care. This is a big subject which is bringing up nowadays, wherein you can do a triaging and early intervention, then go for a personalized therapy, and then with the help of virtual assistants, you can actually help millions of people out there. There are some of the challenges to AI adoption, which are regulatory hurdles, technical limitations, and cultural resistance. I'm not going into the details of it. If anybody would have any question, we can take it after the session. The ethical considerations is about the data privacy, AI model bias, accountability, and inclusivity. The future of AI-driven healthcare is here. So there are expanded diagnostic capabilities, personalized therapies, improved operational efficiencies, and responsible and equitable deployment of AI with a robust governance frameworks and transparency. So too fast or too slow, whatever the pace, AI is here to stay. That's what I want to say. I finished off in 5 minutes, right?
Yes, thank you very much.
Thank
Thank
you.
you very much for watching. Thank you very much for your informative presentations. We really need the AI because it will be able to manage large data, of course. And
But you need the
also,
data.
yeah, to allow multiple task management. And I do believe it will never replace, 100%, yes. Just a few examples I just want to add, because I was involved, diploma in infectious disease. We always have the problem, like, for example, to know about the energy to prescribe medication and to know if the patient is having multi-resistant bacteria. So if I want to prescribe antibiotic, I have to have data, what was happening before, his cultures, his background. So I do believe it's really important to have integrated data. Thank you very much. So 1 or 2 questions, please, because yes.
Thank you for this nice presentation. I have a simple question. As a radiologist, if we have adopted this kind of technology, and for any reason the AI program failed to pick up abnormality or give a wrong diagnosis, so whom will have to blame? The technologists who create and design the program, or the doctors who depend on the program?
I would like to put it in a way, if a patient is diagnosed incorrectly, who would you blame? Forget about the AI.
The AI is interpreting.
Yes. So the AI is a tool which helps the doctor in arriving at a certain diagnosis. It's not replacing the intelligence of the doctor over there. And AI works better when you train it better. So it's like a model which you train. So if you train it to 100% accuracy, yes, it can lead to a nil chances of error. But yes, errors, they cannot be like 100% gone in the medical fraternity because the variability in healthcare is too much. We can reach,
I think, for this example, even if the AI will interpret the X-ray, we have to go back always to the physician to have
yes,
the final decision.
yes.
I give another example. Always and always, when I do ECG for my patient, there is always a wrong interpretation from the machine. I never go and look for it because always all my patients they will have AC elevation and critical situation.
And-
No, it's not. It's always like that.
So,
I never go for the interpretation of the machine.
so I would say, like as she said, she never goes for the interpretation for the machine. But with AI, you definitely can go with the interpretation of the machine. But then you need the intelligence with the doctor to say it is a right diagnosis or a wrong diagnosis. You cannot like say I got this particular tool. It told me it is diagnosis A. That's why I wrote diagnosis A. It's never going to be like that.
Yeah, it depends on his clinical interpretations.
And that's why
That together.
exactly, and that's why we always say the AI is there to help you, but the AI is not there to replace any doctor.
Any other question? Yes.
Thank you so much for the wonderful presentation. I just want to add about the AI. So it's about the volume of the data that you get, right? So you get a lot of false positive right now. It's going to take time, in my opinion, if we want to get to the accuracy. And we have to acknowledge that it's up to the physician, right, how you're going to interpret that data for now, because it's going to take probably a few years until you get to the volume of data that you can collectively make sure that this data is going to, provide you the right information.
Agree completely over there, because what you feed in the data, what you feed in the model is going to give you the output. If you feed in the wrong data, and if you're not training it properly, it's not going to give you the right models.
Actually, we can say you have to decide what data you're looking for.
Right.
Like if you're managing a patient, you have to know just few information to let you know what's going on and manage your patient. And you have to use your critical thinking as well. Okay, this will be the last question for this presentation. Thank you very much.
Thank you.
Share your presentation. Sure, thank you. Thank you. Thank you very much. So our next keynote speaker is Dr. Iman Baudiu from UAE, if I pronounce it correctly. Yeah. I'm passing her the stage to deliver the keynote speech on machine learning methods for prioritizing novel candidate disease-causing variants.
Great. Hello, everyone. It's my pleasure to be among you today. I will be talking more on a specific use case regarding AI in genomics. So thanks again to Dr. Jane for setting the mood for AI and introducing all the critical concepts. I will talk more about one specific use case in genomics where AI has shown success, where we managed to use AI successfully for personalized diagnostics. So a little bit of a background about myself. Let me just get the slides ready. It's here, right? Okay. Okay. Right. So I'm a senior researcher at Biotechnology Research Center, part of the Technology Innovation Institute in Abu Dhabi, which is under the Advanced Technology Research Council of Abu Dhabi governments. We're a semi-government institute focusing on developing R&D solutions for various applications. My background, I'm a computer scientist and a bioinformatician. And so I work on the other side, developing machine learning and AI-based models for solving various problems in the biomedical field. And I'll be talking today specifically about some of the machine learning models that we have developed for prioritizing novel disease-causing variants, in particular in Mendelian diseases. Okay, so in the last decade, we have witnessed a tremendous decrease in the cost of sequencing the human ever since the sequencing the first human genome. It happens in the early 2000s. Now, thanks to the advancements in next generation sequencing technologies and the availability, the massive drop in the cost have enabled us to generate a massive amount of data. So now many centers, many research centers, many hospitals have their own in-house sequencing facilities, and this have created or generated a massive amount of data, right? And so now the challenge or the burden is on the other end. How can we make sense of the data? How can we interpret this massive amount of data and extract useful insights for basically for improving human health, right? So I'll talk a little bit about, as an overview, complementary to what Dr. Jane has said, in terms of some of the challenges of artificial intelligence, in particular in the field of molecular diagnostics. So I'll be focusing more about some of the issues that we have in genomics. So, which of course, some of these also are applicable to other areas as well, in adopting in the feasibility in adopting AI solutions overall. So the first important thing is the data. I would say this is the number one challenge, or enabler or disruptor, if I may say. It really depends on what kind of data we have with us, right? So usually, as data scientists, data is the first thing that we look for. Sometimes even before we decide on the problem, we decide on what kind of data is available, and then we will build our solution based on it. In many cases, data can be very unstructured. So, for example, in the case of electronic health records, and that kind of data poses or has its own set of challenges in actually using them to train useful machine learning models out of this data. The other thing I can think about, so if we have like tabular data, right? Annotations, sometimes we need some sort of an annotation to standardize the different the descriptive and quantitative representations of certain metrics, right? So because for AI, for a machine, we have to feed it data in a standardized way in order to make sense of it, right? And the third thing that I would say it also could be an issue with data is the nature of incompleteness of the data, right? So this is not just in health, but also in biology. And this is an issue that propagates into the models themselves and add to the bias. Because, for example, if you look at networks, let's say about biological networks, protein-protein interaction networks, which are useful in many cases or basically if there is a disruption in a pathway, for example, or let's say there's a gene mutated, which results in a protein not being synthesized, and this could lead to a certain disease, for example, then studying the network, the biological network of protein-protein interaction network, co-expression networks, usually we don't have that complete picture, right? We just have lots of studies that have been accumulated over the years by scientists, and we do have, for example, certain proteins or certain genes that are heavily studied, and we pretty much know a lot about the mechanism of how this protein or how this gene works, but other genes or proteins we really don't know much. This creates a bias that us as a computer science we cannot avoid. So any model that we use this data, it will have that internal bias to it. So the model will be able to learn and give you insights about these proteins or genes that we have good amount of cover or a good coverage of data already. But what about the other proteins and genes, right? It's not gonna give you wouldn't expect it to give you much of an insight out of these because the background knowledge is not there, it's missing. Okay, so data is extremely important. Having a high quality set of data that is comprehensible is the ultimate goal. It's basically the holy grail data that we would need as a data scientist in order to develop effective and generalizable machine learning models. Okay, so prediction, that's one area where machine learning or AI can be deployed. So how can we build models that can predict certain diseases, onset of a disease, progression of diseases, and things like that? And later, how can we make decisions? How can we extract decisions? And here are the stakeholders, are the physicians. How, based on these predictive models, how can the physicians make conclusive decisions based on the outcome of the machine learning models? So I'm again emphasizing what Dr. Jane is saying. So AI is not here to replace physician, but rather facilitate their day-to-day life, saving them time, saving them effort in reaching a diagnosis for the patient. So at the end, it's the final call is the physician's call. And on how to make sense of the outcome or the findings of the model. Okay. Another thing that is also of critical importance that is being discussed a lot in terms of adoption of AI in healthcare in particular is understanding or explaining the semantics or basically or even the finding of the models. So when we look at machine learning models, so it's a series of mathematical computations that are happening that enable the machine to make sense or understand data and make basically predict certain outcomes. Let's say this person would have this disease or not, right? So for someone who is outside of the field, let's say a physician would look at the model as a black box, right? So the black box, there is the model, you feed it the data, it will give you an answer, for example, a yes or no, okay? What's happening in that box is, for most of the parts, for most of the models, is something that is kept hidden, right? However, in many cases, the physician would want to know how did the machine reach that conclusion? The physician, and this is a question that's being asked a lot, how the machine decided that based on these measurements, or these, for example, observed phenotypes on symptoms of the patient, how did the machine or the machine learning model decided that this patient would or have this disease? So this is part of the making models understandable, which is by its own in AI is an active area of research. So there is a lot of researchers worldwide who are working on building other tools for enhancing the interpretation of the models. So basically, it will complement the existing model by saying, well, the machine decided that this patient would have this disease because the first X measurement was more than that, the second X measurement now that, and it would reach that conclusion. So it will give more of a description of why the machine have decided that way, and this, in addition to the finding of the model, would help the physician in many ways in assessing the outcome of the model. Okay. And of course, the another thing that is important is robustness. Sometimes we build machine learning models that are based on a set of data for example, a specific population. Generalizability is an issue and also something that we have to always take into consideration. How would that model work on a different population, right, of patients, or a different circumstances, different disease, right? So robustness and scalability of the model and generalizability of model is also of critical importance, right? So I'll be talking more today about the relationship between genotype to phenotype, since we'll be talking about Mendelian diseases. So the aim of the models that I will be discussing today is how can we understand the link between genotype to phenotype. So in the case of Mendelian diseases, where we do have a direct causal link. So in Mendelian diseases, we know in a nutshell, so we basically are these diseases that arise from a mutation in a single gene. And these are hereditary diseases, okay? So we chose this disease as a first, or this class of diseases because of that direct association or direct causal link. So we know that if this gene is mutated, definitely the patient would have, for the most part, for most diseases, develop or manifest the phenotypes of that disease. Okay? So this is, although this is the simplest mode of genetic diseases, Mendelian diseases, it's still a very challenging class of diseases to work with. So how can we interpret, the question here, or the challenge is how can we interpret relevant genetic variants? So As an input, so we imagine the problem as follows. So as an input, we give the genotype, and by the genotype, we can have whole exome sequencing data of the patient, or the whole genome sequencing data, or a set of variants from a gene panel, could be anything. So we need just all the set of variants that this patient has. In addition, we need a set of phenotypes that are observed in the patient. Okay, and these are the two main inputs that we need for the model. And ultimately, what we want to have is a phenotype-aware prediction model, so a model that has been trained on existing data. And basically, the model would output a prioritized candidate genomic variants. So it will basically rank all the variants that this patient has from the most likely variant causing the disease to the least likely one. Okay? So this by itself is the problem. Why? Because for the case of Mendelian diseases, it usually takes an average between 5 to 7 years for the physician to reach a conclusive diagnostic. That's based on worldwide statistics, because these diseases are so rare in nature that many physicians wouldn't have encountered, or maybe encounter few in their lives. So it's usually a very painful and long journey for patients who have these kinds of diseases to just reach a conclusive diagnosis on a molecular level, just to know, which is obviously the first step into treatment, right? We need to know which gene is broken, which variant in which gene is causing that disease that is shown on the patient, right? So that's what we want to do, and that's what the aim of these models are for. So we want to speed up the process and basically ease up a little bit of the burden on the patient. So, as I mentioned earlier, the data is incomplete, especially when it comes to human data. So in terms of the relationship between genotype to phenotypes, so we do have some data sets that has been collected over studies over many, many years. But what we wanted to do is not to just limit us to, we didn't want to limit ourselves to human data. We also want to look at model organisms. There are lots of studies in genotype that document genotype to phenotype relationships in model organisms, such as zebrafish and mice, since we share quite a number of genes, and many genes basically have the same functions. So what we wanted to say is, like, how can we basically extend our coverage in terms of our background knowledge that we would use for our models by incorporating model organisms as well. This would help us build models that are more comprehensive. So the question here, the challenge for such integration of information from model algorithms, how can we make phenotypes comparable between different species, right? How can we collect and integrate all of these different data sets and put it in a quantifiable representation and use this in training our models? Okay. So, and to answer that question, okay. Let's see, have to go back. Yeah. So we introduced PhenomeNet Variant Predictor, or what we call for short as PVP, which is an AI-based pipeline that scores genomic variant in whole exome or whole genome sequencing data with the aim of prioritizing candidate disease-causing variants in Mendelian diseases. So what kind of assumption that we have to make as a data set? So always when we build machine learning model, there should be an assumption that we use when we design our models. So this is how we decide that this is what we consider, for example, as a true case, or as a positive case, or as a negative case, for example. So this is part of the design process of any machine learning model. So the assumption that we have to make here is, we said, okay, we decide that the variant is causative if it is both deleterious. So if it shows that this genomic variant has evidence that it has some functional consequences, okay? And it affects the gene associated with the disease phenotype. So recall we said that we need the phenotype as an input. So we don't just want to look at variants that have scores that say that these are more likely to be deleterious, but we also want that variant to be in a gene that has an evidence either from a human or model organism that basically if this gene is broken, the phenotypes that this patient has will be observed. Okay, so these are the two sets of kind of filters that we use to select or prioritize the variants that are of relevance. Remember that when we talk about whole exome sequencing data, whole genome sequencing, we're talking about millions of records. So there are like millions. Each patient or each individual have millions of variants in many genes. Even for in the same gene, there will be like hundreds sometimes of variants. So how can we really pick up those that matter? This is the challenge here. Okay. So how did we train the model? I'm not going to go much into the technical details, but feel free to ask me later on. So we took data from ClinVar. So ClinVar is a database that catalogs all these genomic variants and has annotation of each variant in which gene and which disease. Here, diseases are, we have over 3,500 diseases. Mendelian diseases. So these are all annotated with OMIM. OMIM is the database that catalogs the Mendelian diseases in human. And we trained a random forest classifier, basically determining positive set and negative set. So for negatives, we also have to design the negative set either by using benign variants. So we do have this information again from ClinVar, annotated and available for us. And we also added some extra design metrics or design measures for the negative set. And basically, we have incorporated around 60 different features representing categorical and numerical values that are needed in order to enable the machine or the classifier to learn. Okay? So this includes CAD, DAN, GUAVA. These are methods standalone that actually predict the deleteriousness or the functional effects of the genomic variants. And in order to quantify the relevance of the gene to this set of phenotypes observed from human and model organism, we used a tool that's developed by my colleagues, which is PhenoNet, which basically, given a set of phenotypes, it will give you, and each gene, it will give you a score for each gene, such that the highest the score, the more evidence that has been shown in the literature from human or model organism that this gene has a strong relationship to the set of phenotypes. Or breaking this gene would result in these phenotypes. Okay. So we build these models. Okay. Now, how these models will actually can be used in the clinic. Okay. So in a clinic or in a genetic clinic or biogeneticist. So let's say first we have the patient data. What kind of data we need? We need a VCF file, which is basically a processed file that is generated out of the sequencing machine. Okay. And then we have the set of phenotypes. So phenotypes have to be standardized. So it's not going to be free text, but rather represented by human phenotype ontology. Basically, this is an ontology that has standardization. Basically, there's an ID for each and every single symptoms or phenotype. So we need to have it in this standardized way in order for the machine to understand it. We do variant filtering. So we are talking about Mendelian diseases, right? So they are rare. So basically we can filter out all these millions of records by eliminating all the variants that have a minor allele frequency over than 1%. And also if there is an inheritance mode, whether we know the disease is dominant or we suspect a dominant or a recessive mode of inheritance, we can use that as well as a filtering. We annotate each and every variant. So all of this is happening computationally. And then we basically apply our model, right? And the software or the model will print at the end the rest of the variants prioritized, and the geneticist can look at them and say, okay, so what is the top rank? Okay, it's in this gene, this is more likely the one, maybe it's the second one. So at the end, the geneticist is the person who would make who would make a conclusive finding over this, okay? Now, the question is testing, right? Everyone now it's very easy to build models, but the real question is how can you test it, right? How do you know that this actually is performing or the model has learned something useful and can be used? How can we trust that model, right? So what we do is we have to do certain validations. So what we do we had two main experiments. So the first one is using what we call synthetic exome or genomes. So we do have a lot of publicly available data of healthy individuals from the 1000 Genome Project. What we did is we hold out some data or some mutations that we know that they cause the disease. We didn't train the model on them. So the model is blind to those small subsets. This is a standard procedure in building effective machine learning models. Okay, and then we basically introduce this mutation to those healthy individuals on these files, and we call this a synthetic patient because we created that patient, right? And we wanted to, and then what we did is we applied the model and see how well it will be recovered, because we know the ground truth, how well it will be recovered among these million records in a whole exome or a whole genome, right? And that's kind of that's a way of how we truly assess beyond the accuracy, right, in a clinical setup, the usability of such approach. The second set that we had, we were fortunate enough to have access to the UK 10K project for rare diseases. So we had 19 exomes from the rare thyroid data study. These 19 patients have confirmed diagnosis. So we know the ground truth again. So we performed a retrospective study on these exomes of these patients. So we have the phenotypes and we have the data, and we wanted to apply our model and see how well will our model be able to pick up the causative variants or not. So remember also the model here haven't seen those variants before. Okay. So this is just some benchmarking. I'm not going to spend time on it. On the synthetic data on whole exome and whole genomes, and we compared it to the state-of-the-art methods. So you can see here that we outperformed the significantly, outperformed the existing state-of-the-art models significantly. So in 78% of the cases, it was ranked, the introduced mutation was ranked at the top hit. And we also looked at the top 10, because in principle, mostly geneticists will look at like the 10 just to get an idea about a better idea to make an informed decision. We had similar performance when we were looking at whole genome sequencing data, because in whole genomes, of course, you are not just sequencing the coding segment of the DNA, but the entire DNA of the individual.
Dr.
You have
Iman,
weights.
sorry for interruption.
Yes.
Just would like to remind you, you have to stop.
2 minutes. Okay. Okay. I will skip to the last thing. Okay. So the interesting finding was on the thyroid patients, so the 19 exomes. So we evaluated our model and the existing state-of-the-art model, and we have shown that in most of the cases, we were able to actually rank at the top. And just a note here, this study or these 19 exomes, it took the researchers 3 years to actually find the conclusive mutation or variant by traditional approaches. It took us 3 days on our computing cluster just to analyze all those 19. So this was one area that we are very, very happy, and that AI helped significantly. And so these are our publications describing the different models. I wouldn't have time to go through an extension of the models to oligogenetic diseases, but we can discuss this later. So this model has been used in different places in Saudi Arabia and globally in the US and in the UK. So we have tested it on different patient cohorts. As a final remark, so we can say that use of phenotypes facilitate detection of less severely damaging variants in Mendelian diseases, so including symptoms is crucial in enabling a better prediction in this particular problem. Data sharing still is the main enabler for the future use of AI. So again, this is still an issue for us as data scientists. Accessing data or obtaining data is quite often an issue and takes a lot of time. And there is a significant burden on data privacy and high performance computing resources. In order to effectively deploy AI solutions, this requires a lot of computational resources to be available in-house, but hopefully will be there soon. Thank you very much.
Thank you very much for your answer. Because we are running short of time, I give a chance for one question. One question. Anyone wants to ask a question? Okay, was very important topic actually. And really, this is an advanced level to involve artificial intelligence with genotyping testing and prediction. Thank you very much.
Thank you.
So we will give your certificate, please. So now we'll be having coffee break for 15 minutes, please. Enjoy your coffee. We have the coffee for you. This is your coffee. Quality. There you go. Good job. Speaking to that. And I believe come on.
As I'm doing that. Thank you.
Yes, please. In a moment, you stand up. Stand up. Jesus, but she has to. But why doesn't you know? I don't know. So in the English, so you knew. So you get it for the combination. Then, please join on. Follow. Thank you. Thank you. Why is it one of the day? There. And then I realized I have one more. You need to keep it remote on that. I mean, I need to make it. I know. Still, give it out. Oh, we don't have time. It's not a problem. Yes. Please can you use my mobile chat? Yes, please. The ITs. You are the same. To my mobile. Yes, please. I do take my money. Pictures, please. What's up? Nice, huh? You never got to get inside. Yes, yes. If you scan it, then you can send your number. Please. I love it. Traditional dresses. Yes. Okay, mucho sería. Even the president sent me a hello. When I was in your hello, no, thank you. Good. Hey, they're very important for us. Right. I mean, that. My life.
If you put it in, then it will be like the
audio.
sound. Yeah.
Okay.
Yes.
But I don't need it.
Yeah. Then you can zoom.
But how can I play it? Because there's like two buttons that I have.
This.
This is a clicker, right?
Yeah.
This is
Yeah.
forward,
Yeah.
upward. And
Yeah.
how do we play the PD?
Video you need to play here. It's
Okay, so I have to click that over there.
Yeah.
Okay, got you.
you need to press escape.
I need to use this.
Yeah.
Yeah.
If you want to check, then you can.
That's me. That's number 7.
So while presenting, this
Escal, what is the word? All of that. There you go. That's I'm not gonna be the second one, the next one. It's gonna be my
It's not you.
my time is 11:45. It's gonna be you. Yeah,
Okay.
it's your turn. Yeah, I'll give you the podiums.
Oh, yeah. Where can I find the PowerPoint? Okay, you can say two.
Yeah, it's day 2, desktop. Let's see. Yes, which one is yours? Here. Okay. Should be unmuted. We'll start in 2 minutes.
Will we start again in 1 minute?
So it was only before. Okay. It's fine.
Will we start again in 1 minute? I hope you had a good coffee, a good time, good break. Okay, great. Now we'll be starting our session again. Our next speaker is Dr. Nijin Pal from Sweden. I'm passing her the stage to deliver a speech on treatment related to temporomandibular disorder among patients with prevalent type of Ehlers-Danlos syndrome in Sweden.
Good morning. Welcome to my presentation. My name is Negin Pal. I am a dentist and I'm a specialist in orofacial pain and jaw function from Sweden. This is a noble field of dentistry, which is not related to caries or gums. I've also done research since 2010. My research is about epidemiological studies within oral health, specifically in orofacial pain. And I wrote my PhD thesis within temporomandibular disorders. If we consider pain 100% in whole body, 25% is orofacial pain, and 80% of 25% are pain which is related to dental origin, and the rest is non-dental origin pain, and the most common non-dental origin pain is temporomandibular disorders. Unfortunately, my specialty doesn't exist in many parts of the world, but Sweden is a pioneer in this field since 80s. Today, I will present a part of my postdoc project for you. So I started my postdoc project 2022. It's about orofacial pain among EDS. I'm the principal investigator for this project in Sweden and Finland, and we have collaboration with Germany, Austria, and United States. The purpose of this project is to come up with dental guidelines within orofacial pain among EDS as a rare genetic disease. And my postdoc focus on hypermobile EDS and classic EDS. So far, we published 2 articles, which I will present the first one, which is related to Sweden, and the third one is on the second review. Okay, and what is temporomandibular disorders? Temporomandibular disorder describes a number of painful and non-painful disorders, which is in jaw muscles, temporomandibular joints, and the associated structures. It's a common condition in the societies with prevalence between 5 to 12%. In this study, we presented the prevalence of frequent type of TMD, which can be both pain and dysfunction, women in red and men in blue. We can see women have higher prevalence of TMD symptoms compared to men. TMJ sounds is the most common type of TMD symptom is like when the patients like open the mouth, and then it comes jaw and face pain, and the least common is TMJ locking. It means the patient cannot open the mouth or cannot close the mouth. The etiology of TMD is multifactorial, and it's based on biopsychosocial model, comprising biological factors, psychological factors, and social factors. This model is applicable to all types of pain. Biological factors like gender, age, genetic, psychological factors like depression, stress, anxiety, and social factors like social network, education level, and work status, and so on. Among the biological factors, there is hypermobility, which has been proposed as one of the factors which can affect the normal function of temporomandibular joints. It's come up under hypermobility syndrome, which is inherited connective tissue disorders which affect the joints and ligaments. Ehlers-Danlos syndrome, or EDS, is an inherited connective tissue disorders characterized by joint hypermobility, skin hyperextensibility, and tissue fragility. It's a genetic disease. It's a mutation in either collagen encoding genes or in genes encoding collagen modifying enzymes. It means the collagen doesn't have the same strength. The new classification since 2017, it's classified or distinguishes 13 subtypes of Ehlers-Danlos syndrome. And the most common is hypermobile EDS. And the next one is classic EDS, which is my focus. In EDS, the individuals have general joint hypermobility. The people who do not have EDS can have hypermobility maybe in one or two joints, but the people who have EDS, they have general joint hypermobility, which leads to dislocation of the joints. Here we can see in shoulder, dislocation of the shoulder. The other one is in the hip. The other one is in the knee. And the last one is dislocation of temporomandibular joint. And it means the patient is not able to close the mouth, which is really painful. And some individuals experience recurrent dislocation. The other feature characteristic of EDS is skin hyperextensibility and atrophic scarring, which is more common among classic EDS compared to hypermobile EDS. Classic EDS can be diagnosed by genetic tests, but which is not common, at least in Sweden. Some people need to fly to Germany or England to do the test. And hypermobile EDS is just based on clinical examination. And that's puts so much stress on patients. We can assume that temporomandibular disorder should be prevalent among EDS due to the joint laxity. There are some literature which shows the EDS individuals have higher tendency to have problem in the orofacial region, but the prevalence figures has been presented in a mixed EDS group, which is not acceptable because we have 13 different types of EDS. So there is a gap of knowledge when it comes to TMD among EDS. This is our study. I'm an orofacial pain specialist. Dr. Novo is a medical doctor and pain specialist and EDS expert in Sweden. And the last one is Professor Anders Schmemann, who was my former supervisor, wonderful person. So we work together and try to fulfill a part of this gap with this study. The aim of this study was to identify the factors out of this biopsychosocial model among EDS sample. And we also assess the prevalence of TMD, the most bothersome self-reported pain region, the received TMD treatment modalities, and the perceived outcome of those modalities among hypermobile EDS, and classic EDS. The study was performed in accordance with the ethical principle of medical research involving human subjects, according to the World Medical Association Declaration of Helsinki. A digital questionnaire with 63 questions sent to the member of the Swedish National EDS Association, to the individual who have either confirmed or suspected EDS in the healthcare system. I've done the analysis by Stata, is a program like SPSS, and we presented the results in 2 different subsamples. And if it was possible, we use a Fisher exact test to compare the results. We can see the result. Okay. From 950 individuals who received the questionnaire, 279 sent back the questionnaire. And it means roughly 30% response rate, which is quite high nowadays for the questionnaire-based studies. And all the individuals, not all, the majority answer the questions from whole Sweden, which is a really valuable data set. And this is the biggest data set which exists in the world now, until now at least. When we look at the socio-demographic factors, women had participated in this study more than men. And this is because in this association, we have more women than men. And the other reason can be that hypermobility is more common among women compared to men. And the joint complication is more severe among women compared to men. And that's why they're seeking actively treatment. The other finding was education. As you can see, the majority had high education level, which is in Sweden. But the majority, 54%, were not working. And the mean age of this sample was 50 years of age. The retired age in Sweden is 67 years old, and people really work hard. So it should be something that these people with the education, they do not work or they are on sick leave. And this shows they are more dysfunctional compared to other people or general population. When it comes to health-related factors, the majority, 91%, perceived their health poor. 50% had were obese or had overweight. But the majority perceived their oral health as good. And when it comes to patient health questionnaire, which is a construct of anxiety and depression, 71% had sign of anxiety and depression. And there's also an association between autistic spectrum disorder with EDS, but the reason behind that is unclear. In Sweden, there is a study in general population which shows autistic spectrum disorder is between 1% to 2%, but these people have 16%. So they have should be some reason behind that, but it's unclear. When it comes to temporomandibular disorder symptoms, roughly more than 90% in both groups reported jaw locking, impaired jaw opening, headache, feel pain, stiffness, fatigue in the jaw with waking up in the morning. When we look at the pain pattern among these 2 groups, we can see the pattern is quite the same. It's widespread pain. But when it comes to classic EDS, pain is missing in shoulder or wrist. But it shows that the people who have temporomandibular disorder, they have pain in other parts of the body. And this is called comorbidity. A part of my thesis was about the comorbidity between widespread pain and TMD pain. That means TMD pain is not a local pain for these people. I put together different treatment modalities for TMD for these 2 groups. The majority received the common type of treatment, which is in Sweden, bispline therapy, counseling, jaw training, and occlusal adjustment. And the rest of the treatment, like Botox, cortisone, it was not enough to do the comparison. If we look at the subjective effect of all these treatment, we can see bite-spleen therapy, the red bar, shows how much they got effect, positive effect of the treatment. So bite-spleen therapy comes first, then jaw training, then occlusal adjustment, and then counseling come last. But it would be interesting to know why there is a huge difference between the people, the treatment as a bite-spleen counseling, and the effect of counseling. It means just 8% perceived good effect of treatment. In our study, we also asked if they feel, if dental staff had enough knowledge of EDS to be able to provide the individual with good dental care. And surprisingly, 70% mentioned no. So it means a lack of knowledge within this area can affect why counseling, as a very common treatment, as the first step of treatment of TMD, doesn't have enough good effect. The other treatment was jaw training, and Sweden is one of the best, pioneer in this field, and they have a gym which is especially dedicated to this type of disorders. So people, the dentist can this part of the treatment, but still we see roughly, half experience good effect of treatment. And this can be due to kinesiophobia, which means excessive irrational fear of movement or physical activity due to pain. And even in our results, you could see more than 50% were obese or overweight. So it means we cannot just advise the individual and instruct the individual to do some training. We need another intervention. So we can say TMD among EDS is really complicated, and the management needs multidisciplinary approach. We need collaboration between dental and medical sectors in order to help these individuals. Conclusion. In this study, we somehow showed that if the individual have hypermobile EDS or classic EDS, they experience same type of TMD symptoms and roughly same type of pain pattern. And this means as a dentist or orofacial pain specialist, doesn't matter really a patient has hypermobile EDS or classic EDS. We can help them to treat them with the most common conservative treatments. It's better to not to do any surgery for this type of EDS because of the problem with hyperextensibility skin. And education about EDS, and it's compulsory, not in Sweden, I think in the whole world, even in Germany, they still have some struggle to identify the patients with EDS. It takes roughly 8 to 10 years to identify patients with EDS, and you can imagine how much they suffer to get this diagnosis. So, to make the story short, we need new collaboration to do research and to find the better treatment plan for this EDS group. And now I would like to end my speech with one of my painting. It's by watercolor. And yes, and thank you for your time.
Is it your own painting? Yes. Amazing. Thank you very much for your informative presentation. Actually, it's a challenging condition, as you said, because it's difficult to diagnose. And what about the normal variant or the people who have joint hypermobility without having the disease? So you treat the same, like whatever disorder?
This it's called hypermobility spectrum disorders. It's included in my study, but I didn't talk about it today. Because they don't have the systemic manifestation of hypermobile EDS, but we consider them as one group.
So the treatment is the same?
It's quite same, yes.
Okay, thank you. Any questions? Yes.
So, is there any treatment for this disorder for people who doesn't have the disease, like home treatment before surgery, before Botox, before everything? What do you suggest as a dentist?
You mean a treatment for TMD?
Yeah, something like helps reduce the symptoms, reduce the pain. Because when the patient comes to the clinic and we do the clinical search, clinical exam, they say there is pain.
Mm.
So as a hygienist, I want to give them some tips to help them before go to more detailed treatments.
Yes. For actually for this type of patients, because they have tendency for dislocation, it's very important that they do not open their mouth too much. And we can use bit close. I don't know what it's called in English. We have some sort of instrument. You can have it between the teeth. So it gives support to the joint. And if they need to take rest, we have to take them serious. Because if this dislocated, it's very hard to fix it and it can recurrent happen. And this is really put them in a pain.
And
So
do you think using warm pads and cold pads can help? Sometimes we recommended that for the patients.
yes,
What do you think?
we use warm in Sweden, not cold, because there is always risk for a rupture of the ligament. So they can do some training, but which type of training really suit this type of group? It's under investigation. But so they cannot do some stretch training because they always risk for rupture. But the best as a dentist, we know because they know they have problem, but we take them serious and we give them support, especially for the neck and between the teeth, and we do our job maybe a few times instead of one long session. But we cannot cure them because this is a genetic disease.
What about the pediatric group? How we can advise the parents, advise the kids if they have a problem like this, in feeding, they have avoid solid food so as not to have this occasion, or what can we, how we care about the patient, a child with the EDA.
Okay, the diagnosis of EDS when it comes to the children, it cannot be possible before 10 years of age. But and always it's very important to have a proper history from the family. It's a 50% risk if mother or father has EDS. So the kids 50% will have EDS. So we cannot cure the patient because it's a genetic disease, but it's important that the patients, nowadays we do it in Sweden, they receive support for their joints. When they sleep, they have a special mattress. When they have their hand, they have their wrist support. So with these type of helping devices, we can help them. And when it comes to the food, it's biomechanical concepts behind that. So it's better to really prevent a chewy type of food like caramel, which is common in Sweden. So we cannot do many things, but the awareness will help even the patients that, for example, that person cannot is not able to do this type of training, or there's a risk. So this is very important. And another issue when it's come to EDS, it's bullying actually. So that's why they become isolated in the society and they don't feel all right psychologically. So it's very important to diagnose this diagnosis as soon as possible, but it's not possible before 10 years of age, unfortunately. Yes.
Thank you very much. Another question. Another question? Yes. So this is probably going to demonstrate I don't have a clinical background, but when you talk about counseling, what are you referring to? What are some of the things you would be doing with counseling?
Counseling is we give some advice to the patients to not to do some parafunctional habits, or like ergonomy is very important for the people with EDS because of the problem with the back. So we talk and we give this advice, to the patients. And this is the first step because the patients, for example, the majority, even from general population, when they have TMD, they have some parafunctional habits. For example, they bite their lips, bite their cheeks or have other nail biting stuff like that. So we can advise them to stop this type of poor functional habits. And I mean, based on their problem, we can give them even more advice. So we use it like a first step, but they haven't received enough good effect because maybe that wasn't suitable for them as an EDS patient.
So you think that the counseling was more tailored for
Yes.
them in particular would work better?
Yes,
Okay, interesting. Thank you.
you're welcome.
Actually, you talk about the preventive measures. So what about the role of rehabilitations to manage those cases, having a regular checkup with the rehab centers? You think it's important?
Rehabilitation,
Like, you know, doing exercise.
yes, but the problem is before this EDS diagnosis was in the hand of a rheumatologist. But because they have so many problems happen, now the primary healthcare is responsible for diagnosis of EDS. And
So
that
you are not involved with their, you know, preventive exercise.
yes, and that's a problem as well
Yeah.
because lack of knowledge even exists in the medical
And lack of
sector.
collaboration between you and
Yes.
the rheumatologist as well.
So we don't have the rehabilitation program for this type of, individuals, but we are working on it in Sweden.
Yeah, I do believe it's very
Yes.
important.
Yeah.
Thank you very much for your family presentation again. I cannot stop myself from looking for your pictures. It's really details and it's really inspiring. What do you think, guys, about this? What do you think about her picture? Please. Any comment on the picture? It's very important. Yeah, any comment on the picture? Yeah. Say something about it.
Is this from like an actual venue where while you were?
Yes, it's a picture, an old picture. So I've done it with a watercolor. And watercolor is quite very hard to do the painting. I do oil color as well, but this took maybe a week work to do it. Yeah.
Who I just want to know what was the background? What made you decide to paint this?
I'm interested in painting. By the time when I was, I think 6, I started to paint. So, but watercolor I started after oil color. But I think it's just a feeling, I think.
Thank you very much, Lisa, for painting. It's amazing. I wanted to ask, what's the message you wanted to convey through this painting?
I think maybe cold in Sweden. Cold
Yeah.
weather.
Yes, cold in Sweden. Yes.
Yeah, I don't know. I really haven't thought about it, but maybe it's life which is going on. It's just to
Busy life.
yes,
Busy life. So
some
are there going to close that? Winter?
so
Going to close?
yes,
Thank you.
you're welcome.
Certificate? This.
Okay, now it's time for our next speaker. Our next speaker is Dr. Imara Dwan from Qatar. Passing her the stage to deliver the speech on reducing radiation risk and promoting patient safety. Another session about radiation. Okay.
How can I get like the presenter notes?
Sorry?
The presenter notes?
Do you have any difficulty? Can I just like move the presenter notes? Like, how can I look at the presenter notes? How can I see the slides with the presenter notes? Is it possible? It's there. Oh, okay. Yeah. Can I see now? Yeah, I can see. Stop. Okay. Hello everyone. My name is Imran Alwan. I'm a third year medical student from Wild Korean Medicine, Qatar. A little background about me. I have a biochemistry degree, a bachelor degree in biochemistry from the University of Michigan. And then I started med school like 3 years ago. I'll be graduating next year with a degree in medicine. And then after that, I'm planning to specialize in radiology. And today I will be talking about reducing radiation risk and promoting patient safety. So the inspiration of this presentation comes from a project that we're currently working on in Qatar Central Medicine. And our goal is to improve patients' education about radiation risk, but also to debunk all the myths and all of the misknowledge that patients have about radiation and the risks of radiation. And actually, the first clinical rotation I had recently, or like the beginning of my third year medical school, was in pediatrics. And as like the student in the team, in the member, as part of the team, part of my job was always going to the patients. And in pediatrics, you don't have one patient. At that point, you have two patients. You have the child, but also you have the parents. The parents are part of like they are your patient as well. You need to take them in consideration, and you need to consider them when you're discussing the plan for their care. And one of the problems, or not a problem, but one of the things that I've noticed that whenever I go to a patient or like the parent, and the next step is an X-ray or a CT, you can always see that the second you mention the word CT, X-ray, the patient are scared. They have questions, they have concerns. They hear the word CT and they think about cancer and radiation risks. And all of those things are very valid, like they are valid questions, they are valid concerns. And as the healthcare providers, we need to address them and we need to educate them. So we're actually currently working in a project that's we're aiming to improve this. So we'll be discussing that today. So just an overview of medical imaging. It's a cornerstone of modern healthcare with modalities like X-rays, CT scans, and MRIs, and nuclear medicine playing a vital role in diagnostics and treatment. Actually, according to a recent study by Smith and Bindam and his colleagues, there has been a significant global increase in the use of these imaging techniques, particularly CTs and MRI. And this trend underscores the importance of understanding and managing radiation exposure to ensure patient safety. So, as you can see, radiation can be categorized into two groups. The first one is ionizing, like X-rays and gamma rays, and then non-ionizing, like ultrasounds and MRIs. The one that we're most concerned about when it comes to radiation risk are the non-ionizing ones. I'm sorry, the ionizing, the X-rays and the gamma rays. Those have significant health risks like stochastic effects like cancer and genetic effects like tissue damage. And there were studies that showed that there's an increased risk of cancer associated with low dose of CT scans, particularly in younger populations like the pediatric populations. These findings are very important to address and take in consideration because like, they emphasize the need for careful dose management and medical imaging when we are exposing our patients to those kind of ionizing radiations. So a very important principle in radiology and when it comes to radiation and safety is the LR principle, which is as low as reasonably achievable. This principle just focuses on the principal guideline of radiation safety. It ensures that we minimize the clinical need for imaging with the potential risks. A very recent study by Beers and his colleagues underscored that the continued importance of the LR principle, especially that in the pediatric population. And as I said, the pediatric population is very sensitive to radiation, as well as their age and their longer life expectancy. So this principle should be always used to guide us when we justify the use of imaging and try to minimize the dose
that we're exposing those pediatric populations to. So I'm not going to go through this whole list, but as you can see, there are benefits and risks of medical imaging. And I think it's really important that we address and we kind of validate that for the patient that there are risks. We can't just say there are no risks, everything's safe. But at the end of the day, yes, radiation, imaging, it has risks. However, it's very important that, and it's like a principle in medicine all the time. There are risks, that there are benefits, and we need to outweigh the risks against the benefits and see which one is more, like which one outweighs the other, which one has more benefits. And yes, as I said, there are risks for radiation and for medical imaging, but the benefits do outweigh those risks. And we need to communicate that to the patients so that they feel like they are part of the team, they feel like they are making a decision, whether it's the patient themselves or like it's a parent. So one of the risks, or like one of the concerns that patients have, especially in the pediatric population, is the accumulation and damage of radiation on their kids' health if they get exposed to radiation at a young age. And as you can see on this diagram, the amount of radiation from the test is typically very low, and the benefits of receiving those necessary medical tests usually outweighs the small potential risks. So the amount of radiation accumulated from multiple imaging tests is still considered to be within the safe limit, and it's not likely to pose a significant health risk. So medical imaging like X-rays, CTs, and MRIs, they use like low levels of radiation that are considered safe and do not cause permanent damage to the body. Also, it's very important that we communicate with patients that as their health, we take in consideration the risks of radiation before we make a decision of treatment. So it's always important to discuss any concerns about the radiation exposure with the healthcare provider. Okay. So there are multiple protocols that we can use to optimize the strategies and minimize radiation exposure. So those include things like customizing imaging protocols to the patient size, age, and clinical need. There was a study by Rush et al. That highlighted the benefits of implementing pediatric specific protocols. As I mentioned, pediatrics are one of the most sensitive groups for radiation. And the study was showing that when we implement those protocols, there's reduction in the radiation exposure. Also, a regular dose of tracking and audits help ensure that adherence to those protocols, thereby safeguarding patients against unnecessary exposure. So, as I said, children are very particularly vulnerable to the effects of ionizing radiation due to their higher sensitivity and life expectancy. So, there are multiple comprehensive reviews that show that the importance of adapting pediatric-specific protocols and, when possible, choosing non-ionizing alternatives, like I mentioned, MRIs or ultrasounds. Those are very important so that we don't expose children to non-necessary radiation when there are other alternatives like the ultrasound or the MRIs. So there's always that kind of thinking process where if I can find whatever I'm looking for through an ultrasound or MRI, maybe I should do that first. And if I can, then I can process to a CT or an X-ray.
So, but just one question, what about the cost effective? Going for MRI and ultrasound is more costly.
100% yes, MRIs are more costly. Sometimes even like in Sidra recently, the MRI machine, sometimes they're not working, even in other hospitals. So cost is also taken in consideration. And yes, ultrasounds are even, they are faster, they are more accessible to the clinics and doctors. So yes. So did I answer your question? Okay. So we discussed that there are protocols that we can take to minimize the radiation dose and exposure to radiation. But if it's to the point that a patient getting a CT or an X-ray when they are getting exposed to radiation, then there are kind of some protocols that we can take that minimize the exposure. One of them is patient positioning and shielding, which is not just important for the patient, it's also important for the technician or the radiologist that administering this test. So also radiologists and technicians have a role in making sure that patient safety is met. So they are central to implementing those effective radiation safety measures. And there are studies that show the importance of continuous education and regular protocol reviews, which are crucial for staying updated with best practices and advancement. And also, it's important to keep doing routine quality control, including equipment checks, maintenance, to ensure the consistent delivery of safe and high quality imaging services. So as I mentioned, it's really important to keep a quality control and equipment maintenance to make sure all those protocols are met and the patient safety protocols are kept in place. So there are guidelines, and I think every hospital has their own different guidelines. Sometimes hospitals adapt to either UK or US guidelines. I know that in Qatar, etc., for example, they adapt more to the UK's guidelines. But it's very important to adhere to those established guidelines and regulations because it's very critical in ensuring that radiation safety. So there are international bodies like ICRB and WHO that provide comprehensive recommendations with while national standards such as those from the FDA or European Commission can offer additional frameworks. There are also publications by Valentine that highlighted the importance of these guidelines and the need for hospital-specific protocols to tailor those practices to local contexts, ensuring consistent and safe imaging protocols. So another important piece is we can have all the protocols, we can have all the guidelines, but it's also important that the patient feels like they are part of the team, like they are taking initiative in their healthcare. So it's extremely important that we communicate with our patients what's happening next, why are we doing those tests, why is it necessary, why we can't replace them with other tests. So if, for example, if we're doing an X-ray or a CT, it's very important that we communicate with the patients. Why can't we use instead like an MRI or ultrasound? If MRI is more expensive or if it's not accessible, the patient needs to know that. And even though we're still getting the same tests, I believe that it's important that the patient feels safe in the clinic or the hospital and feels like they understand what's happening and why it's happening. So it's also important to use like simple language, visual aids, and address all the patient concerns and questions. So when it comes to patient safety and comfort, it's also important that simple measures like explaining to the patients in very simple language that they understand and not using what they call like medical jargon, which is using words that the patients will know. It's very easy sometimes to use those words because like we use them all the time, but we also need to always be alert that the patients don't always have access to those kind of words, and we need to use similar words that they kind of understand more. So there are like two case studies that I found that were like kind of interesting. One of them, they found that the pediatric tools optimization program resulted in 20% reduction in radiation doses, which demonstrated the effectiveness of tailored protocols that I mentioned recently. Also, there was another study that explored the use of artificial intelligence for dose prediction, achieving around like 30% reduction in doses by adjusting the protocols in real time. So those are examples that highlight the importance and potential for technology and protocol improvement to enhance patient safety and minimizing the radiation dose exposure. So we were talking about AI at the beginning, and 100% I can see that AI will have a huge role in radiology moving forward. I know that a lot of people are scared of AI in radiology. I think it's gonna make radiology just more advanced. It may be like faster, maybe easier. I'm actually very excited to see how AI takes radiology and how it advances it. I never had fear about radiology and AI or like not having a job. I've never seen this. So innovations in radiology safety are rapidly advancing with AI playing a crucial role. A study in 2020 actually highlighted that there's an AI potential for revolutionize radiation safety by offering real-time tools optimization and error detection. Additionally, new imaging technologies like photon counting, CT, and special imaging provide lower radiation doses with enhanced diagnostics
capabilities, representing significant steps toward forward in patient safety. So as everything in medicine is an interdisciplinary collaboration. It's not just the doctor, it's not just the nurse, it's every team member working together. So a multidisciplinary approach is essential in radiation safety. So collaboration among radiologists, technologists, medical physicians, and referring physicians ensure that there's a comprehensive safety measures are in place. There was actually a study in 2017 that emphasized the importance of developing standardized protocols across departments, which help ensure that there's a consistency in implementing best practices, ultimately improving patients' outcomes. So for future directions in radiation safety, we're kind of looking into future of personalized medicine, which offers exciting possibilities in radiation safety. A study in 2020 showed that tailoring, like how you can tailor radiation doses based on individual genetic profiles, can help reduce radiation exposure and doses. So that's kind of exciting to see how different fields can work together to kind of ensure there's more patient safety protocols and techniques taken to reduce patient exposure to radiation. Another important piece is advancing education and training in radiation safety. And there's something I actually seen in the clinic. I was recently doing my neurology rotation, and in neurology, you see a lot of patients coming with headaches and stuff, and it's always like the first thing that's thought about is a CT scan. CT scans have radiation, so it's very important that as physicians, and future physicians, we keep going through training where we learn how to decide on the spot does this patient actually need a CT scan or not. CT scans are very important because they exclude or they can eliminate a lot of dangerous kind of diagnosis that you want to avoid. But at the same time, it's very important that we learn how to see the signs where we can exclude those diagnoses without exposing our patients to unnecessary radiation. And as I mentioned, it's very important that the care is centered toward the patient and their concerns and their personalized care. So for conclusion, it's very important to keep radiation safety in mind and consider all the technology advancement and have interdisciplinary collaboration in the medical team. And it's always encouraged for healthcare providers to adapt to best practices and continuous education and acknowledge patient concerns and make them part of the team and part of the decision-making process.
Any questions? Thank you for your nice presentation. Of course, we have to take into consideration patient safety or deciding of the type of image that we are going to. But we as the physicians, we have to follow the guidelines and protocols because, for example, if I have a patient I want to diagnose with abscess of osteomyelitis, I have to go for MRI with contrast. So we have to follow, to look for the gold standard image, gold standard is to diagnose. Going back to, you mentioned about headache that some of the physicians, they are rushed to go to do the CT. Actually, you have to have your clinical suspicions, you have to have gathering data to be able to identify critical situations like subarachnoid hemorrhage, for example. The patient will be having a severe headache, and of course, you have to take the whole pictures, look for neurological symptoms, and so on. So we don't rush, if the patient is having headache, it has to be a systematic approach. And most of the patients, they don't need, especially if they are young people. Any questions? Questions? Come to you, actually. Because we have our radiologist here. He either should have a question or a comment.
Thank you for my presentation. Just straight about one or 2 points. Maybe some patients do not know the difference between MRI and CT. MRI is a different story. We do use a proton of hydrogen. The hydrogen ion in the body is abundant one, so we follow this proton and see how it changes. We have different sequences, different protocols to do the imaging. So there is no ionization in MRI at all. And MRI is safe even in the pregnant lady, she can also do an MRI. The other thing, case X-ray is the commonest request in any hospital or clinic. People ask for case X-ray for different causes. In emergency, we can do ultrasound test, ultrasound for the chest, which is not very common, but it can help. So we can avoid also unnecessary requests for test X-ray. The CT, yes, CT is very important. We have to know that the highest dose that the patient can receive is from CT abdomen with contrast. This is the highest dose. So if there is a chance to avoid it, it's very important to think about it. And thank you again for our presentation.
Thank you.
Maybe we can make use also of the artificial intelligence to avoid overdiagnosis, overusing of the images by going back to the patient records, right? Thank you very much for your presentations. Now we'll give you a certificate. You want me to be there? Thank you. Our next speaker is Mrs. Sharunda. Okay, sorry. Sharunda M. Brown from USA. I'm passing her the stage to deliver the speech on optimizing the impact of culture, renovation project on reducing waiting times. Wait times.
Okay, how do we pull up the presentation?
No, that's not yours, right? Okay, I think this is yours. Yeah.
All right. Hello, everyone. My name is Sharunda Brown, and I am a registered nurse. I'm an ER is my background, emergency medicine, emergency nurses. I have been a registered nurse for 22 years now. 10 of those years, I worked at the bedside. I worked my way up from patient care tech to charge nurse, director of nursing, manager, director of nursing, and CNO. And so I've been very excited about the work that I've done. My heart and my passion, though, is in the emergency room. Again, the Cultural Renovation Project, optimizing patient flow in the emergency department, the impact of this project on reducing wait times, right? And nobody wants to wait in the ER, right? By show of hands, does anyone in here work in the emergency department? But I see you in the back. Okay. And you too? Okay. Anybody has experience with the emergency department, have been inside of an emergency department. Okay. That's important. I just want to make sure we're all on the same page here, right? So let me tell you a little bit about me and my why. I first want to say, pardon my passion. I have a lot of passion around this topic because I have personal experience with it. That personal experience has to do with an auntie of mine, my mom's twin sister, went to the emergency department in my hometown back in the US with chest pain. She was in the lobby when because later, I went and got her medical records, right? I'm a registered nurse. So I went and got those records to find out what happened because something happened. She sat in the lobby for about an hour and 30 minutes and until she coded. I looked at her medical records and saw that an EKG was completed 10 minutes of her arrival. And on that EKG, it was clear, ST elevation, that she had had a cardiac event. But because of lack of processes, I'm a process system person now. But because of lack of processes, that was the result, right? Code blue situation in the emergency department. And from there, I have been fixing emergency departments. I was not a nurse at the time. I went and became a nurse, began to work in the emergency department, worked my way up to become a leader to make a change. I meant I was going to go in and do something different, right? Because I could see we had a problem. So I need you guys to know my passion. This means everything to me. And I truly love the emergency room. It's a good time. And that seems I know that seems crazy. All right. So most people believe that it takes years, I think up to 7 years to change a culture, right? Well, I promise you, my culture renovation project can change your emergency department 90 to 120 days. I have proof of this. How do I have proof of this? I just told you about my experience. But what I didn't tell you is that the last 10 years of my life, I have been going around emergency departments as a consultant in the United States to make these processes better in rural areas, community areas, teaching, and academic hospitals. I don't think there's any environment that I haven't been in. I've had to implement this culture renovation project in Ghana, in a place where people are living in mud huts, and we are literally taking care of 800 people with 10 clinicians. They don't have ratios there. I don't know about ratios here, but in the United States, we have ratios, right? Meaning in the emergency department, 1 nurse to 4 patients. In ICU, 1 nurse to 2 patients. But we know that don't happen 100% of the time. So we have to put processes in place, though, that's going to keep our patients safe, okay? So the culture renovation projects align and designs an environment that establishes a safe culture, period. That's what we do. And I'm going to show you how we do it. Can I walk over here? Is that okay? All right. Okay, so before I go into leadership, guys, it's important that we understand the geography of our emergency department. You guys have been in the ER and you see the chaos, right? So the best way or the best thing that we can do, which is going to take me into leadership, is to make sure we understand our environment. So one of the first things I do when I go in as a consultant, if I didn't say that I'm a consultant, now I'm a consultant. I no longer practice at the bedside. I work with CEOs when they get into big trouble. I work with medical directors when they get into big trouble, right? What is going on in my emergency department? Why are we losing money? Why is our quality going down? What is going on with our patient experience? They call me, right? So one of the first things I do before we pull this blueprint is that data. Who talked about data earlier? Everybody, I believe, and the importance of pulling data and your metrics, right? So that's one of the first things I do when I go in, and I'm gonna back into that in a minute. But pulling this blueprint is key. What is happening inside of your emergency department? Where are your patients aligned? We have a triage system, right? An ESI triage system that tells us the acuity or how sick our patients are. Where's your sickest patients in the emergency department? Where's your critical team? Hey, what about the times? What's the meaning? What's the definitions of each room, right? What's the turnaround time of each room? Those expectations matter. And so leadership has to communicate that and focus on that. That's very important. Before you implement anything, you have to have this foundation in place. Okay, so leadership, create an environment that's focused on the patient. Patient-centered care, not clinicians. Patient-centered care. Do you understand what I'm saying when I say not clinicians? This is why I say part of my passion, because I'm so assertive. So, but with this, not that you make your processes better for the patient. If your patient has a there has an ankle fracture or something of that sort, do you want them hopping over to the doctor, or can the doctor come over to them? Or do you have wheelchairs? Because I know some hospitals actually have wheelchairs. Do all hospitals have wheelchairs? I work in a lot of hospitals. Some of them can't afford wheelchairs, or some of them only have 5. How many people in the emergency department? They're processing 200 patients a day. How many wheelchairs do you have?
The practical one is really.
Those are the things you have to know. But again, patient-centered care, just trying to give you an example there. You want to reduce redundancy and non-value added steps for your team. That's what leadership does, right? You want your nurse focused on the patients, right? You don't want to worry about that documentation system all day long. You don't want them worried about any of those things. So you remove anything that's duplicated and anything that just does not add value. And again, I told you guys you have to define those rooms. And if like in the emergency department, if I have this supposed to be rapid turnover, I define what rapid is, 10 minutes or less, 15 minutes or less. If you have to pull too much, this the wrong room. Think about this, right? Important when you don't have enough staff and you have a lot of patients. All right, ensure accurate data. Now I'm going to talk about this for a couple of minutes because I've heard it several times in the room. I don't trust anything. Don't care what they give me when I walk in, right? Because what I know based on my experience is the work has not been done behind the data. The person that's pulling the data 9 times out of 10 don't have clinical experience. That's an analytical person. Some places will have a clinical analytical person, but others don't. So you need to partner somebody with your data analyst. And you need to make sure everybody understands what we're measuring. In the emergency department, we measure door to triage, door to room, door to labs, door to doctor, door to decision to admit, door to decision to discharge, right? And why do we do all of that? So we can figure out what's going on in our department. So we can figure out where the bottlenecks are and where we can focus. Everybody understand that? So if my numbers, we know what the average, or we know door to doc time, give you an example. Door to doc time should be 20 minutes in the US, 20 to 30 minutes. What's your door to doc time, Doc?
30 minutes.
30 minutes. All right. So 20 minutes is what between 20 and 30 minutes, right? So with that being said, how do you make that happen? How do you make that happen when you walk into a hospital and the door to doc time is 4 hours? I see it all the time. That's a reality. So we have to do things different, right? So again, back to that, you go back to that data and you figure out where your bottlenecks are, but you have to make sure that your data is valid. So making sure you understand those definitions, communicating with the analyst, and then scrubbing it. Scrub it. You are making decisions on people's lives based on this information. Or everything after will go downhill, right? And that's not what we want to happen. So, like my left without being seen. Left without being seen is what we measure in the emergency department to determine our wait times or determine the quality of the patient flow. So my left without being seen when I walk in, that's what I get in trouble for as a nursing director in the emergency department. If it is high, I am in the CEO's office. Why are the patients walking out of the emergency department? And there's a dollar sign connected to that. So her CEO, and the CFO has some concerns, right? Okay, so we can't let that left without being seen happen, but that number has to be accurate. So when I go in, I look in to see how many patients are really leaving without being seen. And I always, 98% of the time, find a disconnect between the data and the people that are taking care of the patients. Let me see, make sure I didn't miss anything on that, y'all. Trust, I say trusted, I didn't trust, but I want you to trust, but verify, okay? All right, and then trace processes to ensure your policies are doable. So I go in and I look at the policies and they tell me, okay, code gray is a valid situation. Push the gray button and that to save your life, to call for the cops or security up under the nurse's station. So I carry it out. Guess what we didn't have? a button under the nurse's station. You see what I'm saying here? Make sure your policies are doable. And then you lose the trust of your team, right? Like the team was like, push the button. They sent me over there, push the button. And I went looking for the button. The button wasn't there. You lose the trust of your team, and nobody's going to carry out any of your initiatives because they don't trust you. So promote safety and encourage speaking up. You want your team to speak up when things are not going well. How many of you guys have a safety statement or a safety question in everything that you do in the emergency department or in your departments? You have to have a safety statement. You have to identify when somebody has a concern. And so my team goes, I have constantly building relationships and working on getting these patients out of the emergency department. The people who get patients out to mental health facilities or wherever they need to get them, because we get stuck with mental health patients too, are the departments and the clinical teams that go out, advertise their department, and get to know who's assigning the beds, what are their processes. That's another disconnect. EMS doesn't know what ER is doing. ER doesn't know what the doctor's offices are doing. And so you have to connect those dots for a smoother transition. But we have a lot of things that we could do just depending on your organization.
During the evolution of the pathway, if the medics know there's, say, for example, like a 4-hour target, when it gets to 3 hours and 59 minutes, they make a quick decision to admit or discharge. It's never a good decision, it's a quick one. They just want to avoid this, whatever the target is. Then what we're finding is some of those patients have been admitted inappropriately because they didn't want to hit the 4-hour target.
Are you gonna get paid for those that was admitted inappropriately? You're not.
Yes.
Okay,
We have admission plan and discharge planning.
Single parents.
Okay. Oh, it's all free. Okay, here we go. It's different. Okay, that's important.
So 4 patients being discharged, and then the 30-day readmission rate, which is another target we have, they come back in.
Yes.
The revolving door. I never fix the problem, just discharge them to prevent them hitting an inadvertent target. So unless whilst you've got whatever the target is for A&E, 2 hours, 4 hours, whatever it is, you also need to make sure there's not inappropriate decision making to avoid.
So that's what those
either ends.
Those case managers and social services, they have what is that, CDI? Where they look at the physician's documentation, the nurse's documentation, and they determine, the physician, if that patient meets admissions criteria. So those have to be clearly defined. And if your policies and your admission policies.
I think the admission is decided by the physician.
Well, the decision to admit, 100%.
Yeah.
Right?
Yeah.
Yeah. But we still have to look at, did you document?
Yes.
What you were supposed to document to get this admission?
Yes.
Right. And then for us to make the right decisions, because when we came together with those policies and
I'm
procedures,
admitting that patient for this and for that.
we considered
Have to be
safety.
very clear.
Most definitely. And they have, again, we have protocols that the doctors sit down. You guys, let me ask that. I'm from the US. Do y'all have protocols?
Sometimes.
Sometimes.
Not as much.
Okay, so protocols are definitely recommended in an age where you don't have enough staff.
And the protocols show you which patient should be admitted. Yeah, we are following the protocols and evidence-based approach. Just one point adding to what we said, like for example, the American Heart Association, that they are enforcing you to see the patient in the limited time. We have windows for that. Like for the CVA, the CT should be done within 20 minutes. Interpretation 25 minutes to 30 minutes. So thrombolysis within 60 minutes. Those are very strict about. And another thing, at the level of triaging, EMS should know where to dispatch the patient. Because of, for example, if the patient has CVA, the patient should go to a CVA center. So they have a separate approach, separate place to manage those patients. So we have to start from EMS, triaging, adequate dispatching.
So we practice that. So I go out with EMS and I get in that truck, we make fake calls, we call the department and we run it through. They get mad at me, oh my God, you hate me though for that. They can't stand it, right? But we do it to be strict, but we have to do it. We have to do it. Wouldn't you rather for me practice? Not on you, but with someone, would you rather for us to practice to make sure we get that right? Because that's where you're gonna identify the bottlenecks. Who make the decisions? EMS, I went to one hospital where
it's a teamwork.
EMS did not know the hospital protocol. They had a baby. They came in, they called the ER in panic. Because, for whatever reason, babies scare EMS and emergency departments, especially when they're used to just dealing with adults. Well, what he did was want to speak to the triage. Somebody that's not supposed to answer the triage phone answered the telephone. Didn't give that medic the answer he wanted. So what he did was walked on the side of the emergency department. He called OB. They met him at the elevator. He ran in with a blue baby and got on the elevator. The doctor told me it was the moment that the door shut that they realized this was the wrong thing to do. We bypassed the emergency department. That's why you have to practice. You have to practice to prevent things like that from happening. The baby didn't make it, obviously. But those are the things you want to practice with your teams. You want to hold a conference just like this. You want your doctors to come up and tell you how to cardiac cath. You want the EMS to know when you call us, we call somebody after hours and have them warm up the machine before you get here. Bypass the ER, meet us at CT, or meet us in radiology, right? So you have to remove those non-value added steps, find out what your team's really doing, practice, 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 see what they're doing. There's a huge disconnect. Last example, I had a hospital, you make decisions. Administration's making financial decisions. Staff, we're not getting no more nurses. You have all of this. The nurses saying, no, we don't, right? Where they're looking at the data. We have 200 patients that come in. No, I'm sorry. We only have the hospital saying we only have 140 patients coming in per day. Well, I found out you have 200 coming in. Where's the disconnect? The team wasn't putting the patients in the system because they didn't want to mess up the times, the door-to-doc times. Then when the doc came in at 11 o'clock and there was a lot of patients waiting in the library and they got behind them times, he bypassed and she bypassed all those patients that was outside of the metro and started with the patient within the metro. So upstairs can't see in the penthouse. CEOs can't see. They making decisions. You only seeing 140. No, they're seeing 200. They're just not putting them in the system. As a result, the nurse is getting ready to strike, right? Because you won't give them no help. And then they're asking, they're like, we're giving you all the resources, guys. Hey, you got to know what your team's doing. You got to make sure your data's right. All right? Get in there. Don't be the office. You're the person in the office.
Can I give one last more critical example? Just because you are. One day they asked me to take one patient for CT at the time. One day we had one patient, trauma patient, he was young. Then I was asked to take this patient to another hospital, 10 minutes distance, just to do a CT because our CT machine was not working. Should I finish this example? Okay, I can finish it. Well, it's very important, believe me. This will be, okay. Then they asked me to take the patient to another hospital in order to do a CT for him. He was young, agitated, and he was intubated. And I was with that patient, just giving sedation, trying to manage until I reached the other hospital. But when I went there, I found nobody was waiting for me. Couldn't find the medical director, who didn't know what is the ER actually, because I have no idea about. So I asked my staff, I asked my RT, go check for the CT, check for the ER. I couldn't find any information. I was not safely able to deliver this patient to the ER. So I decided I had only 10 minutes for the oxygen to be, run out of oxygen. So I took my patient back to my hospital to the ICU. And lucky enough, after that, we were able to do the CT. After that, then the patient was discharged within 2 weeks. Okay. Thank you. We shall this out? Yeah, thank you. Can you see me? Is that? Yes. Come, because you will be obvious. Just come to this side. Okay.
Light is on.
Okay, come here. Don't need it. No, So our next speaker is Rob Jamin Lennoxon, if I spell it right, correctly, from USA. I'm passing him the stage to deliver the speech on innovative approaches and best practices in dialysis care in global settings. Yeah, did I spell your name correctly? Thank you.
Hello, everyone. Good afternoon. Let me set it up before I start talking.
There's my presentation.
Oh, exactly. Somebody,
You're our hero for today because you were able to manage without.
exactly. I can't get off from this. Slide 76. So escape. Let's go with mine. Set it up. There you go. Thank you so much. Cool thing showing up. All right, good afternoon, everyone. So I'm going to introduce myself to you. My name is Jaime Liamson. I'm originally from the Philippines, but I migrated in the States for been there for 20 years. So I actually an educator by profession for 30 years and also dialysis nurse for 15 years. So I worked in chronic and chronic and acute settings in the hospital. And right now, I'm basically a director of nursing for U.S. Renal Care Dialysis in the United States, which is actually one of the three largest dialysis company in the U.S. So we also have recently bought the satellite company. So and also we have opened like 3 or 4 new dialysis facility in Saudi Arabia. So working in dialysis actually gives my be able to apply my teaching skills as well for teaching in community colleges and also providing all the insights that I could give to my patients when it comes to their diet and also infection control practices as well. So my topic is all about innovative approaches and best practices in dialysis care in global settings. This is just basically a information sharing. This is not a thesis. This is not a master thesis. This is not a PhD thesis or whatsoever. It's just like because I work in a dialysis, it kind of tend me to become curious on what other countries are actually doing and what technologies, cutting advanced edges technologies that are actually developed to provide quality care to dialysis patients. So as dialysis is basically a treatment for CKD and ESRD patients who are, the kidneys are not functioning, and we have to provide dialysis for them to remove the toxins in the blood and also to remove those fluid overload, right? So I will be talking more about that, and then as I go, I will discuss some different approaches and also cutting edge technologies that other countries are actually doing when it comes to providing dialysis care. All right, so from the inception of hemodialysis, hemodialysis has undergone continuous refinement to enhance patient outcomes with disadvantages of hemodialysis using the old technologies. It is crucial to develop innovative treatments that aim to completely replace existing therapies rather than simply clearing them. So facility-based and in-home treatment options now use sensor technology, which playing a critical role in optimizing dialysis parameters, enhancing patient outcomes, and driving costs efficiently. Advanced sensors can help precisely control critical parameters such as blood pressure, blood temperature, venous and arterial blood pressure, in-process pressure, prompt force, and air bubble detection to help enable patient safety and treatment quality. So additionally, liquid temperature sensors in dialysis machines have control system and also using thermocouples and RTDs for accurate temperature regulation. Air bubble detectors prevent air embolism by identifying air bubbles in the venous path, while blood pressure sensors, oxygen saturation and pulse sensors, body temperature probes, and respiratory sensors provide comprehensive patient monitoring safety during dialysis. AI is also playing a transformative role in kidney care by providing quick and valuable insights that improve the quality of surgeries and treatments. AI-powered databases offer personalized, non-invasive monitoring and healthcare suggestions. Big data and advanced analytics are essential in providing precise, individualized insights for patients with kidney-related diseases. These technologies inform medical experts about patient status over time and under various conditions, driving precision medicine and development of medical devices like dialysis machines. So US-based startup Nepra leverages machine learning to create personalized treatment models for CKD patients, focusing on non-invasive potassium level monitoring to prevent metabolic imbalances. Potassium is a very, deadly, what do you call this? This is we actually, to catalyze the patients to prevent hyperkalemia, right? And then those patients, if not going to be dialyzed and monitored, could be fatal. So we tried to kind of, so this US-based startup could actually, create personalized treatment model for CKD patients on determining the monitoring the level of potassium per patients. Another US-based startup, Renalex, utilizes AI with its Kidney Intel 9 and bioprognosis product to assess early stage CKD risks and predict outcomes using prognostic biomarkers and clinical features, guiding medical practitioners in clinical decision making and managing CKD progression effectively. Then we have Denmark-based startup Eboflix Medics employs big data and analytics to create precision medicine solutions through an individualized telehealth system that predicts hospitalization, mortality rates, and health complications for CKD and ESRD patients. And then the NeoKidney, developed by the Biotech SA, and NeoKidney BV is a compact portable dialysis device assigned to be worn as backpack, providing greater mobility and flexibility for patients. Currently, it is in development with efforts concentrated on advancing a functional prototype to critical trials. So because the patients are in a CKD needs to be in the facility for like 3 times a week. I think this is going to be a breakthrough for patients instead of like coming to facility 3 times a week. This could just like be a wearable device that they could do dialysis while doing their daily lives, like performing all their lives activities. That's another wearable dialysis machine. By nanodialysis, BV utilizes a nanotechnology based filtration system to offer a portable dialysis solution aiming for continuous treatment in a wearable format. It is currently in the development and preclinical testing phase. The AWAC, which is known as the Automated Wearable Artificial Kidney, by AWAC Technologies, uses sorbent-based technology to regenerate dialysis, enabling a portable and wearable dialysis system that provides continuous treatment. It is currently in the prototype and clinical trial stage, with progress being made toward commercialization. Oh. There you go. The immersive technologies like virtual and augmented reality are becoming increasingly important in kidney care education, and French startup Surgar develops AR solution for laparoscopic surgeries, creating preoperative 3D models from MRI, CT scans, and integrating them with laparoscopes to display tumors and highlight critical anatomical structures. We have a Singapore-based startup, Kayello, which offers a VR library for kidney professionals and students, providing immersive modules to study laparoscopic surgeries and enabling surgeons to make informed decisions by consulting previous solutions and challenges. Then the demand for remote healthcare has surged, leading to innovations in telenephrology, which facilitates online consultations and remote management of kidney diseases. US-based startup Renal Care 360 Degrees offers early detection of system for chronic kidney conditions, utilizing medical records to determine treatment pathways and providing real-time engagement with medical professionals. Play a video. All right, so Canadian startup called Cares has developed an app for kidney care, integrating wearable sensors, mobile app guidance on diet and exercise, and real-time data access for nephrologists and care managers, making kidney disease management more accessible and personalized for patients. And recent advancement in dialysis technology have revolutionized home hemodialysis, providing patients with greater safety, convenience, and personalization. Startups are developing innovative solutions to enhance renal care, such as wearable dialysis machines that allow patients to remain mobile and active. US-based startup Revelos Peritone X is an inline connection device that disinfects dialysis tubes internally, making peritoneal dialysis safer by reducing infection risk. Another US-based startup, Bionix, offered the Bionix 11, a smart portable bloodless dialysis machine, which a user-friendly interface and cloud-based monitoring, improving the quality of life for CKD patients to enhance mobility and automated documentation. Patient-centered care through multidisciplinary approach. So multidisciplinary kidney disease care has been associated with improved clinical outcomes in comparison to general nephrology care. Multidisciplinary approaches to hemodialysis have shown significant benefits for patients with CKD and ESRD. These approaches involve coordinated care from various healthcare professionals, including nephrologists, surgeons, nurses, and others. Studies have demonstrated improvements in clinical outcomes, such as increased use of our AVF fistula, reduced hospitalizations, and decreased mortality rates. Patient-centered outcomes, including quality of life and satisfaction, has also been targeted through these interventions. The approach includes preoperative vein mapping, early detection of access dysfunction, and regular team meeting to discuss patient care. Guidelines such as KO2QI and Fistula First program been developed and standardized best practices. So I work in a facility. So I manage 5 different clinics in downtown LA. So each of the clinic has actually what we call the IDT or interdisciplinary core team, which involves the nephrologist, the social worker, and the dietitian. So basically they gather like every week to discuss patients' clinical outcomes based on the labs, where patients are actually being hyperkalemia or low potassium, and patients also having a fluid gainer, so they need to do some of those educational sources they could provide the patients to educate them on what are the renal diet and what are the fluid restriction strategies to be able to help patients improve their quality of life. Social worker, on the other hand, actually talk about the social resources that can provide the patients. Like patients could have transportation issues, right? Patients could have difficulty on attending or going to their appointments with nephrologists, like checking their fistula, whether it is functioning or not, right? Or whether there's stenosis. So early detections actually makes them, easy for them. And also the treatment team, like the nurses and the patient care technician, to develop a plan on how to make things easier for the patients. The National Kidney Foundation, or what we call the KDOQI Clinical Practice Guidelines for Hemodialysis Adequacy, is a comprehensive set of evidence-based recommendations for practitioners caring for patients undergoing hemodialysis, which has provided evidence-based guidelines for nutrition in kidney diseases since 1999. The evidence-based guidelines cover various types of hemodialysis care, including vascular access, adequacy, and timing of initiation. So the guidelines emphasizes collaboration among nephrologists, surgeons, and interventional radiologists, and are developed through rigorous methodologies involving extensive literature review and expert outcomes. So when the patients was admitted actually to the clinic, they're actually either admitted from the ER with, the IJ on their neck, and that's basically the only access that we have, or the CBC. That's the access that we have to provide dialysis for patients. And those access are very prone to infection, bloodstream infection. So when we admit a patient, we only make sure that they're given only 90 days to transform those access into either AVF, arterial venous fistula, or AVG, which is a graft, right? And that's going to be a permanent access. CVCs are very prone to infection because all those catheter lengths goes directly to the heart. So what we do is we try to educate our patients. It's also taking care of patients in CVC is actually putting a lot of nursing labor, right? Remember, we have to kind of change the dressing every time the patients come to the facility and make sure that it's free from any infection. We have to apply infection control, checking out the dressing every single time, right? Unlike in the fistula and the graft, we have the technicians who are actually well trained and undergo schooling to cannulate those patients, and those are permanent access that could run the patients with the blood flow of 350, which is very essential on cleaning the blood, right? Instead of like a CBC, which only from 250 to 300 blood flow. And very expensive too, because all the dressing we need to change is expensive rather than just like, the fistula and the graft, which doesn't have a dressing alike with the CBCs. So nephrology nurses are registered nurses with a specialized education, experience in caring for patients who are experiencing or at risk for kidney disease. Nephrology nurses are continually update their education to a variety of programs, publications, and special activities. Continuing education offers various advantages for dialysis nurses. So dialysis nurses have a range of continuing education options, such as attending professional conferences and workshops like this, taking online courses and webinars, pursuing academic courses, participating in hospital training programs, and obtaining specialty certifications, engaging in research and publication, and joining peer learning groups. For dialysis nurses looking to expand their knowledge and skills, the American Nephrology Nurses Association, or what we call the ANA, is an invaluable resource. ANA provides a wide range of educational materials, including conferences, webinars, and specialized publications that focus on various aspects of nephrology nursing. These resources offer nurses the opportunity to stay updated on the latest development in the field and to the network with other professionals. And we also have what we call the NNCC, the Nephrology Nursing Certification Commission, which another important resource for certified dialysis nurse. NCC offers information and certification requirements as well as continuing education opportunities. Online learning platforms also provide flexible options for continuing education, like the Medscape Education offers accredited courses and webinars covering a variety of nephrology topics, making it convenient for nurses to update their knowledge at their own pace. We also have university continuing education, like the Johns Hopkins School of Nursing offers various programs in nephrology nursing and related fields. The UC Davis Health in California also provides a variety of nursing education programs, including those focused on renal care, offering nurses the opportunity to gain in-depth knowledge and practical skills. What are the strategies to influence healthcare policy and advocacy efforts for equitable dialysis treatment? So that includes improving data availability and integrating core registry measures to inform policy development. So the policy changes and quality initiatives are powerful levers to improve home dialysis care. Policy changes and quality initiatives like the ESRD Quality Incentive Program uses measures reported to Crown Web, or what we call now the EQRS, and the National Healthy Safety Network to assess dialysis facility performance. And we also we have the network 16, 17, 18, depends on the region of the United States. In California, we have network 18, if you guys are familiar on that. Those are patient advocacy that actually helps and promotes patients' welfare. If there's any concerns about the treatment of the patients, we actually reach out to Network 18. If there's any issues like behavioral issues before we discharge the patients, there must be a strict and collaborations with network people before we discharge the patient. And I recently have that experience in one of the clinics that we have to discharge a patient just because of the behavioral issue. And then we make sure that the IDT met before the IVD, what we call IVD, to be able to provide patients as well a continuing treatment if we discharge them. So selecting, case studies or successful stories around the world, Japan has developed a successful hemodialysis program with 334,505 patients receiving dialysis treatments as of 2017. The country's health insurance system covers most dialysis costs, making it accessible to patients. Japan dialysis outcomes are impressive with lower mortality rates compared to Europe and the US. The country has also made progress in home dialysis, home hemodialysis. Although,
Prof. Jamil, sorry for that.
Yes.
You have 4 minutes.
4 minutes, okay, I'll be done. And then Canada has developed a successful hemodialysis program through a publicly funded healthcare system that provides universal access to dialysis services. India has also a great improvement on making significant progress in developing a successful hemodialysis program despite facing numerous challenges. China has developed a successful hemodialysis program through a combination of government support, innovative approaches, and dedicated healthcare professionals. South Korea has developed a successful hemodialysis program, as evidenced by the rapid growth on ESRD patients receiving treatment. And the success program in the US can be attributed to several factors, and universal access to treatment through Medicare coverage has been crucial. Spain has demonstrated success in hemodialysis program through various factors. The introduction of home hemo with low-flow dialysis monitors has shown clinical benefits. And in the UK, the success of UK hemodialysis program, patients' education, training, and ongoing support care crucial for improving home hemo uptake. The UK's organ donation and transplantation program has seen significant improvements due to centralized coordination and expert clinical leadership. So basically, this is just an information sharing. This is not, I told you, this is not based on my experience, but basically, I just want to share everybody what have been the other countries actually doing when it comes to patient care for those patients who are in ESRD or CKD. And I'm so glad that I'm on this journey to help patients and treat my patients, even in chronic or acute settings, and providing them an education that I could provide to them when it comes to renal diet and absolutely when it comes to infections control, and at the same time telling them that the CBC is not basically permanent access, but rather the fistula or the graft. So that's all I have, and thank you for listening to me.
Thank you very much for your presentation. Very informative. Always when it comes to fistula and dialysis, always there is a concern of bacteremia, especially Staph aureus MRSA, right?
Correct.
Any questions? One question, we're running short of time.
That'd be better. Exactly, definitely. You could reach me at, just like reach out to me by my chair, and I could give you my email address and even my phone number if you want.
Small question.
Yeah.
The portable, the wearable device.
Yes.
The frequency of the dialysis session, is it same how we do in the conventional dialysis, which is 3 times a week, or?
So in a traditional hemodialysis treatment, patient comes to the facility 3 times a week. Depends on if the patient is a fluid gainer or not, right? So the nephrologist mostly advise the patients to come 3 times a week or 4 times a week. The wearable devices is basically the patients could actually wear it within certain period of time, depends on the nephrologist's prescription. Like, for example, they could wear it like for 4 hours or 5 hours while doing their regular daily activities. They can do it, they could actually wear it while at work, or they do it any, in school or whatsoever, as long as they wear it within the time frame the nephrologist actually prescribed. And then also we have that kind of hemodialysis where it's going to be called peritoneal dialysis, where the catheter is actually connected to the peritoneum. So patients actually do that at home as long as patients have a strong family support that I could help them, because sometimes they have to drive and get all those what we call the supplies from the facility. So we have a strong home program for US Renal, and we have increased our home patients just because of the CMS guidelines as well, to put all the patients mostly on the home dialysis because of the Medicare reimbursement.
Yes, exactly. Same in Saudi Arabia, we are shifting also. Many of the centers and even the hospitals are going for the home dialysis.
Correct. Yeah.
And patient education and training is very important, actually crucial in home dialysis and even wearable.
I strongly believe in that.
Thank you.
Thank you so much.
It's challenging. It's very challenging to monitor the patient at home, having his input, output, and labs.
Exactly.
Decide on a permanent treatment. This is days and frequency.
Agreed.
Thank you very much for your presentation.
Thank you, guys. So I have my certificate. Thank you. Thank you, guys.
Our next speaker is Ms. Humaira Nassim from UAE. I'm passing her the stage to deliver the speech on nurturing resilience, a multi-layered approach to breaking the cycle and healing integration and trauma through maternal wellness.
Yeah, I'm fine. I think I'll be needing the mic. I'll take the mic. Good afternoon, everyone. My name is Omera, and I'm honored to share with you this very important topic that's very close to my heart, nurturing resilience, a multi-layered approach to breaking the cycle and healing intergenerational trauma through maternal wellness. I have a calling towards intergenerational trauma and have spent years researching on the intergenerational trauma that is inherited through generations, and I'll be presenting this phenomena that is mostly overlooked. Firstly, I would like to share a story. That's a very personal story of my grandmother. Back in 60s and 70s, when mental health was not an advanced field, she she suffered from depression and some pharmaceutical drugs were tested on her. Unfortunately, they did not work and affected her liver. And she was diagnosed with liver cancer and she died with that disease. So this fast forward now in when I hit my 40s, I went through the same condition of depression and I realized that I was repeating the cycle and it was my turn to break it. Now, what is the agenda for today? In this regard, I would like to explain, let us understand what is intergenerational trauma and how it is transmitted from one generation to another. Then next, we are going to discuss what is the impact, what is the impact and importance of maternal wellness in the transmission as well as inhibition of intergenerational trauma. And let's build a foundation for a more resilient and healthier future generations. Lastly, I will be presenting you a four-layered approach to healing trauma in mothers. So let's begin. With my experience in the field of holistic healing and coaching, I came across numerous clients that had certain outcomes to achieve. Maybe it was in their personal life to, let's say, reduce weight or be anxiety free, or in their professional career to reach certain milestones. There were certain thoughts, beliefs, patterns that were playing in their life unconsciously on autopilot, which they did not have, it was not in their conscious awareness. But these thought patterns and these beliefs were the very reason that were sabotaging and limiting them to achieve the very same outcome that they wanted in their lives. So let's understand. Let's understand that what are these dynamics? What are these limitations? What are these thought patterns that we live so unconsciously in our lives and identify those patterns? Now, what intergenerational trauma exactly is? It is the transfer of physical, emotional, psychological wounds that are transmitted from one generation to the next. And how is it transmitted? Let's say a person from one generation experienced a traumatic incident, let's say migration, forced displacement, war, genocide, sexual abuse, etc. The impact is so deep on the cellular level that it affects the genetic imprint of that person. And what happens is, how is it transmitted from one generation to another socially? By means of compelling stories, through communication, through family and social dynamics and values. And that's how it gets transferred. But one thing that is very complex in this situation is it is difficult to get the evidence of it. Because to collect samples across generations, let's say 4 or 5 generations, and keep a record of it is not easy. So epigenetics come to our rescue. Let me play this small video for you to better understand what intergenerational trauma is and how it is transmitted. How can I play that? The video is here, right? We tried last evening. No. I noticed. Can you guys hear it? What smells bother us? Anyone would like to share their views of how we are impacted with certain lifestyle triggers that impact us? Can anyone relate?
Yeah, but I have an example, or maybe you can clarify. So I have celiac. That gene didn't turn on until my 40s when stress probably triggered that gene. But I'm certain that my ancestors also had that same problem. Is that an example?
Exactly. That's how we can relate with our ancestors and how those epigenetic tags that were passed across generations, some switched off, some did. And the thing about epigenetic tags, I'm sure as doctors, you guys must be knowing that it can get triggered with lifestyle in childhood development, and it is also hereditary as well. So we don't know what traumas that our ancestors carried, we are still carrying in our bodies. And interestingly, our cellular life as an egg begins in the womb of our grandmother. So what experiences our grandmother when she was pregnant with our mother was having, either positive or negative, we experienced it as the egg in the womb of her grandmother. So this is how critical this information can be for us to live a more a quality life, a resilient and more healthier life. So to understand intergenerational trauma, we can divide it into different types. I've put on 4 major types of intergenerational trauma. Number 1 is patriarchal trauma. Patriarchal trauma, there everybody can relate to it if you have heard the story of Adam and Eve and the forbidden fruit. And as women, especially, I can see a lot of women in the room. What feelings after what the connotations that so what communication over the generations, what stories have you been told? What feelings do you feel when you hear this the story of Adam and Eve? Does anybody have idea? What emotions come just as you hear about this story? Guilt. Very guilt. Number 2, regret. Good. Shame. And as women, let's go to the root cause of this trauma and this story. Imagine how much as women and as mothers, we are carrying the same guilt and shame in our bodies, in our emotional body, especially. So and because we are talking about maternal wellness and how important the role of maternal wellness is, because if we work on the maternal wellness, the rest of the generation, and everything will fall into the right places, right? So as mothers, how does this guilt and shame, let me first tell me how this guilt and shame played in my life from my teenagers, let's say. How patriarchal trauma impacted me, the feelings that I had, the shame, I must not be good enough. Boys can do certain things, I cannot do it. So I deliberately chose the field of hard sciences and chose computer engineering, despite not having much interest in it, but just to prove that I can be an engineer as well. And later in my midlife, I realized that I was calling for psychology, and then I, switched the field. But imagine, women are not good drivers. I made sure that wherever I traveled across the world, I made sure that I'm going to drive the car to prove myself that I am worthy. So that's how our choices, our decisions are made on the stories that are coming from the society, from the family, and etc., from the education system. So these are the ways. And now coming to the maternal wellness, how many are mothers here who can relate with the mom guilt? Right? So the mom guilt, the self-care as mothers is so very important. But we put priority of our family and especially of our children and their happiness primary. And we lose our own health, our own self-care because of this mom guilt. Oh, I must not be a good mother if I'm spending time on my health. So much so that the very same happiness of the children that we are seeking as mothers is compromised because we are not happy. Isn't that so? Because we cannot pour from an empty cup. Our cup is not filled with happiness. How can we give that to our children? The second feeling that comes is that of shame. And the emotions of shame as a mother, what do they bring? Any idea? As mothers, it just said that it requires a village to raise a child. But as mothers, when we are in this feeling of shame, we do not seek support. We do not ask for help. Why? Because people will think we are not good mother, we are not perfect. We try to prove ourselves as perfect mothers. And at that stage, what happens? We reach a stage of burnt out. Can you guys relate with this? Not getting external support, help, because that would mean I don't know how to raise my child, so I'm not going to seek support. I'll be independently raising my child, and in that process, I'll just go into that burnt out phase, and the cycle will repeat. And whenever I'm angry, in my anger, I would, throw that anger onto my child, and then now the child is going to feel the same emotions because children are emotional sponges. They absorb the emotions of the mother, and now the child is feeling the same shame, and I've transmitted and began a new cycle of guilt and shame in another generation. So that's why maternal wellness plays such an important role in breaking the cycle of intergenerational trauma. I can because we are getting short of time, I'm not going to cover all of the different types. Patriarchal trauma and let's say sexual abuse they have the same kind of emotions, guilt, shame. Let's say if somebody in our ancestry has been sexually abused, the same feelings will reside in us in one way or the other and would be driving our emotions, and not only our emotions, our behaviors, our thoughts, our choices in our life. And we will be creating a similar reality rather than innovating, healing, and evolving to a better generation. Next is childhood trauma. So let's say in a patriarchal society where men are favored over women, and girl child is not preferred, male child is preferred over a girl child. Let's say favoritism is there. So as a child, as if I'm seeing the sibling is being given privileges and priority over me, what kind of emotions I'm gonna feel? As a child, what are we going to feel? Depressive. What else? What's behind that depression? Jealous. Jealous, yes. True that. Jealous. What's behind that? Why I'm feeling jealous? Because I'm not given the attention that I deserve. I feel worthless. Now, low self-esteem. Exactly. That's the root cause of people having low self-esteem, because they feel worthless, and it starts from the parents. It starts from the lap of the mother. If the mother has been treated, see how it is interlinked and interconnected. If mother is treated like that, she will pass that trauma on to her child as well. So low self-esteem, feeling worthless, what are going to be the thoughts? As a child, I need to prove myself to my parent. So what emotions we already discussed, what behaviors repeated there? People pleasing. I'll do my best to prove my mother or father that I deserve attention. I'll do all the negative things to seek their attention so that I too get loved. And the conditional loving I will learn from my parent. Then perfectionism. I'll be very self-critical because I have to prove myself. So all these are the root causes, and because of these thoughts, emotions, and behaviors, what is impacted at the first level? You have 4 minutes. Okay, I'll just wrap up. So it's our spiritual health, firstly. Second is emotional health. Then mental health and physical health. These are the 4 things that are impacted in the process. So until we do not make our unconscious conscious, it will rule our life, and you will call it fate. That's Jung's philosophy. So we need to make ourselves aware and conscious enough to realize what thoughts, beliefs, patterns are driving our daily lives. Now, we already discussed the importance of maternal wellness, the womb trauma, the child development. Let's say if the children are being raised by the mother, they are emotional sponges. They are
that if the mother is emotionally overwhelmed and her behavior, her behavior in that emotional overwhelm is to eat sugary foods. Excuse me. What is a child? What are you modeling to our children? That whenever you are faced with a similar negative situation, you need to nibble sugar bites. And then what runs in the family? If this pattern is repeated over the years, what is disrupted in the body? Insulin. And that's how diabetes is diagnosed in the family. So this awareness is very important, that what are the root causes of these chronic illnesses? What are the root causes of autoimmune diseases? So this awareness is very important, and we need to break the cycle. The hand that rocks the cradle is the hand that rules the world. And in that regard, I really admire functional medicine, the integrated approach which is patient-centered, there's personalized care, and holistic approach. And that, I believe, is the future of where the healthcare is going towards. Excuse me. So I would present the 4-layered model in the last functional medicine, where I would like to collaborate with all you passionate doctors out here, where we can come together and collaborate and build a foundation to raise a more resilient and healthier society. So the 4-layered approach is a spiritual health, wherein the number one thing that comes into play is mindfulness, meditation, chakra healing, to clear and cleanse our energetic body. That's the first layer. Second is the emotional health. And Dr. Nagin, I think you presented the painting, right? So the emotional health, art therapy, the way, that's why I mentioned winter blues, because when in winter you are usually depressed. And one way to cure depression is to put emotions out on paper, either through journaling or either through painting. So the second layer of preventive measure is how we handle our emotional health. Then, so just a minute, I'll just take 2 minutes and I'm just stopping. I'm so sorry. Then it's our psychological health, wherein comes counseling, therapy, coaching. And then the physical health by building healthy lifestyle, habits and routines, and taking needed whatever needed health care at the physical level it is needed. We handle it at this level. So this is the presentation for today. Thank you for listening to me. If you have any questions,
Thank you for your presentation, actually. Thank you. Very informative presentation.
You're welcome.
Actually, don't have questions. And Ms. Ramesh will be here to share the next section after lunchtime.
Hopefully
So we'll
by
be able to answer questions. So we had our last session before the break time.
And can I have my set? Thank you. I can understand. Yeah.
So our next speaker, Miss Maria Shelia Zarsadiaz from USA, if I spelled correctly. I'm passing her the stage to deliver the speech on mechanism and effectiveness of heat and cold therapy.
Wait. Wait, how do I hide it? It's still seeing. Is this moving? Nope. Mm. Right. I have like a music intro here and it's not working. It's not.
Music is working with the,
Okay.
it's not connected.
Can you guys hear the music? I wanted you to hear this special music. I wanted to have a relaxing intro with this ancient Egyptian music. Um, good morning to all of you. I hope you like the music and supposedly relaxing and digital caffeine, or a brain energizer. But looks like we have many folks in the audience from different walks of life. So let me start by saying marhaban tasharafna. Kif ahluk ani Maria Sheila. I just love your language and that's all I know. And it's truly an honor to be here and it feels so surreal to be standing and facing all of you. There you go. And I'm super excited to be part of this community. Your role with never-ending dedication that you bring to your profession every day and the hard work that you put into keeping our community safe. Your intelligence, bravery, and compassion are really the saving grace of this nation. And I hope that you welcome pure heart with your open heart in your industry. My name is Maria Sheila Zarza Diaz. I'm from San Francisco, California. And my background in clinical is we're all about from textbooks only. I majored in occupational therapy. I got in a program, I became sick, and the next you know, I changed my major to management information system and communication. So in the past 15 years, I have developed healthcare applications from referral to patient notes, different modules, patient notes, authorization of services, medication, and so forth. And then back in 2022, I decided to open up my own company. And it's basically our mission is to restore individuals' purity and innocence by healing body and spirit, rekindle the individual's original light, give individuals hope to achieve their full strength and beauty. Now, we are a company that Pure Heart is a company that I am immensely proud of. We are a company with integrity and determination to make a difference in this world by helping others heal. And we develop and distribute high quality, sustainable, comfortable gel packs. Now, we are the only company in the world who focus on gel packs alone, backed with intense research and development. Our research team consulted with various existing studies and abstracts, and also with well-known plastic surgeons in California. So we all know about gel packs. There's so many hundreds and almost 1,000 of research on it. But so we're just here to execute that. We are also partnered with Operation Smile, Global Children International Surgery, Anahuna from Amman, Jordan, and Global Clubfoot Initiative. We provide gel packs to them at no cost for cleft lip palate surgery and clubfoot conditions. Now, you're probably wondering why Egyptian? Well, we adopted an ancient Egyptian mythology because we believe that every person deserves to live pain-free. Adopting an ancient Egyptian belief that the heart is the center of a person's being. We strive to provide patient-centered care rooted in the belief that every person is worthy of healing. Now, the belief of the Egyptian mythology, which is an after death, a person must go through a series of judgments. One of these is weighing of the heart, and which is the heart is weighed against a feather. Now, if your heart is pure, you are allowed to pass into the afterlife and live happily ever after. If it is not pure, your heart is eaten by a demon and you cease to exist. Well, it seems like pure heart passed this test. It feels like this is our afterlife, in which we hope to live happily ever after by helping others heal their pain fast. Pure Heart service the whole entire healthcare realm, and we can dive into more details later. Pure Heart is honored here to share with you the mechanism and efficacy of heat and cold therapies, and to remind ourselves that these kind of therapies are just one of the keys to fast healing, not just for our patients at the clinic or hospital, but each individual human being. Here's the summary of the concepts that I would like to present to you, which is the ice making, the ancient Arabs way, composition and relative index of accident types in terms of economic sector in UAE, injuries related to MSK, global health trends issues, status and statistic. I don't know why there's a question mark there, but mechanism of actions and benefits of heat and cold therapy, Pure Heart's contribution to humanity, and Pure Heart's innovative products. Now, does anyone know how ancient Arabs made the ice in the desert? No. Well, long before electricity and refrigerators, people used to make ice in the desert, and this was even stated in the Bible. The creation of yakshals, a Persian word yak, meaning ice, and shal meaning pit. The structure which worked as a cooler allowed the freezing of the water to take place. Yakshals were large above ground structures built with heat insulating materials which serve as coolers during the hotter months of the year. The structure had a deep hole in the center of it, which lead to an underground storage space. Yakshals were often used to store ice, which naturally formed during winter, as well as storing food. And however, these structures were also able to freeze water in the desert. Now, as I was doing my research for this presentation, I became curious on what composition of accident types in terms of economic sector here in UAE. Now, perhaps this information, we can consider this as a leeway to prepare and better understand the subsequent slides and how Pure Heart can deeply connect to it. It was mentioned that UAE ranks 9th of all countries worldwide and the only Arab country who has managed to maintain its rank in the top 10 competitive countries for 4 years in a row. According to the Institute of Management Development World Competitiveness Yearbook of 2020. Now, UAE country has mastered to diversify positive strategies, and many of your industries underwent a huge boom in terms of growth. Now, this period of growth has led prosperity to various industries and positive contributions to your economy, but at the same time, it faces many challenges that are mostly related to high volume of accidents and injuries within the industry. Accidents are really accidents, despite the efforts that the government has regulated and issued. Now, it shows here that 33% for the construction and maintenance, which is the highest due to their hazard field by many international bodies of occupational health and safety. 30% are from craft work industries, which are hotel, driver, storekeeper, security manager, and so forth. 10% are for trading, 11% is manufacturing, 16%
or others, and etc. Now, this table represents the final ranking where frequency FI and severity SI analysis are also shown. Also, the relative importance which identify which accident types are considered that has the most score with respect to each of the listed accident types. Heat exhaustion was ranked number 1. Now let's examine the global health trends and issue. We would like to present this information to provide you a more constructive analysis of where Pure Heart can play a big role to this. We've been hearing about AI, artificial intelligence, which can automate a large portion of the manual work process to speed things up. For example, an AI to easily spot breast cancer, biomarkers that is used to identify presence of a disease as early as possible. I mean, they have this pill as well that you swallow and can detect and read a possible disease. But the latest one is an AI-led primary care appointment that possibly a machine-driven taking the vitals, a machine conducting interviews, and so forth. Patients in the United States accept it, but do not prefer it because they would rather see a human medical professional when there's need to prescribe pain medications, to decide when to go to ER and other services. Now, healthcare costs will grow 7% next year, where providers are expected to seek rate increases from payers as they already struggle with labor cost, and while health plans will face pressure from increased pharmaceutical expenses. Telehealth is one of the select few industries that's seen benefits from the coronavirus pandemic. Before COVID-19 hit the US, virtual care use was growing steadily, but only a small fraction of consumers had tried it. Now, fast forward to 2020, and telehealth became more a necessity than a luxury. The development of remote patient monitoring services and other connected medical technologies has made it possible to treat more patients at home. The FDA Centers for Devices and Radiological Health said it is committed to facilitating access to medical devices designated to be safe and effective when used outside of traditional clinical settings. For example, medical devices intended for use in the home. There's also a rising cost of medical certifications under new MDR in EU that could result in a shortage of medical devices and for children. Some types of devices are already facing shortages. The letters writers warn. Balloons used to treat certain congenital heart defects in newborn infants have become unavailable, and shortages have been reported for dialysis machines used to treat young children with end-stage kidney disease. Another issue that we face in the US is the nursing shortages. As it is, we've had these problems highlighted since the COVID-19. In March of last year, Congress reintroduced federal legislation to set minimum nurse-to-patient ratios nationwide. Believe it or not, we have about 1 million registered nurses with active licenses who are not practicing today because it's not because they don't love nursing. They don't love the stress. They don't love putting the patients at risk. And they don't love going home every day fearing that they had harmed someone. Whilst all these issues and trends are happening, Pure Heart can contribute this to assist. Now, the list of injuries I've mentioned in the bullets are basically what we have witnessed from the pie graph of composition of accident types here in the UAE. What are the effects of hot and cold therapy? Well, the cold therapy causes the blood vessels to contract and reduce circulations, therefore decreasing pain. Removing the cold causes the veins to expand, increasing circulation. Heat therapy can be applied to assist for circulations and the incoming flow of nutrients that can heal the injured tissues. Heat treatment promotes blood flow and helps muscles relax, used for chronic pain. There was a randomized clinical trial study of single-blind parallel group. And the objective was to compare the effects of cryotherapy of what they have used here, specifically neurocryostimulation and CS, with those of traditional ICE application of functional recovery, pain, edema, and ankle dorsiflexion, range of motion, ROM, individuals receiving physiotherapy treatments for acute lateral ankle sprains, LAS. We all know that the ankle sprain is a very common injury, and its management is often costly, with important short and long-term impacts on individuals and society. As new methods of therapy using cold or cryotherapy are emerging for the treatment of MSK conditions, little evidence exists to support their use. NCS, which provokes a rapid cooling of the skin with the liberation of pressured CO2, is a method believed to accelerate the resorption of edema and recovery in the case of traumatic injury. Now, in this diagram, it shows at the functional level is higher, meaning that the participants who received the traditional icing method was able to function faster than the ones who received cryotherapy. In this graph, the pain at rest score in red for the traditional ice method shows significant lower of pain level. In this graph, the pain during usual activity score in red for the traditional ice method shows significant lower pain level. Do you know how many post-op surgery instructions documents that we have read where frozen peas was mentioned? Well, it was almost 100%. Now, who wants to put a frozen vegetable bag on your body? Or will I need to duct tape it just to wrap these gel packs around my head, hand or knees, and so forth? Or perhaps a doctor may suggest, well, why don't you just order an Amazon Prime? Well, guess what? Time is the essence. Time is of the essence. By the time you order from Amazon, even with Prime, you already lost 72 hours of immediate time of healing. The first 3 days of 3 days after your injury is very critical. Now, remember the global test trends and issues that I put earlier? Well, Pure Heart is here to contribute to mitigate that, perhaps in a smaller or bigger way, but we all have one common goal here, which is about patient safety. Pure Heart gel packs is just one of the cryotherapy modalities. But one is I can't find there it is. But what is very unique about our products is that that's how we control to fit and hugs each of the body perfectly. We conducted a very intense research and developed with a total of 125 unique products to ensure that we cover the most common conditions or minimal procedures up to the most critical intensive procedures. Now, these gel packs that I'm about to show you are patients of condition types of hand, wrist with carpal tunnel, ankle replacement surgery, arthroscopy, joint fusion surgery, Achilles tendon repair, and my most favorite one is that we created. It's a hands-free, tie-free, and basically just floats on your body. It's for herniated disc surgery, spinal osteotomy, vertebroplasty, bone marrow aspiration, etc. Now, this is for the mouth, orthodontic, jaw osteotomy, maxillofacial surgery, shoulder rotator cuff surgery, shoulder arthroscopy, shoulder dislocation. And this is our 5-4 thighplasty, inner thigh lift. So So Pure Heart gel packs are anything but standard. It is high time for the innovative idea to come to the surface. Our gel packs, our products are safe and built with high quality products. It's direct application, no freezer burn, no heat burn, but most of all, why put a block of ice bag and wrap it using a tape? Why wrap ice with a towel? Look, we can all get all creative, but if we're in pain and in bed, we want relief to come as easily as possible. And that's what Pure Heart strives here to do. It is leak-free. There's no sweating from the plastic, unlike regular plastic bags. It's BPA-free. The material is eco-friendly and recyclable. And we made sure that all the corners rounded and not pointy and very flexible even when it's frozen. It's FDA compliant, meaning it is exempt under Class 1 general controls. Now, regarding the gel packs ingredients that we have and materials, we made sure that it meets the entirety of safety measures. It is excluded from the California proposition list of banned synthetic chemicals, which causes cancer, birth defects, and reproductive harm. But most of all, our gel packs are very cost effective in comparison with gel packs that you see in Amazon or other websites. And you can either dispose it immediately or use it over. To put it simply, Pure Heart will be covering and servicing the whole entire healthcare web. If we can apply these gel packs, whether it's cold or hot in treatments, we can beat those studies because we have this medical device available at home or work. Pure Heart is here because we want to be part of your healthcare best practices. We want to connect with you, and we hope that you welcome Pure Heart with an open heart and embrace this new innovation. And after all, we have one simple common goal, and that is the safety of our patients within the healthcare lab. Thank you so much.
Thank you for your presentation.
Everyone must be happy right now.
Okay.
I know that. No question, I'm sorry, question, but I'm sure that you'll be still available to answer questions from your audience. We apologize for the downtime to device that disturbed our flow of the conference, but however, we'll compensate for that. We'll be finishing on time. So.
Thank you very much. Thank you.
Now time for the lunch break. We'll come in 1 hour. Sit down. So come back 2:20. Before that, please, if you don't mind, we need to have a group photo before the lunch.
Onu yerde bile yapmak çok zor. Tamamen havada yapıyor.
Adamın tipe bak ya.
Oyunculuğu çok güzel yani. Oyunculuk yapıyor şu an. Onun orada kısmı hiç kamera var mı? Çok hoşuma gidiyor. Ben göbeği bile tak.
more.
Same thing with the student. I can go. Yeah. Yeah. Ladies and gentlemen, welcome back. I hope you had a refreshing lunch break and much valuable networking time. There's a series of engaging sessions coming up, and we are going to start with a thought-provoking session on Destination Medical Center, establishing nursing best practice by building a nursing model of care by Ms. Nina Sargent from UAE. Please join me in welcoming her.
Hi, well, turn that on. Can you guys hear me? Is this a comfortable distance from the mic? I don't want to be blowing anyone's eardrums out here. So I should make the correction. I'm actually not from the UAE anymore. I'm from the US, and I truly always was. I work for Mayo Clinic. About 4 years ago, we started a joint venture in Abu Dhabi with the Abu Dhabi Health System. So there were two parents of this joint venture. That it was Saha and Mayo Clinic. We activated a hospital which has about 3,000 employees. We had 400 beds. And I was in a hospital administrator there. However, I started out during the activation as a health systems engineer. I was brought over to work with the specialties, specifically the surgical specialties, to activate both their surgical practice and their outpatient clinics. I was also the administrator for anesthesia. And I did that And I did the activation for anesthesia and the CSSD as well. I have a background in Lean and Six Sigma, of course, but I also have a business background. And the reason I got employed by Mayo Clinic about 25 years ago, they wanted to teach their staff and ingrain with their staff some of the management best practices. So I was hired by the nursing director of surgical services and also their administrators and physician leads. And I was embedded with the nursing team for about 4 years. And it was a really wonderful learning experience, so much so that I was able to help aggregate those surgical services here in the UAE later. I have an MBA. I have dual specializations. I have that healthcare management specialization. I also received a specialization in international business. All that being said, back 25 years ago, my boss, who was that surgical services director, that nurse, asked me, Nina, have you ever thought about going into nursing? And I thought she was just polling me because we had a nursing shortage. But in retrospect, I think that that would have been like the ultimate in the arsenal for my career if I had that on top of some of these other management learnings and expertise. So I do rely on my nursing colleagues very much, and I have a tremendous amount of respect for them, as well as the physicians and other clinical staff who really are able to put the needs of the patient first. With that, I wanted to ask you all, who is a nurse in here? Okay, nursing. Yep. How about physician? Okay. Healthcare management. Something else. Okay. So as we can see, the majority of you are nurses, and that doesn't surprise me because in the hospital and in the clinic, guess who the majority of staff are? It's the nurses. And that's why I was really excited to partner with the CNO and all of the nurses at SSMC to create this nursing model of care. And I'm going to tell you a lot more about that right now. Hopefully. Okay. So I mentioned a minute ago that we were trying to create, well, I didn't mention what we were trying to do. I mean, I said we opened a hospital and we started a joint venture, but we were trying to create Mayo's fourth destination. Mayo has 3 destination medical centers in the United States. One is in Rochester, Minnesota, which is where I'm from. One is in Arizona, and one is in Florida. So we wanted to catch up to, I think, places like Cleveland Clinic and really expand our ability to help around the globe and help people from this region have quality health care at home or at least near home. So SSMC, or Sheikh Shahood Medical City, was intended to become the leading integrated healthcare destination in the region. This is a picture of SSMC, all lit up at night. Huge, beautiful hospital with the outpatient clinic up front here and ED off to the side. It had all of the problems that Chandra was talking about earlier, and I wish we would have known her about 3 years ago. But in any case, it's a pretty massive facility, as I referenced before. And in order to really transform it, we had to make improvements. We brought a community hospital, which was next door to this, into this facility. And we were trying to make it this excellent hospital. And we already had some processes that we transferred over from the other hospital. We had great staff we transferred over from the other hospital because Saha, the health system, had already started to consolidate their best and brightest to work at SSMC. We also had some Mayo employees. But I will tell you what, we have a lot of improvements to make and a lot of new processes to, this is really difficult. I'm going to use the podium. A lot of processes to even create to really raise us to a destination medical center level.
And how would we do that? Who's in all of those service areas? It was everyone who was raising their hand before, the majority of you. It was the nurses. So how do you get to become a destination medical center? I mean, you can have all these great staff, you can have a beautiful facility, and you can have a great heart and a great idea, but you really have to have your approach to becoming an organization of excellence and really delivering the highest level care in the world to the patient. And that requires a model of care. It really enables excellence in everything. All of those policies, procedures, processes, they all fall under this. So what we did, knowing that nursing was so very important in all of this, because you are touching you are touching the patient, you are interacting with the patient every day. We assembled a team to design this model of care. And it was really a multidisciplinary team from the start. We had a physician lead who helped advise and provide input. In the center there, you see some of these administrative folks. Myself and the woman next to me with the mask on is actually a communication specialist, because once we had this designed, needed to have a change management plan and a communication plan in place where we could get the message out to all of our staff about what our approach was to nursing and really help everyone embrace it. So a nursing model of care, I want to make sure I hit all the key points here. It's really a set of guiding principles. And generally, organizations will have a model of care for their entire organization and their physicians, but then also a nursing model of care. And those are the guiding principles that our nurses can use when they're interacting with the patients to help raise the quality, safety, and experience for the patient, and ultimately the outcomes. So the first step, and I feel like I skipped a slide, did I? I don't know why that's not working anymore, but we'll just keep plowing ahead. So when you look at a model of care, the first thing that you need to do is ensure that you have organizational alignment and strategic alignment, most specifically. So you look at what's the mission of the organization, what's their vision, and what is the overall model of care. So that's exactly what we did. And we also looked at what our values were, and came up with a definition for it. We did quite a bit of benchmarking as well, not only with the Mayo Clinic, but with other magnet organizations, and came up with this set of objectives and guiding principles, which I'm not going to read through, but I do want to point out that it's really important to listen to your staff, and I'm going to get to that in a minute. Actually, the nursing staff, but you have to have something that's going to be implementable. And what we did to make those principles and those objectives and goals implementable is we started to organize them under these 4 different pillars. We knew that we wanted to have a person-centered approach based on our research. We knew that we wanted to have team-based care. We knew we wanted to have really high-level trust and quality, and we wanted to have value-added care. Shonda talked a lot about taking out those non-value-added components, and we definitely appreciated that. And I'll tell you why even more in a minute. It wasn't just the nurses who were represented on our committee who were telling us this, and the nurse leadership, but we actually, ended up polling our entire nursing staff, all 1,000 nurses, to understand where their pain points were and where we needed to focus. And interestingly, they all ended up falling under or within those pillars, and that helped even guide us in designing those categories. So delving down a little bit deeper, person-centered care, that means that we're going to respect individual values and choices and really promote continuity of care. At SSMC, we didn't even have like a welcome guide for our patients. So as part of this project, we recognized, okay, if we're going to have person-centered care, we better be able to orient them to their hospital stay at the very least. Wait a minute, do we have decent education materials? Well, we talked to our nurses, we talked to our patients. Guess what? It was not adequate. We talked to our providers. So those were some of the items that then fell underneath our person-centered care pillar. Our team-based care was obvious, maybe. I flew through why I think Mayo Clinic is number one, and I'll tell you right now what I think their secret sauce is. And you might have seen that picture back a couple slides ago of some destruction. Mayo Clinic came about back in the 1880s when a tornado went through Rochester, Minnesota, and absolutely devastated the whole town. And the entire town pulled together specifically and really the Mayo family, those physicians, and the Franciscan nurses came together to help treat all of these poor people who had been harmed by the tornado. And just a couple years later, they came up with the idea of creating the clinic and also St. Mary's Hospital, which the Franciscan sisters volunteered not only to provide, but also staff with nurses. And they created a nursing school and became nurses. But without that team-based approach way back in 1880 and coming together like that, Mayo Clinic would not be what it is today. And you see it in their model, right in their model of care. And that is we foster collaboration and a multidisciplinary approach. So we really, really wanted to break away from siloing into different specialties, siloing into different roles. We wanted to bring that team to the patient so we could bring the best care to bear. So that's why one of our pillars was team-based care. And I'll tell you about a few of those initiatives in just a moment. Trusted quality, I mean, that's a no-brainer. I mean, we always want to do no harm, but really we want to address the needs of the patient and put them first. We want to give them the best care possible. And to do that, we have to be able to have high level outcomes, reliable systems, so we can deliver those outcomes. We need to be able to measure those outcomes. And we need to do that in an efficient and effective manner, or we won't have an organization going forward, which gets to that fourth pillar I'm talking about. That goes back to value-added care. We need to cut the waste out on the units, in the ED, in the clinic, so that we can make it a system where we can focus on caring for the patient. And again, I'm going to go back to what Chandra was talking about. We need to look at how we have things laid out. If things are not laid out in a way that our providers can give the care they need to, our nurses can deliver the care they need to, we need to adjust it. If something's happening that doesn't need to happen, we need to take that away and either replace it or just go without it, because it was never necessary in the first place, as you pointed out. And I'm going to also pick up, 4 minutes. I'm going to pick on Najim for a second, pick on him. I'm going to recognize him. Yesterday, when he was talking about the fundamentals of care, that's probably the pillar right before this. We need to really know our fundamentals and be able to measure what what we're doing with those fundamentals. Are they delivering those outcomes we want? And that's why I was excited by your presentation, because you can drill down on that with your methodology, your study methodology. So I won't linger here because I do have 4 minutes, and this is probably the best part. And I wish I was still at SSMC so I could show you this this survey we developed. It was the easiest thing ever. Make it simple. We had Teams. We were using MS Teams. They had a survey tool within it. We said, hey, we have a distribution list for every nurse in this hospital. What questions do we want to ask these nurses so they can tell us about what their pain points are and what kind of initiatives we need to set up underneath these pillars? So we did, and we sent it out, and we had like everyone respond. So it was great. And guess what it told us? It told us that there was a lot of unnecessary documentation. It told us that we needed to be using nurses so they could practice to the top of their license, and we needed to be leveraging patient care assistants and finding ways to automate and cut out the waste. So we started to tackle that with several initiatives. I will say several. There were actually 27 initiatives, and they were grouped by pillar. I've already talked about some of them. Team-based, we did some focusing on leadership and staff grounding. We instituted a daily team system, which was for everyone, but it really facilitated that communication Chandra was talking about at the unit level, and it tied our strategy to what was happening at the unit level, and it bubbled up those issues our staff were struggling with on the floors, out in the ED, in the clinics, to management, but it also gave them the tools to tackle things on their own. Finally, what gets measured gets managed. If you don't want someone, if you don't want your patients being erroneously disposed to maybe being admitted or discharged, then don't use that measure anymore. Pick the right measure. But for all of these initiatives, there are metrics, and we are measuring them, and we are meeting on a weekly and monthly basis to watch that, and it is guiding us. So just this, as the structure was really important. We had to have the definition, the change management, project planning, education. We educated it was 1,500 nurses by the time we got through it, but we started that as a beginning step. We did some of those quick wins, and this all continues today. So just to wrap up here, there was a 99% pass rate with the education. The nurses loved it. And we really got positive feedback. I think they really felt empowered. And we felt like for the first time, everyone was using somewhat the same fundamentals of care and the same approach, so we could ensure that same level of quality was being delivered. And we saw our patient satisfaction rate with nursing skyrocket after we instituted this program. So just to sum up, the model of care aligns SSMC's vision, mission, and strategic plan. And it was developed by nurses for nurses. Yes, there was administration involved. There were health systems process specialists involved because they were supporting. There were physicians involved because they're part of the team and they had great feedback and guidance. I'll just finish up here. I just want to stop at the end here and thank my team, the MyCore team who put this together. I wish they were here today, but they're still all hard at work at SSMC. So if you'd like to learn more, I'm on LinkedIn. I'm happy to talk about this. I'm also very passionate about it. And I really think the work I'm hearing about from the people in this room is very exciting, and keep up the good fight. Thank you.
Any questions from the audience?
I've got one question. What education did the nurses take?
We developed an entire program for them. We developed a handbook around the pillars, and then we developed a program. So some of it was like also instituting a nursing journal club, nursing grand rounds, but the actual program that every nurse went through was very specific and all around these 4 pillars.
Any more questions? Okay, thank you, Nina, for such an insightful presentation. I really liked your pillar for nursing model. It's a robust model. Here is your certificate. So I'd like to invite our next speaker, Dr. Eloise Phillips from UAE. Please join me to welcome her. Her speech is on nursing and the journey to advanced practitioner.
Hi. Good afternoon, ladies and gentlemen. It's absolutely a pleasure to be here today and some really inspiring talks given earlier. Thank you very much. Firstly, I'm going to start with an apology. I'm so sorry. I've been really ill. Actually, it's a really bad pneumonia. I'm only just getting my voice back. So apologies. I do hope everyone can hear me okay. And I'm sorry if I have to stop and if I squeak a little bit. So apologies. So
bless you and thank you for being
I just want to talk a little bit today about nursing and the journey towards advancing practice. What do we see at all? Oh, there we go. So I'm really hoping that sort of my journey throughout my professional career as a nurse can really, you know, give people some ideas and things that they can actually look to aspire to within a career in nursing. And hopefully, you know, I can give some examples on the way that I sort of push the boundaries. And actually led to very much the changes and looking the things that we've been talking about today to actually push the boundaries and change the healthcare profession for the better. So firstly, just to sort of introduce, so when I talk about advancing practice, it's actually a defined level that clinical professionals work to. That's mainly started with nursing, but very much within the UK and in America and other European countries, it's gone on for that advanced level for nurses, pharmacists, physios, nurses as well, so other allied health professionals. But the key to advancing practice is really that the professionals need to have a master's in advancing practice and have really developed knowledge and skills to allow them to take on expanded roles and work within very much a defined scope of practice and work autonomously at that level. And very much as Nina was talking about models of care, it was very much a model of care that was used to transform the UK national health system. And very much is a pathway of care, so to speak, for patients as well. And it's basically about moving across professional boundaries. So nurses taking on roles that were maybe traditionally done by physicians in the past. And again, adopting new technologies, AI, and really giving nurses the career opportunities and allowing them to embrace to take on new roles. And just to clarify, you know, this isn't just about nursing, about clinical nurse specialists. I know we have lots of clinical nurse specialists working around the world that are experts in their particular area, but advancing practice has really been about autonomous in total patient care across a number of different domains. So here's a little bit about my journey. Shay will talk more afterwards about advancing practice in general, but hopefully give you some of the ups and downs and lessons learned, which I guess is what we're all here to learn about today. So very much, I think, with any journey we have in looking to transform healthcare systems and adopting new models of care, it is very much a roller coaster. You know, there's certainly been ups and downs, high points and low points. But certainly some of the things that stood out for me is certainly around how I and how we develop others for new skill acquisition strategies. So how do we encourage educational programs and continuous learning? Very much about overcoming challenges with any new models of care that we bring in. Of course, there's going to be obstacles and challenges that we need to develop skills to be able to overcome. Education is a really important part of advancing practice. You know, it can't work without it. And again, for that education, we need mentorship and peer support within clinical practice as well. And I think also as well, a little bit around career enhancement. Advancing practice is very much about giving nurses the opportunities to actually go further, do more, actually in clinical practice without going into management, without going into research or into academia, but it's about having more responsibility, greater career fulfillment, actually, and retaining clinical skills in practice. And certainly, you know, there's been good and bad about enhanced clinical competency, which we could probably talk all day about that one, but I'll briefly mention a little on that too. And again, as Nina said as well, we can't, as one of her 4 pillars, we can't do anything without teamwork. So again, as any nurse, as any advanced practitioner working in a healthcare system, you need a really coherent interdisciplinary or multidisciplinary team to be able to support you to do that. So just a little bit about me. I very much was always ambitious, starting off as a young nurse, so to speak. And these are just a few of the highlights of the places that I've worked in the past. I am an academic now, and I teach and educate others, but I still do clinical practice when I go back to the UK as an advanced nurse practitioner. I'm now a manager as well, working within academia, managing other academics. But throughout my career, I've worked within healthcare systems, both in the UK and here in the UAE as well, and throughout a number of different universities, also advising and developing policy around advancing practice, and also giving advice and expertise to our regulatory body within the UK as well. Oh, was it going to move on? So, I mean, this is my career in a nutshell, so to speak, about, you know, just a few of the positions I've taken on and how I have moved throughout the grades in nursing. I started off working in ED. Absolutely always loved ED. Yeah, exactly. I know some of the things you were saying very much resonate with me, certainly in the UK with our public healthcare system. And then I moved into more of a community role. So we have in the UK what we call district nurses, that actually nurses that go and visit patients in their own home. And at that time, very much we had a lot of burden in the UK healthcare system in the fact that we needed to keep patients out of hospital. And our community nurses was a way that the government was trying to do to actually deliver on that and reduce our number of admissions. So I very much worked my way up through the grades, you know, from learning the skills, doing development programs that others have talked about. I went on to do additional qualifications, became a team leader, obviously moving into more of a management post. But I knew I always wanted to be clinical. You know, I loved patients, I loved seeing patients. And advancing practice was only starting in the UK around that time, around, you know, the early 2005, 2006. And I was offered opportunities to be able to expand my skills to do that. But very much throughout my career, I've moved between academia, clinical practice, nursing management, but also still sort of retaining my roots very much. But, you know, certainly it's very hard to put in a slide the last sort of 25 years. I'm older than I look, by the way. So these are just a few of the credentials really that I've had to go through in my time. Obviously doing a degree in nursing, then I was very lucky to be one of the first nurses in the UK to do independent and supplementary prescribing. So we basically can prescribe anything on our British National Formulary in the UK, obviously within our scope of expertise. I then became a practice teacher, which was a regulated post in the NMC with our regulatory body, that I could train and assess nurses within practice as well. I then went to focus on very much looking around chronic disease management, which then led into my master's in advancing practice, and then going towards more into research, and then obviously doing my PhD. Still, we continue even as academics, you know, still keeping up to date, and still we have professional qualifications in academia to do now, and there's a number of different fellowships that we continue to try and achieve as well throughout our career. So just a little summary there. But I think for me, very much, you know, Nina talked about pillars. I'm going to talk about pillars. I like a lot of pillars in nursing, I think. But you know, the main things throughout my career is always been wanting to stay within clinical practice, being that expert, autonomous clinician, but also teaching and educating others. I've loved talking, you know, from the moment I first qualified. I've always had student nurses, had student doctors, had GP trainees, had a variety of different educators that I've worked with throughout the year. But I also wouldn't have got where I was if I didn't have the support and expertise and mentorship from others as well. You know, again, I talked about those management and leadership positions as well. And I also have done research, doing my PhD, and still actively do research as an academic today. So again, you know, that just highlights really. So in the UK, we have the Health Education England Advanced Clinical Practice Competency Framework, and that's actually based on these 4 pillars that I introduced. So clinical practice, education and research, management, and forgetting the last one, research, obviously. Education, sorry, I must have this. Clearly still the infection in me, not septic quite yet. So these have all resonated, and I think advanced clinical practice really sums up the fact that it gives people the opportunity to actually train and gain skills and expertise across these 4 areas. So for me, some of the key things learned very much was the fact that we can't do any of this without education. You know, new people moving into an advanced practice role do need some skills and expertise. In the UK, we wouldn't accept people onto programs unless they'd had 5 years clinical experience and were a certain grade, and that's still the case today. But they still need assistance and help with that advancing education, and that program needs to be able to cover those. So now in the UK, we credential our Masters Advancing Practice programs, and that's done by Health Education England. And so there's certain programs that are known to meet the characteristics and the requirements and standards for advanced practice. So there's, again, some form of regulation around that. I think it's really important for people moving into advanced practice roles, and when services are considering trying to develop it, really looking at allowing people some time to be able to do these skills and expertise. So training posts and apprenticeships. In the UK now we have apprenticeships, so people have protected time, they get paid their salary, they can go to university but also continue with their clinical practice and their job to be able to train and move and advance up to an advanced practitioner. I think individuals, you know, as well as organisations, need a skill acquisition strategy. We now have lots of portfolios of evidence that people put together. You know, you don't just get to this point without lots of time and practice and exposure to certain conditions to be able to become more autonomous and being able to treat and seeing patients on your own. And really, I think it's having the ability to move to that autonomous mindset as well. I think, you know, very much us first nurses that moved into these posts in the UK were very much those who wanted to challenge and wanted to change practice and to take on those roles. So again, a certain level of confidence in your ability is needed around that as well. But without anything, yes, we can teach courses at universities, but without people having hands-on practice of clinical skills, you know, then they're not going to be able to build the expertise they needed. and allow that time to build and actually apply that theory to practice and real world situations, really. And very much, I think education, is a key pillar throughout this as well, because we're not only looking at training people to be advanced practitioners, but actually making them individuals who want to pursue continuing professional development, keep up to date to ensure that they're safe practitioners as well. I think we also need to address, if we're looking around advancing practice, and certainly some of the challenges I've come across in my career, when I've been setting up services in the UK, is very much that there are challenges for healthcare systems, but there are also challenges individually. Some of the things I talked about, confidence and opportunity, might be there for individuals, but healthcare systems and regulators need to be there to support it. Sometimes some of the challenges we found that systems weren't ready to support it, weren't ready to allow nurses to move into an advanced role to work on their own. Often, we still have in the UK, people are very confused about roles and scope of practice of people. And, it's something that's commonly reported on. Am I seeing a physician's associate? Is it a nurse? Is it a physician? What level of doctor is this? Is it a consultant or not a consultant? That's always very much been a challenge, and is something that really had to be addressed when looking at implementing and advancing practice model of care. Often we find there's cultural barriers as well, so patients might not be accepting of seeing a nurse instead of a doctor because they think the doctor is the best and most qualified person that they should be seeing. But actually, the literature we know, so the work that we've done to look around evaluating advancing practice, shows the exact opposite. Patients actually like seeing advanced practitioners because they give them more time, they actually listen to them, and they provide that patient education that we were actually talking about, which often physicians don't have that same patient-centered approach. Specifically, very much looking at chronic disease management, for example. Again, there's been very often a lot of diplomatic interrelations. I can talk through some of my challenges. It's certainly not been an easy journey implementing advancing practice in the UK. I had it said to me on a regular basis when, trying to join ward rounds or rounds at the start of end of a shift, we can't have nurses prescribing. They're unsafe. They're going to kill the patients. But again, evidence says otherwise. Oral evaluations of actually advanced practitioners prescribing is that we're actually safer because we take time, we're more cautious, and we think very much about our evidence base before making a decision. We have a number of doctors who think we're taking jobs off them, and that was very much something that was said in the beginning, but that's not the reality. Advancing practice was brought into the UK and many other European countries actually because we have a shortage of doctors. There's a big gap. We don't have enough to see the number of patients that we have. We have a growing elderly population, patients with multimorbidity. They don't have the expertise to treat them. So actually upskilling the workforce that we have is one of the most beneficial ways in doing that. Patient acceptability. I never had a patient challenge me and said, I'm unhappy to see you instead of a doctor, because actually their satisfaction often in consultations was often a lot higher. Again, when we're looking at one of the biggest challenges, we've been looking very much here in the UAE and in some other Middle Eastern countries about, can we adopt advancing practice roles? Again, some of the problems here is around costing and insurance. How does it get charged? Who's it get charged to? Is it going to be lesser? So those are some of the problems. And again, I'll tell you a story about when I wanted to do a PhD. So I did my PhD when I was actually a clinician. I was an advanced practitioner. I was a team leader with about 30 advanced practitioners covering a very large city, second largest city in the UK. I asked for a career break to do my PhD because I wanted to be a chief nurse. And that was the way I saw to go to do that. I knew I needed a PhD. My chief nurse at the time said to me, why do we need doctors? Why do we need nurses with PhDs? They don't need it. I literally chased her around the car park, and when I didn't get an answer from her, I went to the CEO. So maybe that's a little bit about that confidence and skills and passion, but unless you drive the discussion forward, we're not going to get to that point. And something that I'm very proud of is the fact that my master's dissertation actually led onto my PhD thesis and led to a change in service delivery within the UK, within the NHS, the way that we deliver community health services. And I think really looking at how we overcome, am I okay for time? Yeah, I'll go for time. You know, to overcome some of these challenges when we've been looking at implementing new different models of care, you know, it needs people with resilience, that team that Nina was talking about, those people that are passionate about it, you know, and not giving up as well, you know, having that drive and determination. There'll be good and bad parts, but we need to keep going. And as I said, buy-in from leadership and management. We're not going to get it. Any changes to nurses and other allied health professionals moving on to advanced practice roles if we don't have that buy-in as well. And time, you know, I couldn't expect as a 25-year-old to suddenly be an expert autonomous advanced practitioner by 26. It wasn't going to happen. You know, it takes 5, 10, 15 years for people to develop those skills. So it's a journey. It's a transition very much. So just briefly, you know, another thing I found, was that 4 minutes? Yeah. So mentorship and peer support was one of those really important things that I needed. I had some absolutely expert doctors that I worked with who were my mentors throughout my years. And I like to think that I've given that back to others. And very much having that, you know, as we're talking about journal clubs, clinical case reviews, having that open forum to discuss patients and what we would do as a clinical cohort together, and having that be able to do that openly. As I mentioned before, you know, education, we do need to select the appropriate people to move into these roles with the academic ability, and to be able to have that master's qualification. And again, as I said about that long, ongoing, lifelong learning, you know, in healthcare, it never changed. We have to keep up to date. Just to rush through the final few ones. But, you know, I think for me, very much looking back at my career and, you know, trying to push the boundaries of advancing practice in the UK, you know, I was part of writing the Health Education England's Advanced Practice Framework. I set up one of the first services. You know, it's because I loved what I do. I was passionate about patient care. I wanted to continue having a clinical role at a senior level, and advancing practice, I saw that as an opportunity and way to do that. So I do very much hope that we can continue discussions around the world, which I'll talk a little bit more about that after myself. But just for those of you who do live locally, I now work at the University of Birmingham, Dubai. We have a lovely big campus and academic city. And about 2 years ago, we launched our MSc Advanced Practice in Healthcare. It's a program that covers all those 4 pillars, obviously without the prescribing, because we can't do that here in the UAE. And certainly I've been very involved in conversations with the Emirates Nursing Associations, a number of the other different Emirates associations and the Ministry of Health and DHA, of looking at how we can actually look at advancing roles for nurses here in the UAE. So if anyone's interested, wants to see our wonderful campus, please do come along to one of our open days. It is that gorgeous. I know it's out in Silicon Oasis in the sticks, but it's lovely. And do, you know, link up with me on Twitter, LinkedIn, or do drop me an email at any point. And hopefully if anyone, you know, locally, even in Saudi, I've had conversations with Saudi as well, certainly with a number of hospitals there looking at developing advanced practice. So thank you very much for your time. And I've got through it.
Thank you, Dr. Teresa. Thank you for questions.
Okay, thank you for bringing up this topic, of course. Because of the increased demand in the medical field, we really need the nurses to have this sort of clinical experience. And I do see that recently the role of the nurses have evolved greatly, and they now become very expert in the clinical field and management. I just need to have an example for the role and the task of the advanced, the clinical role, you know. Can you give an example?
Yeah, so for example, I worked in ED. Shay also worked in ED as advanced practitioners in the UK. So we were actually part of the medical registrar rota in the UK. So working at the sort of mid-level doctor, We
Yeah.
saw, we triage patients, we are the
Triage,
major, taking history, doing absolutely ordering, we can order MRIs, chest x-rays the same as everyone else, and being part of the MDT to make the diagnosis, prescribe what's needed for the patient, make the decision on admission or discharge, and follow up. So yeah, that whole patient care package.
Yeah, thank you. We need really people like you.
On behalf of everyone, Doctor. Question? Okay, last one, huh?
I'll take this down for you, Michelle.
This isn't a question, it's just to add on to that. The mid-level providers is what I was talking about earlier, was a huge thing for the emergency department to support our physicians. I think the one thing we have to make sure we do together, though, because a lot of physicians will have a hard time with this, is you have to go in a room, work together on the protocols, and give them strict direction, and a little wiggle room so that they can take care of the patients, but they usually care for the lower acuity patients and assist you with those level threes, those long.
So I disagree with that. So in the UK, maybe that's your experience in America, but in the UK, that's very different. So we have advanced practitioners working in ICU across all areas now in specialities in ED, and you'd be taking full responsibility for that patient care. Of course, working within what we call a scope of practice and our health education advanced practice competency framework for people to be able to practice, they have to have met all those competencies within their area. So no, they wouldn't be doing it as restricted a scope of practice unless they were newly qualified, initially training. But if you're talking about the advanced ones like Shay and myself, who worked for a number of years, initially it would be doing that. But again, we would either be leading the MDT, taking the ward rounds as well. No, so as an AMP in the UK, I can discharge patients from hospital. So I know it's not the same everywhere, but certainly with my settings in Birmingham in the UK, we could do that. Yeah. So
we have one more.
Hi, I'm from Oman, and just wanted to share our experience. We do have some rural areas where we have the primary healthcare centers. And when you were talking about the system challenges, that struck me because we have something really similar to that. When we introduced the concept of advanced practice nurse for the policymakers and decision makers at the ministry level, they were very hesitant to implement it, as you see the case here in the UAE as well. But they were very much happy to give nurses in the remote areas a list of medication that they can prescribe and dispense, and because they're the only ones working in that health center. And because they don't want to send a doctor to that health center, and that would be more, it would be costlier for them. For that part, but as a nurse practitioner, they're still against it. So we're still working, fighting, and hopefully one day we'll get to it. We have all of our documents ready. Wow. Hopefully we'll be sending our nurses to you as well.
Yeah. Oh, well, no, certainly. I think that's amazing to hear that you already made that step forward. I certainly know in some of the hospitals in Saudi as well that they're really eager to bring in advanced practitioners. But again, it's hard to look at the regulation and then get everything, officially signed off as well. But yes, you've got my email address there. Any help you need to help with the ministry, let me know. More than happy to.
Thank you, Dr. Phillips. On behalf of everyone, I would like to thank you for sharing your knowledge and experience. Here's your certificate. Okay, so our next speaker is Professor Bruce from UAE, and he'll be speaking on the topic Unveiling the Value of Advanced Clinical Practice in Healthcare. The stage is yours.
Good afternoon, thank you. Is it better? I'm sorry, I have to walk around, I can't sit still and stand behind a podium, I find it really, really difficult. I just want to echo what Eloise has said. As an advanced clinical practitioner, My speciality was ED. I was very lucky in my career to be on the pilot of developing advanced clinical practitioners in ED. So my experience was that of, yeah, same as Eloise, but by the end of my time in ED, before I came here, on a night shift, I was the lead clinician. Okay, I could run that department and make the decisions for that department as a nurse. Okay, I did my masters in advanced clinical practice, but we also working in ED, we had to do the same portfolio of evidence as a specialist training 3 registrar doctor. So ultimately, you can go a long way with nursing, you really, really can. Your practice doesn't have to be limited, it really doesn't. The sky's the limit. Back when I started my career, I would never believe I could be studying a resource, leading resource, but I didn't believe I used to be able to prescribe any drug I wanted, procedurally sedate, pull limbs, push bones, do minor surgery. I didn't believe this was a thing for nurses, but it is. And what I'm going to talk about today is very much, we're on the cusp of developing that in the UAE. We are. And there's no reason why, as a nurse, this shouldn't be an aspirational thing. The first step is education. The next is buy-in from organisations. So that's what I'm going to talk about today. So I could say we've got a bit of an overview of what we're going to talk about. But unfortunately, as an academic like Eloise, I tend to go off on a tangent a little bit. I will try and stick very much to what the overview says, the current healthcare landscape, what the UAE strategic care objectives actually are. I might not cover what advanced practice is, because Eloise has already covered that, and I might not talk at length about what the 4 pillars are. I've never been a leader. Leadership is part of advanced practice. I'm very much, I consider myself a clinician and academic. Leading people's not my bag. I've got a bit of ED. Okay? So, we're also probably going to look at post-implementation strategy and the conclusion. Whether I get through all that in the time frame, I'm not 100% sure. I think what's interesting to know is that in the UAE, as well as anywhere else in the world, there's a group. They are the backbone of healthcare. Without a doubt, they are the backbone of healthcare. And they're a dominant force and pushing boundaries of what accepted in the terms of patient care, patient-centered care. I think what's important to note is that the past president of the UAE said it's a priority to ensure that nurse education is developed within the Emirates somewhat. But it's also really important to know that the World Health Organization as well said that advanced nursing practice and advanced nurses or advanced clinical practitioners are a priority within the MENA region to ultimately offset shortages of clinicians, doctors, and be able to provide the patient-centered quality care that we physically need in this region. So the current landscape in the UAE, what does it look like? The healthcare system is very much modelled on a private healthcare system somewhat. And as Eloise said, how do advanced clinical practitioners, advanced nurse practitioners fit into this? The problem with the MENA region, UAE, is that at times we have very much a transient workforce. 80% of the nursing workforce are expatriates. And again, by nature, it's very much a transient workforce as well. What we need to be able to do is understand and recognise that there's a national strategy framework for nurses in the UAE by 2026. And this 5-year framework for action outlines a roadmap for strengthening the nursing and midwifery profession. What it wants to do in this framework, 2026, is introduce nurse-led services. 5 years ago, you wouldn't have thought that were a thing. It wants to introduce nurse-led services and improve the quality and safety of the healthcare services that are delivered. It wants to overcome challenges of providing optimal healthcare whilst aligning with the 2026 UAE vision. And to do this, we must look at innovative solutions. And these innovative solutions are advanced nurse practitioners, not just specialist nurse practitioners, but advanced nurse practitioners that can work autonomously, see patients within their own right, prescribe and complete the whole holistic care process from them arriving at the door to departing, being tracked, managed or admitted. That's what we need to look at achieving. Interestingly, whether you realise this or not, there is licensing in place in the UAE for advanced nurse practitioners. In the licensing document, it also talks about prescribing. However, there's not any people room on the prescribing yet. And what I mean by that, you can't be licensed as a prescriber, as opposed to Eloise and I are. However, there is licensing for an autonomous nurse. There is licensing for that nurse to complete a whole package of care. And that's innovative. We've already seen the value of it in the UK, Europe, and worldwide. There are nurse practitioners, advanced nurse practitioners in Saudi already. And most healthcare models are moving towards utilising advanced nurse practitioners who are autonomous. So, moving on from that, any questions so far? Yeah.
Love your slides, by the way. Great deck. Obviously, the laws have to change here to get to that autonomous state. Yes. What we were doing in SSMC is basically trying to leverage orders and protocols to help people practice as autonomously as possible. What's your prediction for the laws to perhaps change?
I think this goes back to education somewhat. I think it will take time, and it's very much a work in progress. But I don't know what Eloise thinks about. Me, certainly, when you talk about protocols, as an advanced nurse practitioner, an advanced clinical practitioner, Yeah, there are protocols in the way that certain disease processes of pathology are tracked. However, that should be underpinned somewhat by evidence-based practice and best practice from evidence that you read and learn about. Protocols, if you're writing a clinical protocol, are quite restrictive because one size does not fit all. Human beings, by the very nature of human beings, are individuals. Your experience of pneumonia might be very different to Eloise's experience of pneumonia. What medication she might need might be very, very different to what you need and what treatment. You might need escalation to level 2 care. Eloise might need to be on a ventilator. I didn't think that would probably be the case.
This is also by the age and the comorbidities.
Yeah, of course it is. So, protocol's fine, and lots of institutions are very protocol driven. However, the key thing to recognise as an autonomous clinician, whether it be nurse, paramedic, pharmacist, midwife, occupational therapist, you use your experience, evidence-based practice to practice at that level. That's not to say part of my education, I had to complete a portfolio with evidence of what I was allowed to do and how I could physically do it, like any other clinician would. So I couldn't routinely just go into ED, into resourcing for a chest training until I'd been signed off by the consultant that I'd done 15 chest trainings. They were like, yeah, fine, you can pop a chest training, not a problem. Or procedurally sedation for the shoulder. You can't just wander in and go, yeah, I've seen Gilbert see in a minute. It doesn't work like that. So I understand what your question is, protocol-based care, but as an advanced practitioner, I think we need to remove that mindset somewhat. Because if you're an advanced clinical practitioner, you should be autonomous, but importantly, you should also be safe.
But I think in bringing in systems in the first place, we need to have these protocols and sort of guidelines in place and scopes of practice for people to work within initially. Because if you don't have the skills to train the trainees that you have, then yes, I need to develop health systems that we've managed to do that. Sorry, Spencer.
No, that's fine. Yeah, you're right what you're saying. It'd be 5-year vision, 10-year vision, because the advanced nurse practitioners now, with 5 years until they're fit for purpose, and it would be, but at that 5-year point, the numbers of people in training, the numbers of clinicians that are autonomous by themselves would multiply year on year, and the efficacy, their abilities, their impact on the whole healthcare infrastructure would be massive. It would be massive, yeah.
I just want to, yes. I just want to give an example here. It's not always when you just straight away follow the guidelines. Sometimes you have to take a critical decision, not by one doctor. Sometimes you need a multidisciplinary team to decide on something like when the benefits outweigh the risk.
Yeah.
Yeah,
I agree. Yeah.
For me, I just wanted to clarify what I said earlier because I think I may have been misunderstood.
Okay.
I'm a consultant and I go into different places.
Yeah.
And so what I was trying to convey is that when I do go in and talk about mid-level provider and advancing practices, it becomes rough. And what we do to bridge the gap is bring everybody in the room. And where we start is with scope of practices and protocols, making sure we clearly define everybody's role and responsibility, and then move from there. But to come in, saying we're advancing.
And I think Eloise has got that as well, didn't she, somewhat? Cool. How long have we got left?
Just 4 minutes.
Okay. I'm not going to get through the rest of my slides because I'm going to talk about strategic objectives. We're going to look a little bit about what is clinical advanced clinical practice. I think we spoke about that somewhat. I just wanted to make people in the room aware that it's a work in progress. You will be able to progress towards that. And if that's your aspiration in your career, in your nursing career, look towards it, grasp it, because myself, like Eloise, it's been a strange journey. It's been awesome. Has been awesome. I never thought I'd practice at the level of practice. I'm still continuing to practice. But I've also seen the benefits that advanced clinical practice and advanced nursing practice has, especially in remote locations as well. Because remote locations are not necessarily desirable for a physician. And that's true. Any other questions before I finish the phone?
Some of the case.
Yeah, I agree with that as well.
In remote places, they still can receive treatment.
Yes,
Especially
yeah.
in
Yeah. Any other questions? Anything that we've covered that you'd like to know a little bit more about?
So the floor is open for the questions.
And again, I'd like to just echo the fact that, yeah, we are running an advanced clinical practice, masters, University of Birmingham in advance. We'll see you all soon. Thank you.
Thank you.
Yeah, sure.
Okay, so what, if I were a nurse out in the crowd and I was sort of interested in what are the different options open for me in advanced practice? What are the types of
Supposedly, that's a really great question. Currently in the UAE, there's licensure for advanced nurse practice. However, it's not well defined. In the UK, it's reasonably quite well defined. I put myself an advanced clinical practitioner in ED. That's my bag. Acute, acute, acute. However, in the UK, you've got advanced clinical practitioners, advanced nurse practitioners running endoscopy, running theatres, running ITU. Any nursing field that you can think about now in the UK and in most of Europe have got it can be nurse led. It doesn't have to be physician led.
So if I got my advanced practice degree in the UAE today, it might position me for the new roles that are coming in that are more online.
Yes, but it also for the strategic management role, an education role, because the four pillars of advanced practice.
We are running short of time. You guys can discuss it later after the presentation. Thank you, Professor Bruce. Thank you.
Forward.
So I know after lunch, we do tend to doze off and I want to move energy in the room. So let's do a clapping exercise and I'll say some statements. If you agree, when I say go, clap once. If you find it interesting, clap twice. And if you find it exciting, clap twice. Okay, shall we start? Are you guys awake? Okay, so every patient deserves the best care possible. Go.
3, 1, 2, 3. Okay.
AI is revolutionary in terms of patient diagnostics and treatment plans. Interesting. We are all dedicated to improving healthcare outcomes. Cool, cool. So you guys are awake. Thank you. Thank you for being present. Now we are going to head towards our next speaker. And she is Shazia Iram, and she'll from Saudi Arabia, and she'll be
delivering a presentation on the value of certification in infection prevention and control. Is it significant? So the stage is yours, Mr. Ram.
Okay, where are the? The pointer. Yeah, hello. A very good afternoon, everyone. My voice is clear, I hope, or is just mic is coming? Okay. Okay, thank you very much to the chair for introducing. I think my topic is quite different among other topics, or might be it will be new for so many of you. My little introduction about my, as she said, my name is Shazia Iram. By profession, I am a registered nurse, and I have my master's in clinical psychology as well as in the business administration. I have a certification in infection control, and I have a certification in healthcare quality as well. Currently, I'm serving as an ambassador of Certification Board of Infection Control and Epidemiology, United States. So today I'm going to present on behalf of the board. So before going to start my session, I just want to know why certifications are important. Isn't it we have a degrees? Isn't that important? Okay. Even in any field, in any discipline, healthcare. Any thoughts on it? Even you are healthcare or non-healthcare, IT industry, quality engineering, why we go for certification, even we have a bachelor's, master's?
Juice on the direction.
Great, excellent. This is the sum of the talk which I'm going to share. Okay, this is the disclaimer from the board. These are the contents I'm going to talk about on it. That what is the certification, why we have to certify, what's the value of the certification and the process of certification of infection control, and what are the useful resources which can be used to prepare for it. Before jumping to the certification and its importance, just I would like to tell you about the board. What is CBIC? CBIC. It is a Certification Board of Infection Control and Epidemiology. It is voluntary, autonomous, multidisciplinary board. At first, it was established by the Associations of Professionals in Infection Control and Epidemiology in 1981. The mission of the board is to provide pathways to demonstrate and maintain competence in infection prevention and control. And its vision is a world free of infections through demonstrated professional competency. Why we need to certify, as doctors said, that to standardizations, to standardize, to meet the certain requirements. The CIC, which stands for Certification in Infection Control, this is the only standardized measurement of essential knowledge, skills, and abilities expected of infection prevention professionals in North America. Currently, over here is a 9,000. Actually, this morning I received our latest statistics from the board. It's more than 10,000 in over 47 countries. We have a certified people. Sum, I am not going to read all of that. The sum of this is the certification. What it does, it actually reaffirms that the study through the studied and hard work, which can attain internationally recognized level of knowledge in infection prevention fields. It supports future knowledge and skills. It obviously grants personal satisfaction. It promotes professional credibility, and it fosters a recognized professional community that helps to reduce infections in healthcare. And obviously, at personal level, you will feel so much confident while you are certified in a particular field. The purpose, the main objective of the certification in infection control is to provide the standardized measurement of current essential knowledge
which is required for the infection prevention professionals to implement in healthcare settings and to reduce the healthcare associated infections, to reduce the burden, the cost, and improve patient safety. If we look at the value, this data was published in American Journal of Infection Control. They concluded that the CICIPs, it supports the higher salary compensations. There are several organizations who want to hire the certified professionals, and they offer a higher salaries. It increased the job satisfaction through a structured career development framework, and it improves patient outcome. Obviously, when you are equipped with the evidence-based and updated knowledge and skills and you are implementing, then obviously you are reducing the risk of infections and improving patient safety. Certification advances evidence-based practices, and it is valued by the public within the healthcare industry. If we look at the impact in this, on healthcare, yes, the CICIPs, they have a stronger understanding than others who are non-certified. They are more likely to recommend implementing them in the hospitals where they work, and especially when the lead IP is a certified. Hospitals hiring certified infection preventionists were more likely to implement certain practices as compared to those who have a non-certified professionals. Okay, after passing the exam, the successfully who completed all the requirements and passed the exam, then the candidate will be eligible to use the designation of the CIC with their names, and they can use on resumes, business cards, letterheads, and other professional communications. However, the credential may not be used for product or other endorsements. Who certified? There is an agency, if I'm sure the people from United States know about this, the agency, National Commission for Certifying Agencies. This agency accredited the certification. It provides the impartial third-party validation that the civics program has met the recognized national and international credential standards for the development, implementation, and maintenance of certification program. Now moving to the process. What's the process of the certification? How the candidate can go through, and who is the one eligible? Before going into that, the process, the first we have to know, understand what is the difference between certificate and certification. Any volunteer would like to share? Certificate and certification. Is there any difference or none? Or is that same? Certification is
training, right? Certification includes training.
Exactly. Somehow, a certificate, as an example, is awarded following the completion of a course or a series of courses, or just attending something. By the end of this conference, or even the chairs, every one of us, we are receiving a certificate. It's a certificate of attendance, certificate of participation, certificate of speaking or chairing, whatever. So, however, the certification is awarded following a successful completion of a comprehensive examination process. And it provides an independent assessment of the knowledge, skills, and competencies required for the competent performance for a certain occupation and a professional field. Currently, the board offers 3 different types of the certifications, CIC, AIPC, and LTC-CIP. CIC is one of the most popular and mostly acquired and achieving the certificate among all over the world. It has initial certification and recertifications. By the way, every certification has a recertification every 5 years. So it's not only once you just get, you will stop it. Every 5 years, you have to go through again the process of examination. The second is AIPC, Associate of Infection Prevention and Control. The third is Long-Term Care Certification in Infection Prevention. I'm going to just give a brief about all of these. First is we will start with the CIC. It has 2 methods, initial certification and recertification. After every 5 years, there is a recertification. How the examination process work. The exam is a comprehensive job-related objective. It is a MCQ based, 150 questions. Out of those, 135 are scored and 15 are just pre-scored questions. The exam is developed from the practice analysis of infection prevention and control professionals in the United States, Canada, and many other countries. It is recognized by the EPIC and IPAC Canada as a standard of certification in infection control. Also, it is aligned with the recognized practice standards in the healthcare industry. The questions of the exam is only exclusively the property of the board. Okay, who will be the eligible to sit for this exam? There are certain eligibility requirements. For the detailed review, I cannot give each and every point. There is a candidate handbook available on the website of the CIBIC. You can search there, cibic.org. There is a book you can download and go through for the detailed eligibility requirement. However, if I sum the requirements, it could be at least the candidate must have completed a post-secondary education in health-related field. Included but not limited, so such as medicine, nursing, laboratory technology, and public health. This can be attained by even you studied through the private universities or government, it doesn't matter. Secondly, the person who is going to apply for this certification, he or she must have a direct responsibility for the infection prevention activities and programs in their healthcare facilities. The third is work experience. If a professional who is in infection prevention is working full-time in the department, 1 year experience. If someone is doing a part-time, then 2 years, or otherwise at least completed 3,000 hours of working in the previous 3 years before applying for the examination. These are the competency domains which are required. A candidate must fulfill, and they have a direct responsibility working in all these domains, which are essential. And I'm sure if anyone is working in infection control, they know these are our routine and daily the task activities. The exam is administered at the testing centers in United States, Canada, and many other international sites. Also, it can be via remote proctoring if in your country you do not have a testing center. So you can still do the exam by live proctoring. A 90-day window period is a time period from the application and before sitting in the exam. CIBIC has partners with the Prometric to deliver the exams in a secure and proctored environment. Prometric is the company for the test administration industry, and it provides the test development and delivery services. Testing is available 5 to 7 days depending upon the location when you have weekends in your countries. This is just an example how the Prometric testings looks like. Secure environment is there and continuously being monitored. This will be how ProProctor, suppose in case you do not have a testing center in your country, or it's not feasible for you to travel there, then you can candidate can take the exam at home, but there are certain requirements for ProProctor, and you can access the details on the CIBIC website also. That was about the initial certification in CIC. So what about the recertification process? As I said earlier, the certification is valid for only 5 years. So every 5 years, you have to sit again to recertify if you would like to maintain the designation and your credential of CIC. Otherwise, you're gonna lose it. You will not be more eligible to use with your name. You are certified. Just a minute. Recertification can be completed here. There are 2 ways via obtaining infection prevention units like education credits, or secondly the exam. Currently there is still open book exam for the recertification. However, from January 2026, the open book unproctored recertification exam will no longer be offered. So whether the candidate will go for the education infection prevention units or the initial certification again to maintain the designation. So what about the IPU? IPU stands for the Infection Prevention Units. In other terms, we can say it's a continuing education credits, which can be achieved by presenting at conferences, authoring publications, attending any local or national conferences, or many more activities. But make sure those activities must be related to infection prevention field. And if you go back to that slide, the domains, the competencies must be covered in those activities. Otherwise, your IPUs will not be eligible for the recertification. Here is the timeline. It starts with the professional portfolio, and the candidate can start their activities on the 5th year when they are due for the recertification, and they have to submit the portfolio by October 31. Then the board review the portfolio. If you are successful, you will receive an email within 28 to 30 days that congratulations, you are recertified and you can continue to use the CIC designation with you. Of course, with this, you will submit the fee also for both initial and recertification. So there are some helpful hints from the board that as whenever you have your activities, just start to enter in your portfolio, which is available under your account at the CIBIC if you are initially certified. Here are some examples of potential accredited providers, but not limited to. So the activities can be obtained through any of these. In addition to your local and national conferences as well. More resources are available related to IPUs on the site. What if you fail to submit the IPUs, the portfolio? Maybe because the IPUs 40 credits are required for the recertification. In case, what if candidate fail to submit on time, or maybe they are not eligible, they are not according to the requirement, the board will send you an email. They are not according to the what they need. Okay, you still have a chance for your recertification through examination before December 31. So that's why apply as early. Do not wait until the December 1. So you can start, if you are due for the recertification, the candidate, they have to start earlier. How the exams, the development, the making of the examinations. Developing the test, actually, it takes 18 to 24 months, and every 5 years, the board, they revise the exam content and the questions. It's been changed. There is a designated test committee which has a member from United States, Australia, Canada, Saudi Arabia, United Emirates, India, Egypt, Pakistan, and many more. I might not remember. So yeah, because the practices and the environment, the geographical point of view, the diseases, it differs. So they have members in the test committee from everywhere. So according to that, they review the content, and then they develop the items. So once the item development done, then there is another team who review the questions. Then they run the test, the beta test it calls. Then they establish the cut and pass score, and eventually the test completed. And after that, it will be published and will be open for the public.
Ms. Shazia, sorry for the interruption.
Okay. That was about the CIC. Now the second type of the examination is AIPC. This is very simple and very easy and basic for those who are interested in infection prevention field but do not have any work experience, no any job specific requirement, unlike the CIC, can go through. If you have an interest, as long as you have a healthcare background, nursing positions, medical technology, public health, this is the choice for you, the best choice to start from AIPC, because it doesn't require any specific requirements related to the job. This has 85 multiple choice questions, and also it has a recertification every 5 years like others. This is the third certification, long-term care certification. It was introduced in 2021. Same like the eligibility, as I said earlier, like CIC, you have to have a direct role in infection prevention field. And in addition to that, a person must be working in a long-term care facility before applying for these certifications. And the content outline is quite similar to the CIC. In addition, here they just added one competency domain, which is antimicrobial stewardship. Also, the recertification every 5 years in both ways, through examination and through obtaining the education credits. What about the validity of the exam? The exams are based on the practice analysis to ensure the content is current, practice related, and representative of the responsibilities of infection prevention and control. And the exam is highly developed under the guidance of the psychometrician and test development specialist from an independent testing agency. And testing agency oversee the scoring and the examinations. The exam is highly confidential because both CBIC and the Prometric, they maintain the confidentiality. Only the summary is provided to the candidates. The last part is how to prepare for the exam. There is a list of the resources available on the CBIC site. You can download if anyone is interested to go for the certification. According to that, you can create your own study plan, then review the reference material and make your own area. Just know your strengths and weaknesses. How much time? Usually it's 6 to 8 months requires the comprehensive study, and after that you can sit for the exams. Just some examples for the primary resources. EPIC textbook is one of the primary resources and highly recommended. These are the secondary. Lastly, what type of the questions usually come? There are 3 types of the questions. Recall, very simple and basic, just recall recognition, but they are only 15 to 20% questions in the exam the candidate will find. Then the application type, more comprehension, interpretation, and manipulation of the concepts. Around 30% exam depends on the application type of questions. The rest 45 is totally analytical. Integration of a variety of concepts, problem solving, and making judgments, case scenarios. The board neither produce nor endorse the products or material related to prepare any certification examinations. The person can access through the resources only and can create their own study plan according to their feasibility. Here are the resources where you can access for the exam materials, and there are some helpful podcasts from the CBIC which are available on the social media, Facebook, LinkedIn, Twitter, all available. Study groups are also very helpful. In the UAE, there are many study groups also who are training and coaching for the CIC certification, as well as in Saudi Arabia. I do run one study group as well since 2017. So we train, we coach, and just little only for 1 second. If we look at the statistics of the certified IPs outside the North America, Saudi Arabia is one of the top who has a certified IPs 348, the current latest. The second is the UAE, and the third is India. So great people is more growing the certification. For more resources, the address and the numbers of the CBIC office and the agency.
Thank you.
Nicely. Just I'm going to sum up this, that ending with this key message that certification is not a piece of paper which we have to hang on the wall in our offices and in home as well. So what do you think? To me, it's a commitment to best practices and professional development. I'm going to just end professional development. So similarly, the certification in infection control also, it gives a candidate dignity and a chance to stand out among the industry or among the competition in the job market. So you can showcase your skills. You are how skillful and confident in your field and expert, which is really indispensable in today's job market. And thank you. Thank you very much. Thank you for your attention.
Any questions from the audience? The floor is open. Okay. Okay. Thank you, Ms. Shazia, sharing your experience in learning. So we have two more presentations. Thank you everyone for your patience and your presence. A big round of applause for Ms. Shazia. Do you know sound heals? Anybody has heard about that? The traditional practice of sound healing? Music. Music and other sounds, like, for example, my grandmother, there was a traditional practice. She used to clear the stagnant energy in the room by clapping. So let's move the energy in the room by giving a big round of applause to Ms. Shazia. Thank you so much. We are going to move to our next presentation, and we have a poster presentation by Ms. Ranjit. Ms. Lijit. Oh, no, sorry. We have our next speaker, Dr. Nazia Usmani from UAE, and she'll be speaking on risk reduction strategies for code blue readiness and response in the outpatient settings.
Hello, good afternoon, everybody. I'm sure you all are already little bored, so I hope it will be refreshing now. So I'll just go to my presentation. Can you help me with this? Go to the slideshow. Yes. So good to see you, Dr. Seher. Okay, good afternoon, everybody. So today I will talk about risk reduction strategy, especially to increase readiness and response of code blue in outpatient setting. I'm sure we have Miss, I forgot your name. She's going to be happy. So we'll talk about code blue. Yes. So I will specifically talk about FEMA. I'm a quality person. So for me, implementation of quality tools is very important. So our focus will be on FEMA. So we will talk about FEMA and why FEMA is important for quality and hospitals, especially who are having JCI. And then we will go through a very good scenario that we created in outpatient setting, and that is the whole crux of my presentation. So are you all aware about FEMA? Have you ever heard of FEMA? Yes. Amazing. Yes. So who were the first country and first industry that used FEMA? Aircraft. No. You're close, but where exactly? Which famous agency used FEMA? It's linked to USA, so they use FEMA first. It was 1940s. Okay. I'll say it was NASA. NASA was the first agency used FEMA for the moon landing. So NASA did it in 1940s, and I'm doing it in 2021. But the thing is same. This is the beauty of science. We can apply strategies everywhere. So this is also used as a very important quality and patient safety improvement tool. So FEMA is a team-based problem-solving tool intended to help identify, eliminate, or reduce the negative effect of potential failures before they occur in system, subsystem, process design, or the delivery of system. What is the purpose of FEMA? Why we do FEMA? The acronym for FEMA is Failure Mode Effective Analysis. Can you all hear me? Am I loud enough? Okay. I'm sure quality people are very alert here. So FEMA is to prevent wrong processes and problems before they occur. FEMA is to predict possible failures. And FEMA also helps us to contribute to unintended adverse events and outcomes due to poorly designed systems, system failures or errors. So just remember what is Murphy's law. What he said, anything that can go wrong will go wrong. And we have seen it in healthcare, right? Anything that has to go wrong will go wrong. So the horses can move in the opposite direction, Also, if you never know your failures, you will never know your success. So that is why we have to first know where we're going to fail, fail forward. So this is the purpose of FEMA. Also, most of the hospitals now in Dubai, we are undergoing JCIA. This FEMA we applied for. I'm from Dr. Suleiman Al Habib Hospital. I'm sorry, I failed to introduce myself. Dr. Suleiman, they have a sister branch, which is an ambulatory care. So we applied the FEMA there, and also we are having a JCIA. So we wanted to use a quality improvement tool to show them, because JCI wants to have a proactive approach to risk management. This is what I want to, focus here, that instead of, having an incident reporting and then reacting to incidents, running, let's stroll around and do our risk assessment. So this is what FEMA is. Before something goes wrong, let's already know what is going wrong. Especially this methodology, why we choose this? We choose it for our Code Blue readiness and response. Code Blue is about CPR. So we could not, doing FEMA for the entire CPR process is tough. What is very important in CPR, Code Blue, is the initial phase, the first 5 golden minutes. So this is where we wanted to use this, this methodology. And there is a research, the most common places for Code Blue activations are phlebotomy rooms and halls of outpatient clinics, 68% times. So it's not your ER, it's not your ICU, it's not your inpatient, it's your outpatients where we have the most calls. The study analyzed that Code Blue forms, they showed that mostly it's about one hospital, where this is from a hospital where there were around 72,000 patients per month. So they found that in that 68.5% of the calls are from the outpatient settings for Code Blue. And also we know that survival rate is higher in patient who receive CPR in less than 15 minutes compared to more than 15 minutes. Brain death is expected to occur after 10 minutes of arrest. So that is why the first golden 5 minutes are so important. So our focus was first golden 5 minutes. How do we respond to a Code Blue arrest? How do we cardiac arrest? Also, now in non-acute settings like outpatient or ambulatory care, patient acuity is climbing. We're also seeing acuity patients with high acuity in the outpatient setting. So having a well-organized and well-trained staff need to be present at the same level as inpatient. We cannot, because this, the area where we did this Code Blue readiness FEMA, it was not linked to a big hospital. So even though we have DCAS in Dubai, we have very good ambulance, system is so good here. But if you fail in our first 5 minutes, it's no use having such an advanced, healthcare. So if your first 5 golden minutes are not handled very well, we will fail. The whole system will fail. So why did we did this project? What we did is we had a mock. We did a mock, mock Code Blue call. And we found the following deficiencies: lack of coordination, poor leadership and organization, lack of team member role identification, too many unnecessary personnel at the code, staff not aware about policies and protocols, Code Blue team for the particular day not circulated, no system in place to immediately contact the Code Blue. So these were all the failures we did. This is something known as in situ FEMA. It is little different from traditional FEMA. We actually create the adverse events. We do them, we simulate the adverse events. So this is an advanced type of FEMA we do in healthcare. It's known as in situ simulations. So Code Blue responsiveness and outcomes is the factors affecting outcomes of emergency are related to both patient and operational efficiency. American Health Association guidelines warns us that there in 2010 they set a highly 10-year achievable of 35% survival for IHCA survival. Still, we are at 20%. The study shows after Code Blue 20% of patients survive, and their goal is 35%. The ability to function effectively as team in crisis situation. We are very good as team, but when it comes to crisis, we are all going crazy, right? So this is why we need to do FEMA, especially in the crisis situation, the ability to function as a team. And mock drills serve as a guide to understand bottlenecks and hence various failure modes which can happen in real code. As I said, our focus was just first 5 minutes, how we make sure that within first 5 minutes the whole team comes. So this is where we conducted our FEMA. This is where we calculated our failure modes. So what actually happens in failure modes, when we talk to our medical director and CEO that there are issues in our code blue and we are an isolated ambulatory care. They said, okay, go and implement whatever you want to. I said, no, I want you all. I want to quantify our crisis and then I want to give you the quality solutions. Because as a quality person, unless we don't quantify our defects or our problem, we will not know the exact solutions to it. Exactly. We cannot improve what can. So, though I am a quality person, but for me, quantity comes first. Because when I measure something, then I know how to put the qualitative, analysis and risk analysis for this. So, objective of this project was to make sure we have a functioning code blue team, especially in outpatient setting. We don't have anesthesiologists 24 hours a day. So, have challenges with it. We have make sure in outpatient, we know it's outpatient, sense of urgency is not there, right? We are not ED, we are outpatient. We have to create a sense of urgency. Team performance and organization. So although FEMA model is commonly used in healthcare, it was supplemented with observation derived from C2 simulation. This is what I'm saying. This was little different from the conventional FEMA. This is not we sat on our tables and chair and we decided failure. We created a situation. We created adverse event, like imagine the adverse event. This is how we came to know what were the failures. And very important thing for all healthcare workers is to distinguish between latent condition due to decisions at higher organization level with actual failures. This was our main aim. What is hidden behind the layers and what is happening at the patient. So this is the 8 steps of FEMA. We set a process, we diagram the process, we brainstorm the potential failures, and then we quantify them. We quantify them by something known as risk priority number. I'll come to it. We identify the causes of failure and we redesign our system. Mostly FEMA, we always redesign the processes and the systems. So as I said, these were our team members. We made sure we had everyone in our team. This is how very important is to understand when any one of you will start a FEMA in your organization, maybe this will be a takeaway, understand your system, understand the failures. Okay, so the red side, the diamonds were our decision points. So patient was found unresponsive, witness calls for helps, first responder activates code blue, this is the process flow. The receptionist announces the code blue via dedicated emergency phone. Now, the red side, if you see these were the code blue. All code blue members were not called. We did not have a process in place to calling them. Code blue members, so there was no mechanism. What happens? Code blue team members will not arrive immediately. We had the page, we had these overhead announcements, but we don't know how functional they are. So what happens if no, there can be death of the patient. That's why I'm saying the first golden 5 minutes. If yes, we ensure ROSC, that is return of spontaneous circulation, is achieved and patient is then transferred to the nearest hospital. So these were our gray areas where we had to work. Then how we create, that's why we quantify the risk. We have likelihood, severity, and detectability. Likelihood means how likely it's going to happen. It can be from 1 to 9, means it can vary remotely or it's very high chance of acting. Severity, what is the impact? Impact can be a slight annoyance or it can be death. So 1 to 10. And detectability, that is why we do FEMA. Detectability, how well we are able to detect. That is what I was talking about, active and latent failures. So if it is 1, errors are very easily detected and never very hard to detect them. So we calculate the 3 things and we get an RPN number. So RPN, occurrence into risk, into severity, into detection. Okay, this is the RPN. So what we did, I'll go very fast. We identified 1, 2, 3, oh, sorry, 6, we identified 6 failure modes. Number 1 was lack of proper direction and sense of urgency to call for help. And the very important thing is what kind of failure it is. Was it active or hidden? Yes, it was active. We saw it when we did the mock. We saw that there was lack of direction. So this was number 1. Then we had the causes, we had the effects, and what actions we did. Delay in activating code blue. Number 3 failure was not all members of the code blue team reached the site. Then for everything we had a cause, we had an effect. So this is again an active failures. Administration of emergency medication, we found it as a latent. Okay, this did not happen, but we knew this will happen in future. Not all members of code blue team reached the arrest site within 5 minutes. And last one, then code blue call could not be heard in all key areas. Means here the announcement system was not working properly. And also excess crowd control. We found that when we announced the code blue, nobody knew who has to be do. Security did not know who to control. Imagine the real scenario. Everybody is coming. You have to give a CPR. Family members are there. So this was another failure mode that we. So security did not know whom to let in and whom to control. So these were the 6 things that I said for the first golden 5 minutes that we identified. We put a proper action, and you see our RPN is 1364, very high risk. This is your risk. Anything above 1000 is very risky when you calculate your RPN. So we are very high risk at that time. Then another thing, the delayed administration of epinephrine was associated with worse neurological outcomes in the patient. So that is why we also identified administration of emergency medication. Then we had a strategies for them, and then the implementation. So number 1 was we should have the code blue drill every month. Okay, and every month we had mock drills. Number 2, this is the heroes, really. Our heroes, nursing, doctors, the code blue team. This is how we would conduct our code blue every month. We would do analysis. We will do a post code blue drill. There was an analysis of it, what went wrong. Also training in emergency code. I'm sure all hospitals, they have emergency codes. Also very important thing that we did for our register, the frontline receptionist, we told them every day you have to check your, overpage these announcements. So they kept small, small things, they can make a big difference. So they would do a testing every day before they start their job. They had a registry there. All the areas should be responsive. So this was another very important strategy that we adopted.
What about the crash card? Do you review the crash card?
Yeah, next. Proper labeling of crash card. This is very important. When there is no labeling, you might pick anything. So this was reviewing our crash cards and labeling them, putting like where is the pediatric, where is the adult, especially in outpatient settings. Really, code blue calls are very challenging. You agree? There are healthcare providers here, right? Compared to, because we don't have a backup from hospital. Also, then we made sure that code blue team members are everywhere, so that we know, and they are called with the numbers they were given to the receptionist. They were called, and we divided them: the team leader, the compression, the airway, defib, medication recorder. Everybody knew their jobs. So this was how we just implemented few basic strategies, and then we redid then what happens in FEMA is we reanalyze our failures. We recalculate them. As we said, we quantify them. And mostly severity does not change, right? Severity will not change. The impacts of any actions will not change. But what we can change here is the occurrence and the detectability. So we change our RPN from, it was around, I'll come back to it. So it was around 1364 and 316. So this is how you reduce the risk, you quantify it, and now you're not a risky organization. Imagine not doing any methodology and just saying, yeah, we did it, yeah, we did it. But this is the proof. You quantified your risk, you brought it down. So the conclusion is in situ FEMA is a prospective method used by interdisciplinary team to uncover and analyze the failure modes and thereby identify and rank the failure modes in a way that realistic actions can be taken. This is what when you do FEMA in your real practice, make sure the actions are very realistic. Unlike conventional FEMA, the failure modes are isolated by stressing the process in a way that can be done during actual emergency. So we created an emergency to understand the failures. When failure modes usually result in creative workarounds to address the problem of the moment rather than deliberate system improvement. As I said, we changed the failure risk priority number from 1364 to 316. What we found really after this is staff confidence increases because now they know they have done something scientifically, by using scientific tools, a sense of urgency and team coordination improved. So this was the outcome of the project, and obviously we reduced our risk, and these are some of the references.
Yes.
Yeah, I finished.
Oh, wow.
Yes.
Wonderful. Any questions from the audience? Actually, I'm asking, who is the team leader usually?
In hospital setting, it will be your anesthesiologist. He will be the team leader, yes. And in case your anesthesiologist is not there, then your emergency physician will be the one. But since this was an outpatient setting, we did not have anesthesiologist 24 hours. So we preferred a cardiologist. We put him as a team leader. Yes.
You earlier mentioned that you have delay in finding the team in the outpatient. But actually, in the outpatient, we can have still the full setup because if we have the nurses, they can manage with the code until they receive the physician or the leader who can carry over. Because you say it's mostly the most important critical time.
Yes. Yes.
First 5 to 10 minutes. And also in some hospitals, like for example, SKMC, every day they're assigning a specific physician. He might be from the ICU, internal medicine, from the ER. They will be assigned, and he will receive an email that you are the team code blue team leader.
Yes.
In case there is any code blue in this specific day based on your schedule. So I think if you implement something like that, it would be very helpful.
I understand. Yes.
Because always the problem about code blue is who should do what.
We did not stop them from starting the CPR.
Yeah.
Anyone can. Our focus was how they come to
going back to the basic life support. I think every outpatient should.
Oh, definitely.
Yeah.
Definitely. Yes.
Thank you, Dr.
Thank you so
Saskia.
much. Thank you.
Thank you, Dr. Nazia. One more question?
Yeah. While seeing this RPM standard, it was reached to 300. So what exactly the area of improvement we are looking forward? While seeing this risk category still, it is in 300, right?
See, risk cannot be zero, right? You all are aware, right?
Yeah.
So our focus was detectability, right? We could now detect the areas and occurrence. Severity will not change. Mostly, we were not aware of process. For example, we put this announcement test book. So, it was one of the best things to do. Now we know all the areas. We are testing the mics. Anything? Yes.
In your study says that 68% of the predicted.
Yes.
How many real arrest? We also do have the same thing in our facility. Most of them are like a dissonance or single or always like that. Out of the 68, how many were the real cardiac arrest?
Oh, very good. I knew somebody will ask me. That's why I put the full link here. They were the real arrest. That is why I mentioned there were 72% patients per month. You can go through this. Please take a picture of it and go through this study. Yes, it was a rare cardiac arrest. And I understand your point very well. The fake code blues, right? We also have a project on fake. In settings, I would advise where you don't have a hospital backup, please use even fake code blues. Go for it. Take it as a real call. Yes, 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 definitely. We also have RRT in our hospital, but outpatient, yes, we should consider it. Definitely. Thank you so much.
Very great points.
Very yes.
Yeah.
RRT.
Have to anticipate who will go first, right?
But is it possible to have RRT in outpatient setting also?
Yes.
Good one.
And observe
Can
if
you
someone had
please reiterate what is FEMA?
she becomes hypertensive or drowsy, she has to, actually we train.
Can continue this conversation later. Any sort of time. So thank you
Thank you so
for
much. Thank you so
a
much.
wonderful contribution. Yeah, I can see.
Thank you so much.
Thank you so much.
Thank you so much.
So our next speaker, there are 3 speakers, and it's a poster presentation. It is on the top, a study to assess the effectiveness of communication framework and positive work culture in enhancing patient experience. Please join me in welcoming Ms. Liji Ranjit, Ms. Nisha Paul, and Ms. Sinimol Thomas from UAE.
Hi. Good afternoon, all. Thank you for having me here. My study also little bit different than previous presenters. And I would like to congratulate my previous presenter. That is an FMEA project. It was an extraordinary project. So I taken some few learnings from you. Thank you. So our presentation, first of all, I would like to introduce myself. My name is Liji Ranjit, Nursing Director, NMC Specialty Hospital, Abu Dhabi. And we have accompanied by my esteemed colleague and Assistant Director of Nursing, Ms. Nisha, and Nursing Educator, Ms. Sini. And let's see my study. My study is related to the effectiveness of communication framework and positive work culture for enhancing the patient experience in NMC Specialty Hospital, Abu Dhabi, UAE. Okay. While seeing the framework, I would like to explain about the importance of communication framework. The communication framework in NMC Specialty, I would like to highlight about my organization. The organization is started 1975. This established organization having almost 180 doctors, 35 specialties, and moreover 400 nursing staff. This study, we have taken it in a consideration of this dynamic and competitive healthcare system. While standing as a healthcare professional, we all are taking the priority for the patient satisfaction and patient experience. That is our primary element. While looking into that, we taken an important element, that is communication framework and positive work culture importance to enhance our patient experience. My study includes the introduction, that is aided, communication framework and the background, objective, methodology, results, and conclusion, and the discussion. The whole study we have taken into 3 so that all my team members can able to present. So while we are looking into the current healthcare system, we have seen a major role is the patient experience. So what we can do to improve our patient experience, that is the thought, the brainstorming when we started this study. So we taken aided. So anyone can say that aided, who brought the aided? Who identified this aided? When it is aided, it came to a picture. All the healthcare system is always talking about the communication framework. This is identified by a study team, students in 1990. But now you can see any healthcare industry now following this aided communication domain. So I would like to highlight what is aided. Aided is a communication framework that has been used by healthcare professionals to communicate with the patient and also to each other to enhance the patient and patient outcome. So we can see the aided is an acronym. We can see in that slide. It's an acknowledgement, introduce, duration, explanation, and thank you. So I would like to correlate why aided, why it is necessary in every hospital system, how it will enhance our work culture and also a positive practice environment. We are into the process of an ANCC Pathway of Excellence enrollment. We have completed the enrollment last month and we are looking forward to the next year, that is with an accreditation. So we have bringing all the elements, including the shared decision-making, well-being, quality, safety standards to the system so that the communication framework we can enhance. And while looking why aided, it is correlated with the work culture. Generally, when we talk about it, all will say it is not necessary. No, it is really necessary. A work culture is always related with a communication framework. As a manager, as a healthcare worker, we have to see what is the concept and how it will be relating the patient and the staff, including the attitude, belief, and the perception, and how organization is helping the team while following the principles and practices. This will help to enhance the transparency and well-being of the team members. Now, the positive practice environment. The positive practice environment, we will always see and saying it is there in the system. But we can see there are a lot of improvement. It's necessary while seeing to one-to-one facility. That the improvement methodology we are looking in while seeing this study. While the positive practice environment, we have only focused upon the rapport between the professional and the patient. This will enhance the trust for the patient and also for the employee. With the enrollment of ANCC Pathway of Excellence, we have brought few elements to our system to enhance this practice environment. The first one is that active listening and increased town hall meetings. This will help us to get an employee feedback, and that feedback, how we can rectify. In that way, we can help that employee being heard and respected. This helps a lot of improvement, and we got a lot of shared decision-making ideas and policy revision. And the second part is then supportive leadership. The supportive leadership is always helpful while doing a resource management and reducing the burnout in the system. And the most important thing that we all are missing, that is the recognition and reward. The recognition, we are talking about the international recognition, that is the DAISY recognition program and employee recognition program by HR. We will talk about only one element, but for an hospital or for an healthcare system, this will boost the employee confidence and the retention strategy also it will help out. And the next point is work-life balance. That is a primary element for the well-being activity. The work-life balance, that initiative we done it, that is the flexibility terms of duties and well-being club. The well-being club, we have activated multiple activities so that the work-life balance versus the conflict we are able to manage. Then the team collaboration. I think all the team members talk about the importance of multidisciplinary team approach. That is very evident, and that is also necessary for the regulatory body of UAE from recent years. For that, we helped with this team collaboration to reduce the likelihood errors and enhance our near miss reporting. And the continuous improvement and learning. In that, I would like to say about our few initiative, that is the Journal Club, and we have talked about a multiple QI project. This study, it's also related the learning lessons that we have identified from the team members. So, and also while seeing the continuous learning importance, when we are doing the workshop and CNE, we have to ensure our team members up-to-date knowledge and integration of the new technology to the system. Then the diversity. We have been working in this country. In this many years, we are seeing multiple nationality in the system. How we will ensure equal opportunity for all the nationals? That we will take into the priority so that we can get the respect and the patient care with an effective manner. So my background history about this study, we talk about it aided. The communication framework is my primary element, and the work culture and the positive practice environment. I have already explained about it. And the very important thing, the actionable feedback. I'm really happy to be talk about the actionable feedback. We are all know about how important is the patient feedback system. In our organization, as an NMC Healthcare, we have implemented Press-Gani as a patient feedback system. When we see our study, we have seen that the most of the patient feedback related, it's required an action because it was a negative feedback. So pertaining to that, we have implemented our study aided system into the organization. So I would like to explain aided communication tool. Aided, you can see on the slide, A means acknowledge. That means the staff is maintaining only 3 elements, that greeting, eye contact, and smile. You can see this is very small gesture, but it is a very difficult part, and we don't have a benchmark of this standard, and we are still working on it. And the staff introduce themselves with their role, and it will create a trust and clarity between the team. And the duration that will increase that point of an enhancement, and the time frame of interaction and explanation, the purpose of the treatment and the care that we are explaining to the patient for increasing the transparency. And the last one, the least, it is a thank you, but this is a very important section. This will create a positive sense of action, and a positive gratitude will keep this only the element we can enhance the patient experience in our system. So these are some observation tool we have implemented in our organization to monitor the communication framework. So we can see few because of the time limit. I am just moving faster. So the acknowledgement, we can see we are focusing upon primarily the grooming, the greeting standard, the positive body language, active listening, and caring. How is the confidentiality we are maintaining? How is the staff safety standard that is related to the hand hygiene? These all are the one we are looked in the acknowledgement. In introduce, the staff has to be introduce themselves before or after the interaction, and staff has to show the confidence in each care process. And duration, I explained, we are explaining the time frame in each care. In explanation, this are the elements also we have still working on it. This one, staff is explaining about the reason and the purpose of the individual care, and also showing the empathy. And here, the very important point, the staff has to create a trust, and the standard of nursing education has to be maintained with an evidence-based practice. The last one is thank you. So these all are the 5 elements of aided. So moving forward with our study, the next study is related to objectives. So Ms. Nisha, Assistant Director of Nursing, will take over. Thank you.
Thank you, Ms. Liji, for the detailed explanation about the study, basically about the background as well as the introduction. So as we are all have seen that NMC Specialty Hospital, Abu Dhabi emphasized on strong culture of safety within our organization. So with this aim, we move forward for the objectives for this study. First one is to assess the effectiveness of aided tool in improving the patient care, understanding the employee feedback on organizational work culture. And the third one is effectiveness of communication framework and positive work culture in improving or enhancing the patient experience. So these were the objectives which we have selected based on the background of the study. So the methodology which we have formulated was at the NMC Specialty Hospital, Abu Dhabi, we have conducted at the implementation, prior to the implementation of the aided tool, we have conducted a retrospective study that is from the period of April 2022 to September 2022. And we have analyzed that there is some requirement of an action to be taken in relation to the patient's feedback which we have received. So we have formulated and introduced the aided tool. And then followingly, simultaneously, we also have conducted a survey that was a prospective survey among the nurses to understand the work culture, how the work culture has enhanced for the patient experience at that particular point of time. And moving forward, then we have this, the study design is a descriptive study design, and we have included, as I mentioned, the study period is from April 2022 to March 2024. And the sample was the total number of actionable feedback which requires an action to be taken. So that we have conducted a convenient sampling at that particular point of time, and we have come to the results. So moving on to the results, I would like to invite Ms. Sinimol Thomas, the co-investigator, for continuing with the results. Thank you.
Good evening, all of you. Thank you, Ms. Nisha. So I'll be continuing with our results of the study. As my co-investigators are discussed, I'll be explaining the results based upon the objectives. So we have implemented this aided communication framework in the month of October 2022. So the number of actionable feedbacks. Actionable feedback means the patient feedback wherein we have to do an immediate intervention to solve it. So we have found that the number of actionable feedback during the previous period, that is 6 months prior to this, it was quite high. So we have to take some intervention in order to reduce that. So as we have analyzed the data from April 2022 to September 2022, and we have received around 28 actionable feedbacks. So we have analyzed those feedback, and we found that some area wherein we are lacking, it is like the patients were telling that the staffs are not listening. Okay, the staffs are not responding. The staffs are not explaining them about the procedures. So we have identified there is a gap in the communication between the patient, between the staff and the patient, and we have implemented this aided communication framework to improve that. After the implementation of the aided, as Ms. Nisha was explained, we have analyzed the data in 3 phases, which includes a 6 month of duration each phase. So the phase 1 included from October 2022 to March 2023, and the next phase included from April 2023 to September 2023, and the last phase, the third phase, is from October 2023 to March 2024. So here we can see that, as we can see in this graph, yeah, we have compared the pre-aided implementation phase patient actionable feedback, and here we have found after the implementation of aided a 58% reduction of the actionable feedback. Or other words, we can say that there was an improvement in the patient experience or patient satisfaction. In the phase 2, there was a 64% reduction, and in 75% in phase 3, 75% reduction in the actionable feedback. So from this data itself, it is very clear that the aided communication framework is having a very significant impact in improving the patient satisfaction, or we can say that there is an improvement in the patient experience. So simultaneously, we have done an employee organizational work culture survey among the nurses. You know that how the employee feel or how the employees are motivated, how they are engaged in the organization, that itself is having a role in their interaction with the patients. That is how they will communicate with the patient. So the survey result also, it is the main aspects include like the speak up. They are motivated to speak about or report any kind of safety events or incidents, or the 1:1 feedback between the nurses and the line managers, and the awards and appreciation, how they are appreciated about the work which they are doing. So 80% of our nurses have participated in the survey, and this is the survey result in brief. Here we can see that I think about the company vision and mission in all that I do. More than 90% of the staff strongly agree with that. Yes, they do. I feel appreciated in my team and in the organization. More than 90% of the staff again agreed on that. I deeply connected to the work I do. Around 98% of the staff strongly agreed on that. I feel appreciated for my contribution at work. Here we found a slight decline in the agree part. So further to this study, actually we have implemented our DAISY, as Ms. Liji had told, international award system like DAISY awards, HR recognition in every quarter, thank you card for the nurses, and on the spot recognition for the good work which they are doing. And people of all cultures and the backgrounds are valued here. More than 90% of the staff again agreed for that. I leave work with a sense of achievement on most of the days. Again, 90%. When I speak up, my opinion is valued. Again, the staff agreed. I have a concern about discrimination and I know where and how to report those concerns. We do have in our facility, we do have a very good system of reporting incidents and reporting to the ethics. We do have a very established system across the NMC healthcare. So all the staffs are aware about it. They know how to do that. My manager provides me a timely feedback about my work. So in our hospital, we do have an open door policy and all the line managers are giving a one-to-one feedback to all our nurses within the time frame wherein the feedback has to be given. Either it is a positive feedback or negative feedback in a constructive way. We are giving it to the staff so that we can improve the productivity. My organization always considers the needs and safety of the patients first. Of course, here we can see that 97% of our staff agrees with that. That implies that in our organization, we do have a very good safety culture. It is in place already. So in relation to the aided parameters, as the previous speakers are already told, there are 5 parameters. So even there was a reduction in the actionable feedback, still there are some areas for improvement we have identified. So those feedbacks we have compared and we have analyzed with these different aided parameters in which area they are lacking. Here you can see that after the phase 2 implementation, these are the different phases. Phase 1, phase 2 and phase 3. So in different phases of aided implementation, after the phase 2, we have analyzed, we do have a monthly evaluation of this aided checklist for all the nursing staff. So we have analyzed those data and in the phase 2, we have identified in the acknowledged part and the explanation part, those are the areas which is lacking compared to the other parameters. So what we have done is that we have done a reorientation, retraining and continuous monitoring for the nursing staff, especially in those areas. And here you can see that even in the phase 3, you can see an increase even in those areas as well. So it is not yet, it is still an ongoing process. Okay, so we are still monitoring the actionable feedback. We are still monitoring the aided. We know still for us also there are areas of improvement. But of course, from this result, we can conclude that the implementation of this aided communication framework, we had a notable reduction in the actionable feedback. In the other way, we can say that wherein an improvement is required related to the nursing services, which is in align with the existing literatures, whatever it is available. So the results of the organizational work culture survey indicate that the employees exhibit contentment with the organization, which enhances, of course, the patient satisfaction. And in other words, we can say that the patient experience is improved. So the integration of this effective communication and interpersonal skill is integral to the provision of patient-centered care, ultimately contributing to the enhancement of patient satisfaction. And findings implies that they consistently improve the patient satisfaction. And in our facility, we found it is very effective. So if any one of you feels that it is, you can implement it in your facility. So we can promise that it is, we strongly suggest it. Of course, it will improve the patient satisfaction or patient experience. Okay, so that's about our study. Thank you very much.
Really impressive how you 3 covered within time.
Thank you.
Thank you so much. Can I ask a question? Questions? Later. Okay, later.
Yeah.
Can I ask Ms. Liji, Miss Nisha, and We're short of time, that's right. Okay, so our next speaker and our last speaker, before that, I want to do an announcement. We have certificates there. So please, after this presentation, we'll be distributing the certificates and we'll be, please join us for a photo session as well. So we'll see you here just after the presentation. Okay. So our next speaker is Mr. Anwar Khan from USA, and he'll be delivering the presentation on AI, not a substitute for clinical care. Interesting topic.
And I promise I will.
Yeah, engineering industry.
Incident, huh? There we go. Okay.
I see. Okay.
Okay, good afternoon, everybody. How are you? So I know we're at the end of the day and I'm between us and the networking session, so I will try to keep this brief. I know you already had a couple of other discussions on AI today, but I wanted to start off by maybe having a little bit of a survey. But before I do, quick introduction about myself. My name is Anwar Khan. I'm a partner in KPMG. I'm also the Global Healthcare Technology Leader. What does that mean? I'm not a clinician. I'm a technologist, but I really leverage technology to enable better healthcare. But with that, I wanted to start out with a quick survey. How many people today use AI in any form, whether analytics for patient care, process automation, financial analysis? Not yet. Okay. For those that do use it, how many actually trust the results 100% blindly?
Oh, you
Any area. Yeah.
Do I trust it?
Yes.
No, you have to be, well, with the way I use it, you have to be the expert, right? You have to be the expert because when I use, so if I throw one out there, I use ChatGPT on, right?
Okay.
But because I'm the expert in emergency medicine, I know when I get something wrong and I get wrong information from Chat. And then I'll have a conversation and say, no, and here's why. If you're not good on those prompts, if you're not good at speaking that language, you can really get something messed up. So you still have to be that expert and garbage in, garbage out.
Yes.
Earlier I gave example about the ECG machine. We know that the ECG will give you the strip of the ECG that will be. Then there is interpretation already on the top, but I never go for that.
Because detailed interpretation on easy. No, sometimes it's telling you that it's the elevation, maybe acute myocardial infarction. So many data is there. We never go for. AI, right?
Yeah, no, that's a good point. And so that was the last point, is it trusted? What are the standards around it? So it's good to give you some ideas, but you, as an expert, as a clinician, can never, AI cannot be a substitute for your experience, your insight, and your instinct, right? To be able to interpret it. So the premise of the talk is really talking about, right? AI is a tool. How do you use it as a guide or an enhancer or an enabler? Absolutely not a substitute. So I'm going to skip ahead a couple of slides. So the first thing is that, as somebody just said, garbage in or garbage out. So data is the hallmark of being able to be after AI, right? All AI really is today, it's a harmonization of all information that's out there publicly available. It coalesces it, it synthesizes it, harmonizes it, and it comes up with certain informations. But it's really about the interoperability and how do you actually track the lineage of the data to make it the AI more and more powerful as you train the models, as you refine the output, and as you develop trust. So here we have the patient in the center, and what AI is really aiming to do today is to pull all of the information across your entire experience. So you coming into the hospital, you being discharged, your insurance if it's applicable depending on where you live, being able to see what happens to you from a home health perspective, a telehealth perspective, a mobile perspective, and more importantly, all the communication as well as the data around your community. What did you get your meds from the pharmacy? Where did you get your groceries? What is your lifestyle? Do you go to the gym? Pulling in all that information, being able to curate it, helps define the behavior, socioeconomic impact, environmental impact, and of course, ultimately the healthcare outcome. So as we do that, it's very important, I'll say this a couple of times, it's the trust in the data. How do you establish that trust? How do you refine that trust over and over and over again? So again, now that goes through the effective data governance. So data governance, and I think you already said this, so I love the fact you said garbage in, garbage out, which it is. So that's a term that's been used for the last like 20 years, and it's still there. So what we are trying to do in the industry to help shape it is to define the regulation around it, define standards around it, not just the privacy and the security standards or the personalization standards, but really how do you actually create the data, how do you access it, and how do you apply it, and how are you going to govern it, and ultimately be able to develop it in a trusted enabled tool. So there are four main areas around this, right? The first is looking at the efficiency of the data. How do you collect the documentation? How do you structure it or destructure it? How do you actually take unstructured information and put it into an effective and agreed upon data model? And understand how coding works, building works, etc. Second, the quality. That's the second part. How do we actually take the data and make it quality control? Who's checking the data, to your point earlier, right? Do you have the clinician? Do you have the financial analyst? Do you have the administrator checking that data, verifying that data, and having the right controls around it? From a clinical perspective, again, that's the key here, right? Is the data true? Is it trusted? Is it clinically effective and applicable? Moving to personalization, how do you actually make that information specific to that individual? There's so much information out there. It's data overload, and you have to be able to democratize that data and make it in digestible chunks that's applicable to the patient, or the administrator, or the family member, or the care delivery physician. Insights. How do you actually drive insights that are meaningful and applicable and actually meaningful to basically able to create a better action? And that's ultimately the goal of AI. How do we actually create better actions, better outcomes, better results, better communication, better facilitation? But we're not there. We're getting there, but we're not there. So I'm going to skip through the examples, not because I don't want to go through them, but just because of the interest of time. But as you can see, we've used AI in virtual assistants. We've used it in medical report generation. We've used it in health education and training, patient education and engagement, and of course, and ultimately personalized medicine. The overall goal of this is to create the better experience. And I know a lot of us here today, we're talking about the patient experience, right? But how can you use AI, data, and analytics to actually improve the patient experience and make it more personalized? How do you actually take genomic information and commingle it with the phenotypic data as well as the clinical data? How do you take molecular information and lifestyle information and aggregate it to actually create a true patient profile so you can actually deliver a personalized care protocol or a treatment regimen to that individual to ensure that the outcomes are better, but also be more preventative. So I will sort of end with this around what we have developed at KPMG, and this is a consulting model. It's a framework that we found very effective, and it continues to refine, so it's a living, breathing thing. We continue to refine it as we talk with clinicians, administrators, so forth in the field. But really just looking at, what we're calling the trusted ethical framework around AI. And again, it's making it fairness, getting rid of biases, being able to have the explainability and the traceability of where the information came from. If I were to unpack the model or as to impact the AI, code, how do you explain it? How do you trace it back? And what's the lineage of it? Accountability. Who's responsible for it? Who oversaw it? Who defined it? What are the standards around it? The security around it. Risk-based, security architecture, privacy concerns as well. The safety around it, the data integrity, and ultimately the reliability. But as AI continues to be a pervasive tool in the industry, commingled with analytics and other type of neural technologies and microtechnologies, how do you actually take that and actually develop it? And all of these standards and all of these frameworks around it have to be applied on it in order to make people believe in it and to be able to use it in a trusted fashion. So I'll end this and I'll open it up to questions. And again, I'm trying to be respectful because I know we're behind schedule. But really 5 guiding pillars. Transforming the workplace. So again, we talked about the impact of AI. AI is going to change the workforce. Not necessarily for the bad, worse, but it's about how do you take the workforce and train them, elevate them. How do you take people doing routine tasks and allow them to do more value-added and strategic tasks? Second, establishing the oversight and governance we talked about. It's developing standards. Myself and my colleagues are working with standard bodies out there. There's CHAI, which is again the Coalition for Healthcare AI. There's other standard bodies that are being developed in order to actually put the right governance around the AI models. Aligning cybersecurity with it, we're developing security architectures, not only for the privacy, but also being able to log in, use it, especially from mobile devices. Also, you're using it to pull data from wearables, making sure that that information does not leak out into the public domain, but really kept in a very contained structure. And then mitigating biases, again, like we talked about, right? It's important to mitigate biases, having the human in the loop, and then ultimately going to increasing transparency, because it is about transparency, but it's digestible chunks and it has to be able to be spelled out. So those are my key points. I apologize for rushing through the examples. I usually do this in a lot longer and elaborate fashion, but I wanted to just open up the questions given that we're a small group. So questions on AI, how you're using it, and the ethical use of AI. Any questions?
So the floor is open for the questions.
It's late in the day. I get it.
I think you explained really well then.
Very fast, thank you.
Thank you so much. Okay.
Okay, we'll take it when it comes. We can break.
So anyway, they have to distribute others in
Perfect.
certificates as well. So can we have the certificates now that we have? We have to present certificates right now. Okay. So meanwhile, our photographer is coming. Let's do a meditation. You are all tired. Let's relax a bit. Not music, just breathing meditation. Sound. Yeah. Sound healing. Yeah. 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 Do you have a meditation? Huh. Let's relax. We don't mind that even. So, you can come here. It's fine. You have so many healers today, right?